லைவ் வந்துச்சா? லைவ் பண்ண சொல்லிடுங்க. எனக்கு ஆக்சஸ் கொடுங்க கொஞ்சம் ஸ்லைட் ஷேர் பண்ணு. Towards classes. Niveta PA. Niveta PA. Submit. Yeah. Akka. It's better. Banner over those. Somebody using mute. You're using mute.
Good morning, everyone. The conference will be starting in few minutes. Thank you for your patience. Hello, good morning.
Good morning, ma'am.
Good morning, everyone.
Ask her to talk again. Good morning. Niveta, it's
Good
audible.
morning, everyone.
Hello, good morning.
Good morning. It's audible, Niveta. You can start this.
A very good morning to one and all present here. I welcome you all to the virtual 7th International Conference on Nursing Science and Health on February 15th, 16, 2024, organized by BioLeaks, Scientific Partner, Society for Nursing Practices, and United Innovators, our research partner. BioLeaks is a not-for-profit professional association which prominently promotes research and development. We at BioLeaks have brought a revolution in the field of worldwide conferences. The conferences organized by BioLeaks brings together the professional wizards and leaders who have explored all avenues in the field of life sciences, medicine, and technology. BioLeaks conducts events worldwide which help in enhancing the skill set of the people from diverse industries and forms a common platform for eminent personalities, physicians, researchers, doctors, and academicians, professionals, business figures, and much more. BioLeaks conferences encourages better comprehension about improvements and progressions over the world. We work with our motto of creating a better tomorrow by organizing conferences and creating a network which will help grow a better tomorrow with the help of advanced technology and achieve. 7th International Conference on Nursing Science and Healthcare. The great enthusiasm, the Society for Nursing Practices, building on the accomplishments of our prior 6 editions of this nursing conference, SFNP remains dedicated to advancing the elements of nursing science and healthcare. The conference will accentuate the groundbreaking spirit of enriching the nursing profession. The nursing conference presents the most innovative studies and research in the industry to give researchers, medical professionals, and academicians the most recent and cutting edge evidence for optimum healthcare practices and safety. It gives me immense pleasure to introduce our honorable dignitaries. Mr. Raghavendran, Principal, College of Nursing, Cuttack, India. Dr. Virendra Singh Chaudhary, Professor and Head, SN College of Nursing, India. With much pride, I would like to welcome all keynote speakers for today. Mr. Andrew Dermott, Chief Nursing Officer, Peter MacCallum Center, Australia. Professor Dr. Jeffrey A. Lucero, Professional Lecturer, Far Eastern University, Philippines. Professor Veena Sharma, Principal and Professor, Rafida College of Nursing, Jamia Hamad, deemed to be University, India. Professor Dr. Chong Mei Chan, Associate Professor, Department of Nursing Science, University of Malaya, Malaysia. Ms. Farhana Tabassum Siddiq, Director of Undergraduate Programs, Ziauddin University, College of Nursing, Pakistan. Mr. Abdullah Ali Nihla, Chief of Nursing Affairs, Eastern Health Cluster, Brand Ambassador, Nurses for Future Project, Saudi Arabia. I would also like to welcome and introduce our session chairs for today. Dr. Virendra Singh Chaudhary, Professor and Head, SN College of Nursing, India. Dr. Arul Balan P, Professor, Dr. Kumaraswamy Health Center, College of Nursing, India. Ms. Suchanda Bhattacharya, Tutor, Assistant Professor, Jamia Hamdard, India. I would like to welcome all the participants and we are looking forward to your active participation. I would like to thank each and every one of you who have gathered here. Now, I kindly request Mr. Raghavendran, Principal, College of Nursing, Cuttack, India, to welcome the gathering. Sir, please.
Thank you, Ms. Nivedita.
Sir.
I think you can hear my voice. And my video is stopped over by you, by the host.
Hello, sir. Good morning.
Good morning. Can you hear my voice?
We can't able to hear you, sir.
Hello? Ma'am, can you hear my voice? Hello? Can you hear my voice?
Yeah, audible, sir, audible.
Okay. Thank you, sir. Take a first step in faith. You don't have to see the whole staircase, just take the first step, which was given. These are the quote given by Martin Luther King. With this quote, I want to start my welcome speech. A very hearty morning to everyone joining us today. I assure you that this conference will prove to be fruitful and informative for all the members participating in the conference. It is my pleasure to welcome you all to our conference. I am grateful for all the speakers who have joined us today to share their knowledge and experiences with us. Myself, Dr. M. Raghavendran, and I am extremely overwhelmed to have this opportunity to address you all at this conference. I am sure this conference will truly explore the diverse spirit and will be an immense success. It always been a great medium to include people from all the departments, and this inclusion increases the mutual respect among the people. It will also a great way to grab opportunities since it is a great platform to share our experiences and wisdoms with people that can be inspiring. Before beginning, I would like to thank all the dignitaries joining us, and we are all the grateful that you all have taken out time from your busy schedules to help us understand the working and the qualities of this firm. And it would be my honor to introduce you all to our national annual seventh international conference. We have tried to keep this conference as interactive as possible. Therefore, all the participants can free to ask the legible and relatable questions. Just, I want to talk about SFMP, the Society for Nurses Practice. It is one of the leading professional association caring for the people. It is an international forum for nurses, academicians, nurse researchers, and nurse administrators for sharing their knowledge and innovation in the field of nursing science and health. SFMP aims to bring together nurses to encourage the intellectual development and providing opportunities for networking and collaboration. So before uh, the theme of this conference is Elevate, Educate, Empower, the nursing journey. And the theme signifies a focus on uplifting the nursing profession, promoting education, and empowering the nurses. So, encapsulating the essence of the event. It encapsulates also the essence of nursing and emphasizes the continuous process of growth, learning, and empowerment that the nurses experience throughout their lives. I strongly feel that acting collectively is the need of the hour and uniting our youth for the common cause can work wonders. So it's my most sincere hope that owing to our relentless endeavors, this conference will help our youth to take strong resolutions on how they can move closer towards the attainment of their goals. Thank you all for being a part of this conference for us, and I wish you all the happy learning experience. Thank you.
Thank you, sir. Now, I request Dr. Virendra Singh Chaudhary, Professor and Head, SN College of Nursing, India, to welcome the gathering. Sir, please.
Thank you very much, ma'am. Welcome, everyone. And before starting off my welcome speech, I would like to be quote my speech with the words, as anyone who stop learning is old, whether at the 20 or 80s. Anyone who keep learning, stay young. So in virtue of that, we are, as a nurse, we know that the learning is throughout the process, lifelong process, and in which the SFNP, that is the Society for Nursing Practices, is taking the responsibility for the all the professions to be professionals should be young throughout their life through the learnings. So thanks for joining us today in the 7th International Conference on the Nursing Science and the Healthcare. We are excited to have you all at today's conference, and this will be a big opportunity for all of us to be learn from each other and grow together. As Dr. Raghavendra already say, that learning through which this platform that is provided by the SFNP for us will take get together from the worldwide participants, speakers, and through their knowledge, it will help us to enhance the knowledge of nurses, knowledge of the associate professionals, paramedics, medics, and other information or technological lines. As we know, the theme of this conference was very suit for that in the present scenario that elevate, educate, and empower the nursing generally. As the nursing is the heart of the healthcare sectors, and you can enhance the quality through the regular learnings. And for continuation of that, this society, or that is our FSNP, organize this conference to take all the participants throughout the world, the experts from the throughout the world under a one umbrella. So it's a big opportunity and privilege for me to welcome my all the participants, our keynote speakers who are attached with us from all of the countries, as the madam has already introduced our experts. And it's privilege for me to welcome all these keynote speakers on this conference. And at the same time, because nothing will be possible or nothing will be succeed without the participants. So I welcome my all the participants who will be joining us through the virtual mode. And this is a big opportunity actually given or provided by the SFNP and the scientific partner of BioLegase, that through which we are going to be get together, because it is a difficult task in these days to get the time to move here and there. But this platform will give you opportunity for us. So I am thankful for the SFNP and the BioLegase to provide this opportunity for all of us, for our professionals to be enhance the quality of the professional. Thank you very much. Once again, welcome you all for this conference. Thank you very much.
Thank you, sir. Now, we'll move on to the keynote lectures we have been waiting for. Now, I would like to welcome our first keynote speaker of the day, Mr. Andrew Diamond, to render the lecture. Sir,
Can you hear me okay?
good morning, sir.
Good morning. Can you hear me?
Yes, sir.
Wonderful. Thank you very much. Are you able to share the presentation, please?
Sir, we have to share the presentation.
Yes, please. Have you got the presentation okay?
One second, sir. Let me.
Thank you. Apologies. Apologies for the delay. I'm just having a technical issue. Apologies there, everybody. Unfortunately, I'm unable to share my screen through the function.
Hello, sir. Actually, we have some problem with our end. Could you please share, sir?
I'm just trying to share. It's not enabling. One moment. I'm just trying to get some assistance.
Hello, sir.
Hi, sorry, it's not letting me share the
Can you hear
screen.
me, sir?
Yes, I can hear you.
Yes, sir. Actually, we have some problem with the end presenting the screen. Could you
That's
please
okay.
share the screen?
I'm just trying to come in. I'm just going to, one moment.
Okay.
Well, let me share screen. Oh, there.
Yes, sir. Thank you. We can able to see your slides, sir.
Wonderful. Can you see?
Yes, sir. We can.
Hello. Hello. Sorry.
Yes, sir.
Real apologies for the delay there.
It's okay, sir. Fine.
Thank you.
Thank you.
Okay. Thank you very much, Dr. Raghunavendran, Dr. Chowdhury, and Dr. Navita. I'm really pleased to be able to come to present to you today at the 7th International Conference on Nursing Science in Healthcare. My name is Andy Dimmick. I'm the Chief Nursing Officer at the Peter MacCallum Cancer Centre in Melbourne, Australia. Just very briefly about my background. I'm a cancer and an intensive care nurse, and I have worked in Australia, the United Kingdom, the Republic of Ireland, across the public and the private sector. So my background is predominantly intensive care nursing, focusing on patients with cancer. My roles have taken me through various different aspects of education, clinical leadership, and also clinical practice. So in particularly my role as a practicing nurse in the critical care setting, as a nurse practitioner and a clinical nurse specialist, and then worked into the leadership and now the chief nursing at Peter MacCallum's Cancer Centre. So very briefly, I'm sure you're all very, very well aware, we are located in Melbourne in the state of Victoria in Australia, and we are on the banks of the Yarra River and on the port of Melbourne. So just to give you an overview of the Peter MacCallum Cancer Centre. So the Peter MacCallum Cancer Centre is Australia's only public health service solely dedicated to caring for people affected by cancer. And we're Australia's leading cancer research, education and treatment centre. So you're ranked number 14 in the world's best specialised oncology hospitals. We have operations across 6 sites within the state of Victoria, and we provide care for patients who are undergoing treatment and diagnosis of all oncology cases. We treat annually approximately 42,000 patients, 46,000 inpatient separations, and we have 289,000 specialist appointments. In the top right-hand corner of your screen demonstrates where we are across the state. So our main hospital is in central Melbourne, where we have other campuses from Bendigo in our rural and regional area, Sunshine, Box Hill, and Moorabbin.
So your slides are not moving.
Sorry there?
So your slides are not
They're not
moving.
moving?
Hello, sir.
No.
Hi.
Hi, sir. Your slides are not moving, sir. Ah, now it's moving.
It's now
Yeah.
moving? Okay, apologies. So
Okay.
there we are. I'll use a different screen. So there's our slide there. Apologies there. So the Peter MacCallum Centre in the top right-hand corner, you see there is the site across the state. So we provide cancer radiation oncology treatment for the state of Victoria in the public setting. And also we are the primary site for pediatric cancer radiation therapy for the state of Victoria and Tasmania. So the focus today, I'm just going to talk about advanced practice nursing. So there are various definitions around advanced practice nursing. The definition I've used here today is around the International Council of Nurses. So as a registered nurse who has acquired through additional education, the expert knowledge base, complex decision-making skills, clinical competencies for expanded nursing practice, those of which are characterized and shaped by the context in which they are credentialed in practice. So it's important to note that in terms of the advanced practice nursing roles, it's really country and regional perspectives that need to be taken into consideration. So from the international context, in terms of advanced practice nursing roles, the 2 dominant roles are the clinical nurse specialist and the nurse practitioner. So for myself and my background practice, it was a nurse practitioner in the cancer critical care setting. So varies across the world. Early models for the clinical nurse specialist role was in the United Kingdom in the 1970s, and other areas around Canada, New Zealand, Ireland, Japan established in 1994, and there's various models in New Zealand and other parts around the world as well. So from a nurse practitioner perspective, again, varying different best practice models from Botswana, established in 1981, the UK in the 1990s, and some earlier models in, for example, is in Jamaica in 1977. So important that there is also a mixed model of the advanced practice nursing roles. So some countries or regions don't have a complete distinct CNS or an ANP or an NP role. For example, in Germany, due to the different federal state setup, there is a mixed model of nurse practitioner and clinical nurse specialist. Singapore with a hybrid model, and also with the Netherlands. In other areas, in particular in Australia, the clinical nurse specialist in many aspects is also potentially considered as a clinical nurse consultant, and that's very similar in terms of the Hong Kong model. So really briefly, just looking at the characteristics and really to determine the different... Is that okay still? Can you hear me okay?
Excuse me, sir, could you run the slideshow, please? It's very difficult for me to read. Sorry. Thank you.
Can you see that okay?
Yes, sir. We can see your slide.
Okay.
Could you please share it in slideshow mode, sir? Full screen mode?
It is on... it is on full slideshow mode.
Okay, sir. It's okay, fine. Can you just enlarge the size?
Let me have a look. Is that better?
Yes, sir. Fine, sir.
Apologies, for some reason it's not all connecting up.
It's
I've got
okay,
3
fine.
different screens not working properly. So the clinical nurse specialist education component, looking at the education, practice and regulatory. So from the education perspective, again, this is country or region specific. It's looking at those nurses with a master's degree training. Again, some countries or regions have a training package or a plan to work towards. There needs to be recognition of the educational programs at the state or the organizational level, and appropriate credentialing with the appropriate credentialing body. Key things for practice to pick out is around that designated role. So making sure the roles are appropriate for the nurse practitioner or the clinical nurse specialist. And which we'll touch base briefly on next is those key components of education, leadership, research, and clinical practice. Many of these roles hold extended autonomy, in particular advanced assessment skills, which many of those have an assessment component within the education pathway. There's also the assessment of the advanced clinical competencies and ensuring that there's a service provision for the right patient population. On a regulatory component, varying between country and region, there's the authority to diagnose, prescribe medication, order diagnostic tests, admit or discharge, and in particular, that will really vary. So in some areas of practice, the ability to prescribe a full range of the prescription range, and others a very targeted area of prescribing. So in the theme of the conference, just moving on to the next slide. Can you see that okay? So this is the professional practice model that we utilize in the Peter MacCallum Cancer Centre. So the professional practice model is a model of care that we, or a model of education that we use for our nursing teams. So building on the novice to expert in terms of the professional. You okay? Can you hear me okay still?
Yes, sir, you are audible.
Thank you. Thank you. So the novice to the expert, so through the different aspects of professional nursing practice. So again, looking at the 4 domains of research, leadership, education, and clinical practice. So in particular here is looking at how we're able to deliver, and just to focus on a cancer perspective, the world's best cancer care and discovery and translation. So the ability to involve new therapies, new treatments, and new regimes, and potentially new services that are nurse-led. So it's working in partnerships with our academic partners, so the universities, to be able to provide this ongoing education. And what we envisage is to have the elevate the nursing roles to be able to be a complete component of the multidisciplinary team, working alongside and within our medical and our allied health colleagues. Another component really of this is, again, that of course the patient and the carers and the community are at the center of all that we do. So the co-design of services, the co-design of pathways with our patients and carers is integral in how we develop and elevate the role of nursing practice in Australia, and particularly in the Peter MacCallum Cancer Centre. The next area is really looking at how we then educate our advanced practice nurses. So the key thing is engaging with our key stakeholders, particularly looking at the clinical teams. Where do we need to have an advanced practice role? And that's nurse-led. So working alongside our service to make sure that we're providing the best for the patient at the appropriate time. So working in collaboration with our medical and allied health colleagues, our key stakeholders, and the operations. The collaborative partners is our academic universities around that ongoing postgraduate, master's level, and then on to doctoral level training. From a clinical perspective, it's how we then place those particularly advanced practice roles in the specialist cancer roles. So for example, a breast cancer stream or a non-tumor stream, for example, in infection prevention. The education, as I said, is around also the individual's education, but it's the reverse. How does the nurse also, in an advanced practice role, educate others in the organization? So there's an expectation that the education goes both ways. From a leadership perspective, again, it's that contribution of the nurse at a senior level in the governance of the organization, but then also in the organization's operations. And finally, the research component. So undertaking their own research, being a PI on various studies, but also contributing to the multidisciplinary research agenda. In terms of empowering, it's our next component, and I've pulled 3 articles here just to really highlight some of the key things. So when you're looking at advanced practice roles, the first one is about barriers and facilitators to implementation of advanced nursing practice roles. So Torres et al. In 2019. So what they found that there's a diverse range of roles across, particularly in primary care. However, there's disagreement around the level of autonomy, and that really depends on the team of the nurse is working in, but also the setting. And those team factors are key in terms of what would be barriers and facilitators. The second, the impact of nurse practitioners in hospitalizations and discharges from long-term nursing care by Mileski et al. In 2020 was a systematic review, looked at the nurse practitioners in the primary care setting. And in this area, and this is a key thing for us in terms of taking nursing forward, is demonstrating the value and the contribution for advanced nursing practice. In this paper, they demonstrated that there was a reduction in unnecessary hospitalization, an increase in access to healthcare, and an increase in terms of, or improved outcomes for the patients. The third, in terms of empowering and demonstrating the worth and the value of the advanced nursing practice roles, is a paper by Tay and Whitehead in 2021, looking at the effectiveness of the role of advanced nursing practitioners compared to physician-led or usual care. Again, a systematic review undertaken with 13 randomized controlled trials. And what they found was there was various positive effects in all these particular studies around indigestion management, perception of health status, in terms of blood pressure control, and from a service perspective, patient satisfaction and decrease in waiting times. So in conclusion, the role of the advanced nursing practice is critical in a healthcare setting, and it's our ability as a healthcare team to ensure that we are able to develop those roles and make sure they are contributing to the appropriate components of the hospital. I'll pause there. Thank you very much.
Thank you, sir. Thank you so much for your wonderful keynote session. Next, participants, if you have any question, you can put it in chat box. Does anyone have any questions? Yes, sir. I think no one have any question.
No problems. Thank you very much.
Thank you, sir. Now, I request Professor Dr. Jeffrey A. Lucero to render the lecture. Sir. Sir, are you here? Okay.
I'd like to thank the organizers of this virtual conference for inviting me to be one of the keynote speakers in this momentous event. Indeed, it is an honor for me to share with you all this humble piece of work which has been a part of my advocacy in promoting awareness on HIV and AIDS, and subsequently eliminating HIV and AIDS-related stigma. I am Jeffrey Alcantara Lucero, a faculty member from Far Eastern University in the Philippines, and allow me to present my work entitled HIV and AIDS in the Academy, Teachers' Experience, Knowledge, and Attitude Towards the Disease. For the disclaimer, the information of view. None of these reflect any claim or opinion of the institution of my affiliation and other local or international agencies unless specified. HIV and AIDS are two different entities. HIV, or human immunodeficiency virus, is a virus that causes a deadly disease, which is called AIDS. The virus was first detected in the Philippines in 1984. Since then, the number of HIV infection among Filipinos continuously increases. At present, the total number of reported HIV cases in the country is almost 700,000, and the virus incessantly infects others, especially those in their productive age. A person infected with HIV or diagnosed with AIDS are acceptably called as people living with HIV or AIDS, or PLWH. We do not call them as HIV patients, victim, or whatnot. The area in the Philippines with the highest cases of HIV is the National Capital Region, also known as Metro Manila. Because of being adjacent to the area, the province of Cavite, which served as the main source of information in this work, ranks second to have the highest HIV cases. The major mode of transmission that lead to the exponential increase of HIV cases in the country include multiple usage of syringe by various individuals and male having unprotected sex with another male. Statistically, the people living with HIV in the Philippines generally rise from the 25 to 35 years old age. Such finding is alarming, since this age group generally refers to the productive group of the country, being the young professionals who contribute to the nation's economy. An unhealthy population in this cohort would potentially retard the economic growth of the country. Moreover, it was reported that overseas Filipino workers account for 30 to 35% of all cases in the country. In the province of Cavite, data show that call center agents comprise the most number of HIV cases. It is also noteworthy that even professionals in the healthcare field also acquire HIV infection due to varying reasons. Aside from health professionals, there are also teachers who were not exempted from being infected with HIV. In the province of Cavite alone, there are a number of teachers actively practicing the profession who are included in the HIV and AIDS registry of the country. The school or the academy is a place where young people gather to understand concepts in their environment. This happens through the aid of the teachers. Also, aside from being sources of knowledge, teachers serve as advocates of a healthy school environment and role models for their learners. Nevertheless, the school can be a source of stigma and discrimination if the teachers facilitating knowledge transfer among learners share false information because of misconceptions and or lack of awareness about a certain issue. Sadly, because of insufficient knowledge, teachers themselves stigmatize and discriminate vulnerable groups, which could have included the people living with HIV. With those facts mentioned, the ongoing presentation endeavors to present the results of my work on exploring the experiences of teachers living with HIV and AIDS. Also, it will be discussed in here the knowledge of teachers on HIV and AIDS and their attitude towards working with colleagues with HIV and AIDS. A qualitative study involving 4 teachers with HIV and AIDS from various school settings revealed that they experienced the following. Number 1 is stigma and discrimination. Second is somatic debilitation. And third is stress and depression. Being infected with HIV, the key informants have experienced stigma and discrimination, that is, feeling of being judged and rejected by the people around them. The key informants have also experienced somatic debilitation, which is being unwell and failing to perform some of their activities of daily living. Stress and depression has also been felt by the key informants upon learning that they are positive with HIV. They describe it as a feeling of sleepless night and too much sadness. Amid living with HIV and receiving treatments to suppress it, the key informants were asked how they perceive their lives in the future. Summarizing their diverse responses, it appeared that the key informants are concerned about their feelings on what their future would bring to them and their plans to live it. The key informants express their feelings on what their future would bring to them with HIV thriving within their system. According to them, looking at what would be ahead of them in their future with HIV is full of uncertainty and questions in mind. Nevertheless, the responses signified common themes which are generalized with the acronym AIDS, which means anxiety and worry to face tomorrow, intrepidity to surmount life's challenges, dependence to treatment, others, and God, and lastly, survival from a curse. When asked about their plans in the future in the midst of living with HIV, the key informants generally responded with a positive attitude. According to them, having acquired HIV crashed their being as a person, thinking of the mean judgment they might get from the people should they discover their condition. They also have this fear of becoming a burden to their family because of the debilitating effect of the deadly pathogen that invaded their system. Nevertheless, their unwavering hope that a cure will be discovered soon and the motivation given by their respective support groups keep their desire to live and continue fighting. According to them, they plan to do AIDS as they face what life brings to them as people living with HIV. AIDS in this context means advocacy for HIV and AIDS awareness, to remain in good shape, to be disclosed to the public, and to engage in safe sex practices. A quantitative study was then conducted to determine teachers' knowledge on HIV and AIDS and their attitude towards working with a colleague with HIV and AIDS. I believe that this would shed light on why teachers infected by the virus share common experiences, as stated earlier. Involving 300 teachers from various educational settings, results showed that they have low level of awareness on the mode of transmission of HIV. Also, they were found to have negative attitude towards working with a colleague with HIV. That means that they are not comfortable in dealing with these people due to various unspecified reasons. Knowledge on HIV and AIDS was found to be directly related to attitude towards dealing with colleagues with HIV. This means that the teacher's attitude towards people with HIV can be more positive if they are properly educated with HIV and AIDS, especially in its mode of transmission. In view of the conclusion found, the following are hereby recommended. There should be a more comprehensive health education and promotion program on HIV and AIDS. This should be developed for the general population. The program should aim at providing accurate information geared towards eliminating stigma and discrimination among people living with HIV so they can disclose themselves and seek treatment without fearing negative judgment and treatment from other people. Second, church and other professionals are encouraged to undergo HIV testing, especially if they engage themselves in risky sexual activities. Lastly, aside from HIV and AIDS, awareness on other sexually transmitted infections should also be conducted to prevent its transmission and encourage early seeking of treatment among affected individuals. Here are the references that I use in my work, and I would like to end my presentation by sharing this quote stated by Kael, a Filipino with HIV, when he was featured in a noontime show. HIV is not a disability. Yes, it can kill our immunity, but not our humanity. My friends, people living with HIV are still people. Hence, they deserve to be treated well and taken care of just like any of us people. And with that, I thank you all for listening.
Thank you, sir. Thank you so much for a wonderful keynote session. Next, I would request Professor Veena Sharma to render the lecture. Ma'am? Ma'am, are you here? Ma'am? Ma'am, are you here? Veena, ma'am? Hello, ma'am. Good morning. Veena, ma'am? Ma'am, can you able to hear me?
Hello.
Yes, ma'am. We can able to hear you now.
Okay, because we had some connectivity issue.
Okay, fine. No problem.
Are we ready then?
Yes, ma'am. We can
Okay.
able to see your slide, but not a presentation slide. Something
Okay.
Zoom.
Okay, we'll just get started. Just give me
Oh,
a moment.
no problem. Take your time.
Just a minute. Okay. Share screen.
Screen is not shared, ma'am. It went out.
We will just doing it. Give a moment.
Okay, sure.
Desktop in here. Desktop in here. Download. Doesn't want to break it. Yeah. I will just whatever. Sure. हाँ ये तो नहीं आपने डेस्कटॉप पे क्यों नहीं रखा इसको डाउनलोड में रखा था मैं क्यों डाउनलोड्स तो वहाँ है आपके sorry. अच्छा तुम ये कर लेते फिर मैम should I change the वहाँ से करेंगे do it whatever
Yes, ma'am, we can able to see a slide now.
this is should I say
Yeah, ma'am, we can able to see properly.
the slides are not moving now
The slides are not moving, ma'am.
moving
You can
is it
open that PPT in presentation.
presentation mode here
Yeah, presentation mode. It's opening now in Google Gmail only now.
should I give it to in download mode or anything
Have you downloaded the PPT, ma'am?
yeah download
Then it will be downloaded in documents, right? File
document
manager.
yes
Yeah. Go to
in
file.
desktop it is on desktop I will just
Yeah, desktop.
open on desktop
Yeah, sure.
desktop I will now it's okay
No, ma'am, we can't able to see a slide. It's just showing the Gmail.
yes I will share just screen share I will share the screen
Yeah,
and
just do.
then it's but
Is it not on your desktop?
yes ma'am
Are you
but I will
mistaken?
desktop I will not show the desktop it's very just a minute files I will go to the files it's just now just a minute
Okay.
oh, this is Microsoft opening I will just computer
किसी को आपको बुलाऊं?
मैं personally
Oh God, you sit here.
Hello, ma'am.
Yes, yes, tell me.
Yeah, ma'am. If you're facing any problem, you can just share the PPT with us.
I
We'll
will share
present.
you. I will share you. I will
Oh,
share you.
sure,
I
ma'am.
will
Do.
share it in
We'll
WhatsApp.
present. Since I was supposed to take signature from her and give it back
I
to
will
her.
share you. I will share you.
I
Just wait.
didn't enter her out. I gave to the secretary and I went. Now
I
she's
will
getting.
share you, ma'am. Just a minute. I will share you. PPT, I will share you.
Sure,
I
ma'am.
will.
Sure.
Just a minute. I will share you. I will share you in WhatsApp. You can open the PPT.
Mail, ma'am. Can you please share it in mail, please?
Your mail ID? SNF.
We'll send in WhatsApp.
In WhatsApp?
Yeah. In chat box also.
I will share you in WhatsApp. Okay, just a minute. Just a minute.
Oh.
I will share you in WhatsApp.
Yes, ma'am.
Yes, send.
I shared the mail ID in chat box, ma'am.
Yes, yes. You can open. You can open. Okay. You can
Okay.
open. Now you can open and show. You are sharing this. We are just. Now you can open.
One sec, ma'am. Have you shared in WhatsApp or Gmail, ma'am?
Is Sushmita? Sushmita is a WhatsApp. I will Gmail. I will Gmail you. Just a minute. I will Gmail you. What's your mail ID? Tell me.
I have texted in chat box, ma'am. Gmail chat.
You can tell me, please. You can tell me, please. SFNP.
One sec, ma'am. Nursing@biolix.com.
Nursing. Nursing.
At
nursing at
Biolix BIO.
Nursing dot है या at
Nursing at, not dot. Nursing at.
Just a minute. You can do the reached. It's reached. Now you got it.
One second. Let me check.
I will stop share here.
Yeah, do that, ma'am.
Okay, I will stop share here. Okay. Just you share the PPTs.
Yeah,
just
one second.
Just a second. Now madam is
Okay.
You can share.
So good morning, everyone. Can you hear me?
Good morning, ma'am. Yes, you are audible.
Yeah, thank you. Good morning, everyone, and greetings from Rufaidah College of Nursing. Rufaidah College of Nursing, Jamia Hamdard, New Delhi, India.
Thank you for that.
Ma'am, can you able to see the slide?
Yeah, I can see. Thank you. Sorry for the delay and for those glitches, which happen sometime with technology. In keeping with the theme of the conference.
Sorry to interrupt, ma'am.
Yeah.
Actually, your virtual background is different.
It's different?
Actually, Asia Pacific Congress.
Okay, you can remove me from there so that I can concentrate on the presentation.
Okay, ma'am. Go on.
Yeah. So, in keeping with the theme of the conference on Elevate, Educate, and Empower, I am going to talk about nurses leading the change and advancing health. Next, please. So nursing is an integral and major component of healthcare organization, and nurses are the largest workforce in any healthcare setting, and they are also the key person at the bedside and for the patient care. Next, please. And today's healthcare setting demand that not just nurses, but all healthcare professionals are flexible, creative, and they are able to empower others to be flexible and creative. And there have been a lot of challenges for the nurses when they are meeting the demands of the healthcare of the people, whether it is in terms of shortage of nurses, higher patient acuity, fewer resources to deal with, and very diverse demographics and influences of outside. Next, please. So in order to elevate, educate, and empower, we need to talk about the leadership. But while we talk about leadership, it is equally important to talk about the followership. So what is an effective leader without effective followers? So in order to have leaders, leaders also required followers. And followers also have to be equally effective as the leaders, which means that they need to know who to follow, when to follow, how to follow, and how to use the follower role most powerfully and effectively. Next, please. And leaders should follow 5 practices of leadership to realize their visions and become self-directed. That is, they have to challenge the status quo. They cannot continue with traditions forever. The leaders and followers both need to have a shared vision, and leaders have to enable the followers to act rather than to react. Leaders have to follow by example. They have to be a role model, and they have to manage risk. They have to communicate effectively, and they also need to develop trust, credibility, and respect in the organization. Next, please. So while there are very many theories on leadership, there are very few or no theories on followership, which is equally important as leadership. So leaders cannot be there unless there are followers. And effective followers are those who not just follow the rules, but they also question the rules at times. And they are equal partners with the leaders, which means they work collaboratively with the leaders, and the leaders also needs the followers. Next, please. Next, please. Now, nurse leaders are very important for quality initiatives and patient safety, and they use certain tools and techniques which are nurse sensitive, so that they can gauge the quality and patient safety measures that they are taking in their organization. Next, please. Some of the nurse sensitive indicators for quality and patient safety are patient falls, mortality, failure to rescue, medication errors, which is very common, and deep vein thrombosis and VAP. Next, please. So some leaders use unit-based report cards to share data regularly with their staff, and many of these report cards are produced monthly and contain data such as patient falls, medication errors, turnover and vacancy rates, staff satisfaction, patient satisfaction, financial indicators such as length of stay. And next, please. And all these indicators, for all these indicators, whenever there is an event or incident, root cause analysis, RCA, or root cause analysis has to be done by the nurse leaders. Next. Patient satisfaction is also important in today's healthcare scenario or climate. And that is an important measure for quality of nursing care, because patient care is the core of nursing profession. Next, please. And measures of patient satisfaction may include what are the perceptions of the patient, whether they are being cared for or not. Satisfaction with timeliness of responses of the nurses and doctors to the call bells, and also their need for pain medications. Reassurance and explanation given to family and friends about diagnostic and therapeutic procedures. And very important indicator for patient satisfaction is whether the patient wants to return to the hospital should there be any healthcare crisis, and whether he or she recommends the hospital to others. Next, please. And the patients as consumers have indicated that compassion, caring, and excellence are what makes a hospital the hospital of their choice. And as you all know, as we all know, that compassion, caring, and excellence are the core qualities of a nurse or nursing care. These are very important virtues in nursing and nursing profession: compassion, care, caring attitude, and excellence in patient care. So patient-centered care is something which involves respect for patient values, preferences, and expressed needs, care, coordination, and integration, education, information, and communication with the patients and family members, physical and emotional support, and involvement of family and friends, and transition and continuity of care even when the patient goes home. Next, please. So for patient satisfaction and gauging the nursing quality, there are various bodies like Joint Commission International, JCI. In India, we have NABH and NABL, and they do the accreditation, and they also do the quality checks in healthcare institutions. And they ensure that all healthcare institutions, they meet minimum standards of care. Next, please. And therefore, it is important for all nurse leaders to keep informed themselves about current NABH, JCI, NABL standards, so that they ensure that the patients are receiving the best possible evidence-based nursing care. So that brings us to evidence-based nursing practice, which is required for providing cost-effective and quality patient care to the patients in hospital. Next, please. Now, there have been many studies which have shown that patients do not receive care consistent to the latest evidence available in the healthcare. And among the reasons provided for not accessing research, evidence-based the evidences or the research evidences, some of the nurses cited that they had lack of time, they do not value research, they have lack of knowledge regarding databases which have the researches, and they do not have access to computer, internet, and medical library, and they do not have skills regarding reading, meaningful reading, analytical reading, and critiquing research articles. Next, please. So nurse leaders, they have to create an environment where evidence and best practices are valued, and they have to give careful thought and persistence for this. Next, please. Now, in India, we have another challenge that since 60% of Indian population lives in villages or rural areas, and in rural areas, nurses are in short supply. And recruitment and retention of nurses, in not just nurses, but all healthcare professionals in rural areas, is such a challenge, because nobody wants to go to the rural areas and work there because of various reasons. And but nurses are required to float around even in such scenarios and provide nursing care, provide staffing wherever they are needed. Next, please. So this means that those nurses must maintain broad, generalized nursing skills and competences, which can mean that they have to care for not just, they have to care for people across all age spans, whether children or elderly. They have to provide critical care to people in rural areas. They have to also provide OPD services, palliative care. So their role in rural settings is diverse, and they are jack of all in some sense. And they also need to know triage decision making, which is again requires skills for the nurses working in rural areas also. Next, please. Now, nursing has become, all of us have become global citizens because of the internet connectivity and also migration of people, especially migration of nurses from one country to another to work in other healthcare settings. So there are also a lot of transcultural issues. So nurses, as members of global health community, they have to be well prepared with knowledge of global health threats, transcultural care, and they have to know the systems, so that they can participate in healthcare the worldwide. Next. So another thing as nurses that we have to do is, as member of global health community, is working towards sustainable development goals, or SDG. And in that SDG 3, although SDG it has got 17-point agenda, but SDG 3 is all about mental health, substance abuse, traffic accidents, reproductive health, etc. And in moving this agenda forward, SDG 3, the nursing profession will be called upon to build capacity of people, healthcare professionals and people, and provide nursing research to achieve SDG goal, mainly SDG 3. Next, please. Talking about patient-centered care, nurses should use the patient's needs, preferences, and values as they are the central focus when developing the plan of care. Next. So patient-centered care is based on 3 goals, that is eliciting the patient perspective on illness, understanding patient's psychosocial context, and reaching shared treatment goals based on patient's values. And shared means the healthcare professional and the patient. Next. It is also important that we talk about cultural diversity in healthcare setting, because we just talked about that how nurses are migrating from one country to another. And even in our own country, we have so much cultural diversity that if we are working from one state to another, we need to understand the culture of the patient. So there is an increasing diverse healthcare system with increasing diversity of team members, and nurses need to increase their knowledge of the healthcare practices of people from different socio-cultural groups, whether they are from their own country or from other countries. And caring for culturally diverse clients presents the nurse with many challenges. Next, please. So nurses must be sensitive to differences in the culture of their patients, like it can be language, it can be interpretation of communication, eye contact norms, gender issues, touch norms, physical contact, food practices, and caregiver acceptability issues. Next, please. Now, another thing which we need to keep in mind when we talk about elevate, educate, and empower is power, politics, and policy. And as we all know that wherever there is politics, there is power, and wherever there is power, there has to be politics. So power, politics, and policy influence nursing practice, education, and research, which in turn influences healthcare. So people who are powerful are able to exert more political pressure. Political success brings more power that allows people to accomplish goals through policy development and implementation. Next, please. So authority has been a problem for nursing since at least the Victorian era, and nurses were kept under the authority of physicians. So here we talk about the power in the hands of the nurses. So nurses have always held subordinate roles. They have always been subordinates to doctors. And this has been there since a long time. And they have to care for the patients. They are accountable for patient care, but they do not have the matching authority. Next, please. So nurses are ordered to care by a society that does not value care. Some paradox that although we talk about nursing care, but the society in general does not value the care. And nurses gained authority through knowledge, feminist influences of society, and slow increase in the scope of practice. So, since nurses are largely, they are the women form the largest workforce in the nursing profession. Therefore, there have been a lot of issues related to the women being in nursing profession and having subservient role in society in general. So nursing leaders, they have fought hard for standardization of nursing education, development of knowledge, and nursing profession has got its own body of knowledge, and they have been fighting for professionalization. Next, please. So how to achieve power in nursing? Keep knowledge and skills current, because knowledge is power. Earn higher degrees, so keep studying. Participate in interdisciplinary conferences like this one. This is one conference where we are talking about elevating, educating, and empowering nurses. Participating in nursing research and evidence-based nursing practice. Participating in professional associations, and like SFNP is one. Then broad human networks. One has to keep connecting with people and publish in quality journals. Next, please. Next, please. Communication is also very important if we were to talk about elevation, education, and empowerment of nurses. And effective communication is required for keeping employees informed of the challenges of the unit, organizational goals, mission, expectations, and responsibilities in meeting the shared goals of the organization. Next, please. And nurses should also be informed about the legal and ethical issues which are there in the profession. So the current societal values are changing, and there is an increasing abundance of litigation in healthcare arena, and therefore nurses also have to be wary and cautious about these issues, because more and more people are becoming now more and more knowledgeable about what healthcare they're receiving. They're asking questions, and they're also doing a lot of litigations. So nurse leaders must apprise their employees about the pitfalls that may arise due to not meeting standards of care in their units, and the legal consequences of not following these standards of care. Next, please. There have been changes for nurse empowerment. There have been changes in nursing education also. Now we talk about problem-based learning, team-based learning, outcome-based learning, simulation-based and reflective practice learning to enhance nursing practice. And it is very important that we as nurse educators inculcate critical thinking skills in our nursing students, analytical skills, so that they are able to make judgments, they are able to make effective clinical decisions, and they are able to provide high quality and safe patient care. Next, please. We also have teacher practitioner model, where we are not isolating the teachers from the academicians, academicians in nursing from practitioners in nursing. So we talk about dual roles for teachers as well as the bedside nurses. So those who are working in the bedside area, they also are involved in academics, and those who are academics, they are also involved in the clinical care practice. So dual role for both sides and not isolating them. Next, please. Career development is also very important if we were to elevate, educate, and empower. So in order to become a valued member within the organization, as an entrepreneur, we need to branch out as an entrepreneur. So the nurse must acquire people skills, that is communication, soft skills, mentoring, being a mentor, being a mentee, and networking with fellow professionals. Next, please. So with that, I thank you for your patient listening, and over to you, Niveda.
Thank you, ma'am. Thank you so much for your wonderful keynote session. Participants, if you have any question, you can put it in chat box, or else you can raise your hand. You have any questions? I think no one has any question, ma'am. Thank you, ma'am. Thank you for the wonderful keynote session. We'll move on to the next keynote speaker of the day. Now, I request Professor Dr. Chong Mei Chong to render the lecture. Dr. Chong, are you here? Hello.
Hello. Hello.
Yes, ma'am. Yes, ma'am.
Hello, good
Good
afternoon or
morning.
good morning over there.
Yes, ma'am. Good morning.
Hi, good morning, good afternoon. Thank you, for coming for this conference, and thank you very much for the organizer to invite me to share my talk today. Let me share my slide.
Yes, ma'am.
Sharing screen. Can you see my slide?
Yes, ma'am. We can able to see your slide. Could you please share it in full screen mode, ma'am, so that everyone can see?
Is it okay now?
Yeah, yeah.
Thank you. I will start.
Thank you.
Right. Right. Thank you very much. So today I'm going to share my thoughts on elevating the roles of care manager to improve patient safety. Okay, this is my content outline. I will talk on patient safety, understanding the role of case managers, the current state of patient safety, optimizing care manager role, case study, and some success story that I would like to share with all of you, challenges and the solutions, in terms of patient safety. Right. So from this picture, in terms of patient safety, we know that a comprehensive patient safety is a basic ground, is a foundation upon which we build trust in our healthcare system. It's very important, to maintain patient safety in the healthcare system so that our patient, will stay confident and will stay safe, when they are in the hospital. Okay. Care managers are the most important person in ensuring this safety, as they are responsible for coordinating patient care, reducing risk, and preventing medical errors. So we as a nurse, especially when you are in charge of a patient, you are in charge as a case manager, you play a very important role to ensure the patient safety in the hospital. Right. So who is actually care manager? The definition of care manager is sometimes it will be interchangeable, defined as a case manager. Right. So coordinating and managing the care of patient. You are a coordinator. Not necessarily the care manager should be a manager in the ward. But a staff nurse, a registered nurse who is in charge of the patient can be a care manager. And she or he will facilitate communication among the healthcare team, patient, and their family. right? So they play a very important role in becoming a communicator and to facilitate in terms of interaction within the different level of healthcare provider. So they're also ensuring that each patient is unique and need and are met. So they ensure the patient, every single patient, yeah, each and every one of the patient have different kind of need, right? So we need to look into the holistic care for the patient. Therefore, a care manager have to ensure each patient receive a unique need, receive a unique care to meet their needs. So what are the responsibility of the care manager? A care manager will be a patient care coordination. You coordinate the care of patient from the patient admit to the ward. You plan for the care, right? And then you monitor the patient condition, and then you will be a risk assessor. As a nurse manager, when we practice our nursing process, one of the assessment we are going to use all this data from our assessment, be it subjective data or objective data, we will develop a distinct nursing diagnosis. Therefore, we have the skill of assessing the risk of patient, maybe risk of fall, risk of hemorrhage, right? And then risk of infection. Then when we assess the risk of patient, then we will find the solution for it. Then we come up with our intervention to prevent the patient from having the risk, right? Having the actual problem. And then when we nurse the patient in the ward, we'll make sure the patient the safety are ensured, are guaranteed in the ward. And so when the patient discharged, before they discharge, the case manager will assess the patient, and then they will plan appropriately before the patient discharged, and so the patient can follow up the care at home. So those case manager play a very important role, and then they have they are very competent in their care, and then they have all the skill to care for patients, but somehow or other they do face some challenges. For example, the complex of cases. Patients will come in, especially in terms of geriatric ward. Geriatric patients will be very complex. They will come in with a lot of comorbidity with them, right? And then some will be from different culture perspective. So patients are very complex individual, right? It's not so you can have one formula, you can have one guideline fits all. And then limited as resources will be one of the problem. Communicate effectively with various stakeholders is also another complex issue that the case manager used to face the challenges, right? Then role ambiguity can lead to misunderstanding, right? So you are a case manager, sometimes you don't know where to put yourself. Are you just a nurse, or you are a manager, or are you just responsible to carry out whatever instruction by the doctor, or you can actually plan for the patient? So a lot of role ambiguity that lead to misunderstanding. So that all about what in short, what is the case manager and what is their responsibility and their challenges. So now we shall move on to see what are the current state of patient safety in our environment. So from the WHO estimated that 1 in 10 patients worldwide is harmed while receiving hospital care, right? That is very serious, right? So this incident can result in patient harm, prolonged hospital stay, and increase the healthcare cost, of course, right? So the most common hospital problem that will affect the patient's safety will be medication error, right? So what is medication error? How we differentiate error from mistake, right? Mistake means if somebody is a nurse who serves the medication, have not gone through the training, without any knowledge, so they tend to make mistake. But in terms of error, you have done everything. You have passed your nursing, in terms of serving medication. You have the skill in serving medication. You know all the right that you need to follow. Hello, is there any problem? Hello? Is there any problem, Sumanta? Right. So medication error tends to happen. Yeah, even though we have the knowledge, we have the skill, yeah, everything under control, but errors still happen. Why? Okay, so we need to find out why. Yeah, medication error is one of the indicators for patient safety. And patients are at risk of fall, also one of the important indicators in terms of patient safety. And hospital-acquired infection. Right. We have all the measures. We do 5 moments, hand washing. Yeah. And then there are so many steps. You know, you have surveillance, infection surveillance in the ward. So many, and then we used to have health education for nurses. Yeah, continuous professional development for nurses to improve their skill in preventing infection in hospital. But yet still happen. Why hospital-acquired infection? We can't stop it. Right. So all these will affect patient safety in the hospital. So case managers are responsible for patient safety, ensuring that patients receive the right medication. Okay, that is important. Adhering to safety protocol. So there are lots and lots of protocol in the hospital, but are they really user-friendly, or they are easy to reach out to nurses? Is nurses referring to the protocol? Some of the protocol, the ward manager will keep them very nicely in the cupboard and hardly be used by the nurses, right? So all these protocol must be easily accessible to the care manager or nurses. Educated on infection prevention measure is very important, right? For risk assessment and prevention strategy is important, and collaboration with physician, nurse, and pharmacy is important to ensure, the patient safety will be taking well care. So elevating care manager role, how are we going to help the nurses, or help the care manager to improve their competency in terms of patient safety precautions, right? So there must be a clear defined role and responsibility for the care manager role, as I mentioned, ambiguity role can cause a lot of problem. You need to have clear defined role, and comprehensive training program is very important. You cannot assume when they were in basic training, they have learned all this. They know what is infection control. They know what is risk of fall. But we need to have continuous training, to make sure they are more competent, to prevent to have patient safety. The integration of electronic health records and communication system is very important as well. There are a lot of devices can be used, to prevent from any infection control or to prevent from risk of fall. Okay. Then interdisciplinary collaboration is very important. To maintain patient safety in the hospital environment, it's not just the care manager role. We need the support from the clinician. We need the support from the physiotherapy, occupational therapy, right? And also we need the support from the pharmacist. So I would like to share one case study and success story. This case study is in the teaching hospital background. Hospital A is a prominent teaching hospital in Kuala Lumpur, Malaysia. Commitment to provide high quality healthcare. Hospital A was facing challenges related to patient safety, including medication error and patient care coordination. Right. So optimizing strategy, they start this strategy as what I say, role clarification and a clear defined role of every healthcare provider is very important. Role standardization, interdisciplinary collaboration is important, and advanced technology. We have to take advantage of the advanced technology in the hospital, such as you use devices to monitor patients, right? And then communication, in terms of communication, you can use advanced technology in terms of communication to prevent any patient risk. So the measurable outcome, after the project, this project, the medication error decreased by 35%, and then case coordination is efficiently improved, resulting in 20% reduction in line of hospital stay and patient satisfaction score increased by 25%. The hospital readmission rate reduced by 15%. Those are all are less than 50%, but shows some improvement, right? So success story from this project is fewer medication error, shorter hospital stay, and higher satisfaction with their care, a culture of cooperation among care managers and other healthcare professionals, enhanced patient safety, and elevated overall quality of care at Hospital A. So what are those challenges and solutions? Challenges, resistance to change. Yeah. So when you have come up with new procedure and new guideline, of course, you have those people who are very complacent with what they have done, they are resistant to change, right? And resources constraint. So if you want to include facility like using ICT and all that, all this need money. Okay, and variation in patient population. We, as I say, patients are very unique. Yeah, we will not receive just a same patient, similar patient all the time. Patient might come up from different background. Patient may have different level of education. Yeah, and patient may have different mobility. Like, so you really have to consider all this, right? And then solution to it, change management strategy. So good managers have to have a change management strategy to overcome this. Allocation of necessary resources. Yeah. So when you have very short of resources or resources constraint, you really have to plan and fully maximize all the resources, right? Tailoring approach to specific patient group. So engaging stakeholder, engaging administrator by demonstrating a cost effectiveness of these changes. Yeah, so you need to identify who are the stakeholders who actually who have the power, yeah, to include in your change management. Yeah, healthcare providers by highlighting improved patient outcome. Yeah, and patient by improving them in care decision and planning. So when we want to plan for any treatment or any intervention of any care, yeah, nursing care for patient, we are not going to we decide what to do for the patient. You have to get the patient involved and discuss with them what is good for them. They know what goes best for them. Yeah. So you need to have shared decision with the patient. Continuous improvement is very important in patient safety. You can start any project, it works well, yeah, but you don't have continuous improvement, it doesn't work, yeah. And regularly review and refining care manager roles to adapt to evolving patients' needs, technology, and healthcare policy, right? We cannot have one healthcare policy work for 10 years, 20 years, right? Things change over the time, especially with this technology, yeah, ICT technology advancement, yeah. You have revolution, yeah, 4R, 5R, yeah, 5.0 revolution, yeah. So you have to go in line with the society change, go in line with the technology changes, right? So the healthcare policy have to review from time to time, right? And then in terms of diseases, yes, the especially infection control, infection diseases such as COVID-19, yeah, pandemic have actually changed a lot of reorientations of the healthcare system already, right? So a culture of continuous improvement is essential to sustain success, right? So we have to inculcate, yeah, a culture of continuous improvement. Though it is not easy, yeah, but you need to train the nurses, yeah, in line with continuous improvement. So recommendation and conclusion, yeah. As I mentioned, clearly define roles of the care manager is very important. Yeah, we must know what is their role. Their role can be advocator. Their role can be educator. Yeah, and they can be a supervisor. Yeah, to other younger nurses. And then their role can be the planner. They plan, yeah, together with the patient, what is good for the patient, right? And they can play a role for organizer or consultant in terms of care, right? And in terms of comprehensive training is very important. Yeah, we do not want a training just for the sake of collecting CPD point. yeah, to renew maybe a annual practicing license. Not just that, when you plan for a training or a workshop, yeah, you must do a need assessment, yeah, whether it's appropriate, yeah, for the nurses. You don't teach the same thing over and over again, and then the nurses are not changing. Yeah, so you have to find out the root cause why after giving so many round of training, the nurses still behave the same. The 5 moments, they are still not compliant to the 5 moments. So you really need to plan. You need to look at the need assessment, and then you need to look at the attitude. You need to look at the behavioral change as well. Of course, they can change the behavior, right? And then giving the cause, you must follow up and monitor them from time to time. Technological integration is very important. Yeah, makes full use of the advancement in technology. Yeah, monitor our devices. You can monitor. Yeah, monitor the patient safety. Then interdisciplinary collaboration for care managers is very important. You need to work closely with the clinician. You need to work closely with the physiotherapy, occupational therapy, dietitian, yeah, and pharmacists. Yeah, because polypharmacy can cause a lot of problem to patient as well, especially in terms of risk of fall. Right. So who are the person? Yeah, who are the champion? Patient safety champion? Who? All of you. Yeah, all of the participants from this conference, you and me as well. We have to work together to overcome to improve the patient safety in the hospital. Healthcare professional, should get involved, should be the champion in patient safety, right? And policy maker is very important, to come up with a clear guideline, to come up with a clear policy, to monitor, patient safety. Administrator, of course, in the hospital, especially in terms of nursing, and then quality control unit play a very important role as well. So all the healthcare provider and all the category of healthcare provider in the hospital and the stakeholder play a very important role in maintaining patient safety. This is my reference. Thank you very much for your attention.
Thank you, ma'am. So, any questions?
Hello.
Any questions? So, if you have any questions, you can write in the chat box.
Ma'am, can I ask a question?
Sure,
yes,
sure.
Sure.
Good morning, respected speaker, ma'am.
Morning.
I'm Neha Raj from All India Institute of Medical Sciences, New Delhi, India.
Yeah, nice to meet you. Yeah.
Nice to meet you, ma'am. Ma'am, I have a question. Like in our scenario in Indian setting, we have seen like in nursing profession, most of the nurses are female, and very less they are coming up, but males are also coming. What is the scenario in Malaysia, ma'am? Because this is one of the important factor. You must be, maybe you are also facing same issues there. So how can we just take care of this thing? Because it should not be a gender biased thing. Because when a nurse is there, nurse is a nurse. If a doctor is there, male or female, we are not seeing. But in some areas of like in our nursing care, especially obs and gynae, we are seeing. In Indian scenario, people would like to have like nursing care from the same gender of that health professional. So what is the scenario over there?
Right. Okay, in Malaysia, we have quite a significant number of male nurses now, right? In Malaysia, but the number is not so much as compared. The ratio is still dominant by female, right? Because in Malaysia we do have the position which is called medical assistant, which is more dominating by male, right? To me, in Malaysia we do have male, but there are a lot of constraints because male patient can only work in the male ward, right? Unlike we all for female nurse, it is acceptable anyway. We go regardless of male or female ward, right? So and in midwifery, in maternal and child health ward, male nurse are not very acceptable, right? This is a lot of gender bias, and also in terms of status bias. When obstetrician and gynecologist male, it's okay for them to work in the maternal and in maternity field.
What's another area?
But when it comes to nurse, they say no, female cannot. Right. So there's still a lot of biases, right? Which we can hardly get things right, right? Okay. So to me, we in terms of patient safety, we need both. We need both, right? In terms of safety, like in ED ward, emergency department, we need more male nurse. Yeah, because male. Don't get mad with me. I'm not being gender biased. Usually, male think very fast. We as a female, we take a lot of things. We have to think in the emergency department cannot offer us to take time and think what is best for the patient. But male usually make decision fast in the emergency department. We might need the male nurse in the ED. Maybe
they're more practical oriented, ma'am.
It can physically can reduce the patient's risk. Yeah. Indirectly can improve the patient safety in the ED with more male than female, right? But in pediatric ward, I guess female nurse, women are more caring, are more careful in terms of handling baby than male, right? So like in psychiatric ward, in terms of patient safety, we have risk of patient injured, or maybe the staff will get injured, from the attack of the aggressive patient. So maybe in psychiatric ward, we need more male nurse, right? In terms of physical attack kind of thing, in terms of controlling the patient. In OT also the same. Maybe in OT also we need more male. Orthopedic ward we need more male. So we should get a balance, balance
should be there,
and take the advantage of the different gender. So we shouldn't feel like in terms of gender bias, we don't want male in our profession. Nursing is for female. We don't get the kind of thing, right? We should take advantage of the male nurse in whatever area which female nurses may have some disadvantages, right? But of course, I don't know in India, maybe in country like in Malaysia, maybe it is more male domineering, and maybe in Muslim country, correct me if I'm wrong, I just give an example, religion become very sensitive when we want to explain, right? So in male domineering country, right, the female nurse will be at disadvantages when there are a lot of male, because when it comes to promotion, they become nurse manager, nurse officer, people will consider male more than female, right? We can't avoid this kind of thing. We can't deny and we can't avoid this kind of thing will happen. But that also depends on how we as a female, we must take care of our what you call that, benefit. You have to show your competency. You have to show you are equally good with male, right? So then you can have equal chance.
There should be like some awareness in the society. That would be like that is going to help us also, because when we are making curriculum, we are making as per the societal needs. So we need to have some, I feel like, because I'm also in teaching, I'm tutor in nursing, in College of Nursing. So most of the young guys, they say, ma'am, there should not be any this inequalities there. 80-20 is the ratio they want to follow, like 80 female nurses and 20 male. So this should not be, but as a teacher, I also understand that it should not be there. So I feel like there should be some changes in the mentality of the public. We have to work on that. Because if you are projecting very good things in front of the public, Public is what? Patients, those who are coming to hospital or at community level. So I think there would be change. There would be positive change.
Yes, it should be. But in Malaysia, female nurses are well accepted by the public. They are not like a stranger anymore. Because maybe 20 years ago, when we just having male nurse in the public, they feel very strange. Yeah. Oh, I didn't know there's male nurse around and kind of thing. So and the what you call that? How to address them? The title of like you used to call nurse manager sister. What about in India? You call sister or matron? You still
Now
call
there
that?
is change in the nomenclature. Now all are known as nursing officer. Previously it was sister for male also.
Now you call madam, isn't it? Right. So in Malaysia, we still call it's like the British. We still call nurse manager sister. We call matron, and then you call a male nurse sister. Oh my God.
Same scenario was there in, but now the nomenclature is changed in
it shouldn't be. It shouldn't be. It's to call Mister or call madam. We call male nurse. We call sister as well. It's not very appropriate, right? But they say sister is not a gender title. It is the title of
designation was like that.
The designation. So but public will not understand. Oh, he's a male. Sister, right? Okay, this is a problem. This is a problem. But we slowly get rid of it. Even now, matron, we call them as madam or Mrs. or whatever. We don't call matron and sister. Right. We have to change according to the society.
Obviously, we need to say we have to be more professional at like clinical areas. We have to give respect to each other.
Yeah. So now people are moving like director of nursing, right? CEO. So that kind of thing, we have to increase our image, build up our image in the society.
And image in the society.
Yeah. So nurses should be on par with other professions already. We shouldn't feel inferior. Right? And there's so many nurses already have PhD and all that. We should feel proud of ourselves.
Proud of our work, obviously, ma'am. Self-respect is the key for success in this profession. When we are respecting ourselves, people will start respecting. You're right.
You yourself have to look into yourself first. Like now I'm an associate professor. I have a PhD. When people ask me, what is your position? Number one, I say I am a nurse. We mustn't forget we are a nurse forever, right? Sometimes when you go for any conference, some of my colleagues they want to introduce themselves. Who are you? They are lecturer from this department and all that, right? Then they will say, I'm from department of I'm from faculty of medicine. They always say, I am from faculty of medicine. And this department, I'm from nursing. What? Why should you slow down? You should highlight I'm from department of nursing.
Obviously.
When you feel inferior, people will look at you inferior. I don't care when I go anywhere, even they have professor. I say I am a nurse. Nurse first, then only lecturer, then only you call your professor. Whatever. Yeah, we must do that. Yeah.
You are very right, ma'am. It was lovely talking to you, ma'am.
Thank you.
Thank you so much. May I get your email ID, ma'am, in the chat box?
Okay, sure.
Thank you so much, ma'am. Have a good day.
Thank you.
Thank you.
Thank you. Ma'am Farhana, do you have any questions? You have raised your hand.
Yeah, I just wanted to comment on the ratio of the female and male. In Pakistan, we faced a big problem when our diploma program was eradicated and we started BSc degree only. Our female in remote areas, they don't have much access to intermediate science. And now a very big paradigm shift is seen in Pakistan, that more boys are joining the nursing profession compared to the female, because the boys, they have more access to the education, they can travel to another cities, although women do. But now female dominant profession is becoming almost male dominant in Pakistan. And we are facing an issue due to it, because most of the male, when they did internship, have some experience, they go abroad to earn money. So again, we have a problem of shortage of staff. Thank you. Thank you.
Hello,
so
ma'am. Good morning. Nice to meet you. Namaste from India. Assalamu alaikum, ma'am. Farhana ma'am, you are also in teaching, ma'am. Okay. Can I get your email ID, ma'am? I'm from India. I'm in College of Nursing, AIMS.
Yeah, sure. I'm writing in the notes.
Okay. I'm Nilima Raj, ma'am. Nice to talk to you, ma'am. Thank you.
Okay.
Thank you, organizers. I'm feeling very happy because we got a platform where we can talk to so many.
Good. Yeah. Happy to talk to you all too. Yeah.
Hello,
Ma'am,
ma'am.
thank you. But if you
Thank
have
you.
any questions or any conversation, you can have it in the chat box, ma'am. I'm
Yeah.
sorry.
Thank you, Dr. Farhana, for your comment. Thank you very much. Okay. Thank you. Bye.
Ma'am, thank you, Professor and Dr. Chong Mei Chan, for your insightful speaker. So next, I will call Ms. Farhana for your presentations. Thank you.
You have my presentation?
Yes, ma'am. Yes. Should I need to share it?
Yeah, share it.
Okay.
It will be more quicker, faster.
Okay, thank you. Yes, ma'am, you can start your presentation.
Okay. I would like to really thank all the organizers and coordinator of this conference, because it's very important, not for our subcontinent, India, Pakistan, Asia, but it's very important. You can hear me clearly?
Yes, ma'am, you are audible.
Yes, very clear.
Okay, so it's a very important topic you have selected, and it's a very great opportunity for global nurses to join together and talk about elevate, educate, and empower. It's a nursing journey which is not only close to my heart, it's actually close to each and every woman or man who join nursing, who join to become a nurse, who dream of becoming a nurse, who embark on the journey of this education and empowerment. They want to choose a career where they can care. And this is the theme, foundation, or whatever you can say, that nursing is the only profession which is worldwide, globally, equally for female and male. Although it had been a female dominant profession, it had been the most important profession because it is related to our health. Next. Next slide, please. Previous one. Can I go back? The nursing journey, actually, before we talk about elevate, educate, even empower the nurses, we need to look at the few skills that what we need to have to join this profession. It's nursing or nurse, it's like a rainbow, which is engulfing the whole world. And it's a sunshine, which is boosting upon the world. And we have to have compassion, care, competence, commitment. We should be compelled and with the courage and a good communication skills. Next. And how we can elevate our profession. As a nurse, unless myself, will recognize as a nurse when I want to start this profession, that I want to recognize its significance, its value within the healthcare system, and to acknowledge the tireless efforts of all the nurses working around me, locally, regionally, nationally, and when we go beyond the borders, globally. So we have to ensure the well-being of our patients, ourselves, our co-workers. and we are working tirelessly around the clock, 24 hours, 7 days a week. Lifelong learners are the lifelong workers. So we have to celebrate to elevate our profession. We have to celebrate nurses' dedication, resilience, and unwavering commitment for making a difference in making people's life. Nurses make a difference. We do. You see, the therapy for the infants was started by the nurse. Physiotherapy was started by the nurse. The personal protection equipment was invented by a student nurse for the virus protection. So we have to recognize our significance, that we are making a difference. I have to believe it, that I'm choosing this profession. I will elevate furthermore. I will climb the ladder, and I would be able to make a difference, not only for the patients, for myself, for my colleagues, for the health globally. Next. Next slide, please. And how we elevate. The cornerstone of the nursing education, nursing profession, the cornerstone is the education. When we talk about nursing profession, having a good nurse, a very good effective nurse, a good outcomes of a care, we have to look at the cornerstone of that success, and that is nursing education. Nursing education is the only foundation which takes us to the success, and then we can say we dare to elevate the nursing profession because we are empowered with good education. We must invest in robust educational programs. Unfortunately, I don't know about India much, Philippines, but I have worked with the Filipino nurses in Brunei Darussalam for 12 years in Saudi Arabia. I know that in Philippines, there are a lot of many college of nursing there. But what we invest in Pakistan in nurses? No pharmaceutical company has ever supported a nursing activity or educational CME. No, we don't get any sponsorship for the conferences. If we want our national health to increase, we must invest in robust educational program. We must equip nurses with the knowledge, skills, and competencies. Whenever in an interview for the job in past, I was to be asked a question, what do you think about nursing? And my answer for the past 20 years is the same. Nursing is nothing. It has got 5 pillars: ethics, morals, standards, values, and skills. They are needed to deliver the high quality care and continuously learning. I'm 60 plus already now. I'm Pakistan's first advanced nurse practitioner for the past 17 years. And till date, I'm the only advanced nurse practitioner of Pakistan. First, from UK, University of Nottingham. Now I'm doing MSc in Diabetes Care and Management. That will make me again the first advanced nurse practitioner in Diabetes Care and Management of Pakistan. So that gives a reflection of continuous learning, that I'm enrolled in Asia University, Malaysia for PhD. I've slowed it down because for me, FEND scholarship, MSc in diabetes care is very important. My nation needs it because 27% of the population is having diabetes and we don't have a single nurse practitioner in diabetes care. So continuous learning is not just a requirement, but it's a necessity in today's fast-paced world. Next, please. Next slide, please. Yeah. The core of the nursing journey, we are talking about nursing journey. And we say nurses, we proudly say, nurses are the catalyst of change. They're the change agent. Core of the nursing journey is actually nurses themselves. nurses to advocate for themselves, for their profession, for their patients. We need to create an environment where all the nurses, regardless of their sex, education, social status, religion, even religion, regardless of that point, they should feel valued, respected, and supported in an environment. Then they will become a catalyst. They will have the authority, they will support, and they will have the resources for positive change. We cannot make change, we cannot bring change if we cannot invest in nurses. This way, even I have to invest in myself to get this that open. And as a change agent, we are driving innovation and improving outcomes for individual and communities. 1 year ago, I took part in a national competition, National Idea Bank. And there was no nurse in that competitions for the past 3 years it was going on. And I won the 3rd position for my just one single idea to train the community nurses, low-cadre nurses with diabetes care and management and make a difference for the nation. Not only nation, it will impact the borders as well, across borders. So that is innovation. We have to go for the entrepreneurship. We have to make nurses to be a business manager. Healthcare industry is a big business. Our nurses need to be empowered in that way. And improving outcomes for individual and communities, our nurses need to be innovative. Because you see, without nurses, no hospital, no healthcare management, no healthcare facility can run. Next, please. And when we think about empowering nurses, when we think about educating nurses, making them innovator, researcher, advocator, we have to think about the challenges, a staff shortage and scheduling. It leads to burnouts. Well-being and the quality of the care they provide, their own health to be restored. So addressing these challenges requires a collective effort from all stakeholders, healthcare institutions, policymakers, educators, and the community. I remember 40 years ago when I used to watch drama, a nurse means in our Pakistani dramas was, she will bring a tray with the medicine. People are sleeping and she is awaking them. Please take your sleeping pill, or she's just doing the dressing. So I left the college and I said, oh my goodness, I don't have to do anything. I'll just take the tray of the medicine, give the medicine to the patient and do dressing only. But when I joined Aga Khan University Hospital, the first very advanced nursing education institute of Pakistan in 1981, believe me, I was shocked. Kilos of books I have to read. I ran away from the college to become a nurse. So I don't want to become a doctor. I didn't want to become a scientist. My father wanted me to become a doctor. So I said, nurses don't study. But then I realized that our policymakers, our media, our educators, our community, they have to change their thinking about nurse, thinking about having this ideology, philosophy that nursing is the most important, wanted, needed profession for the national and global health. Next, please. Next slide, please. So I will not talk about the problems.
Yes, ma'am.
Yeah, I will be just ending in 5 minutes. I will not talk about the problems we face in Pakistan or in Asia Pacific or globally. I will talk about the opportunities nurses have, because I went to 17 countries in the world because of nursing. I was offered US citizenship because of the nursing. I live in England and doing my second degree now. In Saudi Arabia, I developed a fantastic home care, wonderful home care system I established there. I'm a researcher, I'm an educator, I'm a manager, I've been a director of educational institutes, I established institute, and still I'm a very good bedside nurse. You give me a baby and say pass cannula, I'll do that. You ask me to take the arterial blood, I will do it. Sitting in the office and a director chair, principal chair, my skills, I did not lose my skills, not any skills. So there are so many alternative careers in nursing. We have to just climb that ladder to get that key of success. The advancements in technology is making me to speak to my Indian counterparts. That's a wonderful opportunity. We are ambassadors of peace now. We can globally cross the borders without even moving from our chair. So the growing recognition of the importance of mental health and well-being present avenues for innovation and transformation within the nursing profession. Next, please. I think there's a last slide. Next. Next slide, please.
Yes, ma'am, changed.
Okay, so now we have to, in conclusion, we have to see that what we can offer to our fellow nurses, especially the junior nurses, what we can offer to them. We can offer to them profound significance and impact leaders make. We can show them the compassion, dedication, and firm commitment serving others. As we strive to elevate, educate, and empower nurses, it's a wonderful theme you have selected. It's the calling of the day. Nurses are the backbone of our healthcare system. So we have to elevate, educate, and empower nurses. We are the unsung heroes whose contribution often go unnoticed, invaluable beyond measures. And we need to strongly say that even though we are pushed, we are even though we are pushed, we are hurt, we are giving pressures, we are still the backbone of the healthcare system. Thank you so much.
बात है ना किसी का पैसे लेके तो मैं आपको 3750 न्यूज़ होना
I think this was the last slide.
Yes, ma'am.
Hello. Yes, ma'am. Thank you so much for a wonderful keynote session. Participants, if you have any question, you can put it in chat box or else you can raise your hand. Or else you can unmute and ask yourself.
Hello, ma'am.
Yes. Yes.
Am I audible, ma'am? Hello.
Yes.
Yes, you are audible.
Nilima Raj, ma'am, from AIMS, New Delhi, India. Ma'am, hello. First of all, my heartfelt congratulations to you.
Thank you.
I'm so inspired by your keynote session. We need leaders like you, ma'am, obviously in every country, in our profession. We as educators can play a very important role, ma'am, because we can mold the life of a student with our positive attitude. Because as you said, now there are so many, like we all have gone through the various struggles in our life in nursing. It is not a very simple journey. I think it's for everybody. But the new generation, they are having lots of opportunities and they have so many of skills. So I feel, I always tell my students, you people are so lucky. You should have positive attitude, because when I take care of first year student at present. So first year honor students, they are like babies in nursing. So with our positive attitude and good guidance, we can just guide them and we can, like, they will be a good student. So empathy is the factor, important factor, I feel like that. As you told, you have so many of degrees and other things, but you have like love and empathy for patient. That is very important. And what I feel, we need to, as a leader or as a nurse manager, we should promote our juniors, especially in case of research. We should try to create a research friendly environment in the clinical as well as in the education, and we should support them, because this is the time when we need to have evidence based practices in every sphere of life. So your session was very inspiring and encouraging. Thank you so much, ma'am, and again congratulations. Hope we will have talk in future, ma'am. Thank you so much.
Thank you, ma'am. Participants, you have any other question? Hello. Anyone have any question? Yeah, ma'am. Thank you, ma'am. I think no one has any question. Thank you so much for the wonderful keynote session, ma'am. Hello, ma'am. Can you hear me? Vahana, ma'am. Can you able to hear me? I think you are in mute, ma'am.
Oh, yes. Yeah.
Thank you, ma'am.
Thank you so much.
Thank you so much for a wonderful keynote session. We'll move on to the next session. I request Mr. Abdullah Ali Nifla to render the lecture. Are you here, Dr. Abdullah?
बाहर देखो.
Okay, we'll move on to the technical sessions for the day. Thank you, everyone. Thank you, everyone, for the wonderful keynote sessions. I have an important announcement for the participants who are presenting today. Kindly please remain here. The session will begin now. Can we start the session? I would like to ask the session chairs. Can we start the session? Dr. Virendra Singh.
Yeah, sure, ma'am.
Sure, shall we?
Yes, ma'am. We can start.
Sir, thank you. I would like to welcome our session chairs for the day, Dr. Virendra Singh Chaudhary, Professor and Head, SN College of Nursing, India. Dr. Arul Valan P, Professor, Dr. Kumaraswamy Healthcare College of Nursing, India. Ms. Suchanda Bhattacharya, Tutor, Assistant Protector, Jamia Hamad, India. Now, I would like to welcome our first presenter of the day, Dr. G. Karpagavalli from Tagore College of Nursing, to give an oral presentation. Karpagalli ma'am, are you here? Karpagalli ma'am, are you here? Akriti Kafil Bare. Akriti Kafil. Akriti. Shweta Jalni. Shweta. Karpagali ma'am, are you here?
Okay.
Is anyone ready to present now? Is anyone ready for the presentation? You can present.
I am Anisha. Shall I present?
Manisha?
Yes.
Okay, you can. Yeah. Shall you?
My time is only at 1:10, but nobody is here.
Your full name, please.
Anisha VB.
Anisha. Okay, Anisha. Okay, fine. You can present, Anisha.
Shall I?
Yeah, sure. Share your screen. Session chairs, I would like to ask one thing. You have the evaluation sheet with you for the marking?
No, ma'am.
Evaluation sheet?
So we have not received evaluation sheet.
You have not received.
We have not received.
Okay, I will ask the coordinator to share with you. Actually, evaluation form is basically you have to mark for the participants who is presenting here. Out of 10, you have to mark. I'll ask the coordinator.
We can mark out of 10, but we don't have any evaluation form.
Okay. Okay, sir. I'll ask the
Niveda?
Yes, ma'am.
I have the evaluation criteria. You have sent me, I think, yesterday, and I will print it. So it will be on the 10 marks. Now there is no I mean, the distribution of marks is not there. Only total marks is there.
Okay, ma'am. Ma'am, we could not able to hear you, ma'am. Hello, sir. Kindly check your mail, please. We have shared the evaluation form with you.
Okay, ma'am, I'll check.
Yeah, we will check.
Yeah. Shall I ask the Anisha to present, sir?
Yeah,
yes,
please, we will continue.
Yeah. Anisha, you can start.
Am I audible?
Yeah, you are audible.
Yes, Anisha, you can start.
Good morning. Good morning to you all. My name is Anisha, Assistant Professor in Amala College of Nursing, Kerala. And I take this opportunity to present my topic here. And I am honored to present here also. So today's my topic is effectiveness of structured anxiety management strategies on level of anxiety among BSc nursing students. And the study was conducted among BSc nursing students on their level of anxiety. So the background of the study: anxiety is a common emotion when dealing with daily stresses and problems. But when these emotions are persistent, excessive and irrational, and affect a person's ability to function, anxiety becomes a disorder. So this is a normal aspect of life for everyone. A young person must adjust to any change, whether internal or external, positive or negative. So anxiety disorders are the most important health issues faced by adolescents. and also their parents and those who work with and treat adolescents. And anxiety disorders are the most common psychiatric disorders among adolescents with an estimated prevalence of 31%. It can happen at any stage of life, but they usually begin by middle age. Women are more likely to have an anxiety disorder than men, according to National Institute of Mental Health. So stressful life experiences may increase your risk for an anxiety disorder. So,
excuse me, ma'am, slideshow, please. Sorry to disturb you.
It is in slideshow, ma'am.
No, we are not getting that slides show. That is only first slide is visible.
We are not playing the slide. Actually, it is in a word destination.
Now is it visible now, sir?
It is not opened in a full view. It is in a small view.
Sorry, it is here. It is in slideshow only, sir. So.
Okay, at least you change the slides that you are going for next.
Sorry, sir, I don't know whether it is a net issue. Here it is in slideshow and I am moving it also. So what to do, I don't know.
Okay, fine, continue. Okay, fine, continue.
Continue, please.
Okay. So relaxation techniques are an excellent strategy to handle stress. So relaxation is a technique for reducing the negative effect of stress on mind and body. To relieve stress and the symptoms of mental illness, such as depression and anxiety. Slowing heart rate, lowering blood pressure, slowing breathing rate, improving digestion, maintaining normal blood sugar levels, reducing stress hormone activity. These all are the various advantages of relaxation technique when we do or practice daily the relaxation techniques. Example like breathing exercises, relaxation technique like meditation and all. And here in this study, mainly meditation and breathing exercises are used. So meditation, it is a sort of supplementary treatment for the mind and body. And the meditation can help to achieve a deep state of relaxation as well as a calm mind. So during meditation, one can concentrate on attention and clear the mind of the muddled thoughts that may be bothering much and producing stress. So altogether, physical and emotional well-being may be improved as a result of this process. Meditation is increasingly being practiced as a therapeutic technique. This meditation also teaches people how to focus their attention while attempting to eliminate or dissipate their thoughts. So goal of this exercise is to achieve a state of increased relaxation and mental peace. Sir, now it is visible. Sir, may I know it is visible?
Actually, it is not moving. You just stick on the slide number 5th only in that our presentation, but you will be continuing with that. You will change from your side because it is not in the slideshow basically.
Oh. Is it needed to stop and restart again?
Slide. You can find that 4 box, right? Near that one system like symbol is there, right? You can just choose that. Just
Actually, I
click
have
that.
shared the screen, but
Yeah, we can able to see your slide, but not in a full screen mode. And your slides also not moving. Currently, we can see your 5th slide only.
Shall I stop the share and start again?
Yeah,
Check whether
reshare. But please do it faster.
Now it is okay, ma'am.
Yes, now it is okay. Perfect. Just move the slide and see it's moving or not. Yeah, it's
Yes,
moving.
now it is okay.
Yeah.
Sorry.
Okay, no issues. Continue.
Shall I continue?
Yes, yes.
Yeah, continue. Continue, please. Continue.
Okay, need of the study. So need of the study among 15 to 25 age group in India, 1 out of 7 feels anxiety, depressed, and has a little interest in doing things, according to a new report by UNICEF, which warned that the COVID pandemic can impact the mental health and well-being of children and youth for years. So a survey conducted by UNICEF and Gallup in early 2021 with 20,000 children and adults in 21 countries found that people seem reticent to seek support for mental stress. So to support this, a Discovery cross-sectional study was carried out by Basu et al. To find the prevalence of depression, anxiety, stress among nursing students. About 33.33% of students suffered from moderate to extreme depression. 56 to 0.59% had moderate to extreme level anxiety, and 23.26% experienced moderate to extreme level of stress. So in another study, an analytical cross-sectional study was undertaken among 180 nursing students to determine the impact of anxiety on individuals and other contributing factors. So family discord, apathy in the course, uncertainty about future placement were all the concern, all statistically significant predictors in the development of sadness and anxiety according to a binary logistic regression. So my statement of the problem, a study to assess the effectiveness of structured anxiety management strategies on the level of anxiety among BSc nursing students in selected nursing college, Trichy. The objectives were assess the level of anxiety among BSc nursing students, assess the effectiveness of structured anxiety management strategies on level of anxiety among BSc nursing students, find the association between level of anxiety and selected socio-demographic variables among BSc nursing students. The hypotheses were there will be significant difference between pre-test and post-test level of anxiety among BSc nursing students. And there will be significant association between level of anxiety and selected socio-demographic variables. And the conceptual framework I used for this study was Imogen King's goal attainment theory. And this was the model. And tools and techniques used. And the research approach was quantitative approach. And the research design, one group, the study was conducted in one group only, that is pre-test, post-test, pre-experimental design. Variables, independent variable was structured anxiety management strategies, which included breathing exercise and meditation. Dependent variable, the level of anxiety of BSc nursing students. Setting it was conducted in Amala College of Nursing, Trichy. And 4th year BSc nursing students was the samples. Population, all 4th year BSc nursing students were studying in Amala College of Nursing, Trichy. And the sampling technique also, it was applied was purposive sampling technique who meet the inclusion criteria. And the sample size was 30. Inclusion criteria, those students who are presently studying in the 4th year BSc Nursing in Amala College of Nursing, and also those students who are willing to participate in the study. And students who are absent during the time of data collection were excluded. Tools used, tool 1, structured questionnaire to assess the socio-demographic variables of BSc Nursing students. Tool 2, anxiety scale. Hamilton anxiety rating scale was used to assess the level of anxiety. And coming to the structured questionnaire, mainly the socio-demographic variables were age, gender, religion, area of residence, type of family, monthly income of family, educational status of father, mother, then occupational status of father and mother. Also the birth order of the student. Then type of school, type of stay, hostler or day scholar, then primary support person, intake of anxiolytics and previous meditation training session. And the Hamilton Anxiety Rating Scale, it was a 14-point scale. The symptoms were scored from 0 to 4, like scores were given. And the total score was 56. So less than 17 score is mild anxiety, 18 to 24 was considered as mild to moderate, and 25 to 30 as moderate anxiety, and 31 to 56 is severe anxiety score. And the data collection process, first the permission was taken from the principal, and data collection period was from 6 February 2022 to 6 March 2022. So after a brief self-introduction, first the purpose of study was explained, and informed consent was also obtained from all the students. And using the structured questionnaire, we collected all the baseline variables, and followed by administration of Hamilton Anxiety Rating Scale as a pre-test. Pre-test score was taken first. And the investigator administered structured anxiety management strategies. First, a breathing technique was taught to them, a deep breathing exercises, and followed by meditation. Totally, it took around 20 to 30 minutes. And the training session was given for 1 hour duration for 5 days. And the students were asked to practice this particular therapy for 30 minutes daily for 4 weeks. And they were asked to practice this daily, and also they were asked to maintain a meditation log so that they can note it down whether they have done or not daily. And the duration also they have to specify in the meditation log. And this was going on for 1 month. And after 1 month, again a post-test was conducted using the same scale. And all the subjects were comfortable, and they were they cooperated also well during the data collection period. And they also expressed their investigator also expressed her gratitude for their sincere cooperation. So the characteristics of the study population were 63.3% of students were in the age group of 21 years. And considering the gender, 93% were females. And regarding the residence, the 80% of students were residing in Panchayat. And 83.3% were belong to the nuclear family. Coming to the birth order, 53% were first born child. And regarding the intake of anxiolytic, 96.7% were not using any anxiolytic, and 83.3% of students have not attended the meditation training also session. And coming to the distribution of BSc Nursing students according to the level of anxiety, it was like this. The level of anxiety, about 18 students were having mild anxiety, and 7 were having mild to moderate, and moderate anxiety for 4 students. And out of 30, only 1 student had severe anxiety. And the analysis of effectiveness of structured anxiety management strategies on level of anxiety among BSc Nursing students. So coming to the mean and standard deviation of pre-test and post-test level of anxiety. The pre-test mean was 16.17 and post-test 7.70. And the paired t-test showed the value as 9.349 with p-value 0.0001 of significance. And this showed that structured anxiety management strategies were effective in reducing the level of anxiety among BSc Nursing students. So analysis of association between pre-test level of anxiety and socio-demographic variables. The study shows that there is an association between pre-test level of anxiety with intake of anxiolytics and previous meditation training. And there was no association found between other socioeconomic data like age, gender, religion, type of family, etc. And this study was consistent with another study finding also by Manan Singh S. Based on the effect of relaxation technique on first year BSc Nursing students. And here also the students were using some relaxation technique. And the study showed that there was a significant reduction in the level of academic stress and anxiety after the relaxation technique. So coming to the nursing implication, we can use this particular strategy in nursing education, as we can teach the students on the importance of structured anxiety management strategies, mainly on their level of anxiety. And in the nursing practice also, the nurses can organize some conferences, etc., on the importance of structured anxiety management strategies. So in the nursing administrators also can take part in making some protocols by for including this type of therapies or strategies for as an effective management in case of anxiety, depression, etc. So in nursing research also, we can utilize this research finding to focus on more and more evidence-based practice in implications. And the limitations of the study was, sample size was very less, 30 students were only there. And the observation was done for only for 4 weeks, as there were some time boundaries. And it was limited to 4th year BSc nursing students also. And the recommendation, a comparative study can be conducted in students with a low and high risk anxiety. A comparative study can be conducted by utilizing various interventions to assess the level of anxiety. An exploratory study, a qualitative study, can also be conducted to assess the barriers of implementing the structured anxiety management strategies. So the conclusion, based on the study findings, it is concluded that structured anxiety management strategies are effective in reducing the level of anxiety among BSc nursing students, which is significant and compared very well with other studies also. So daily practicing of structured anxiety management strategies are inexpensive method and also will be helpful in reducing the level of anxiety. So it leads the practitioner from mind to heart and to the integration of these two centers of human being. So meditation was basically used as a technique here. So this is a practice of intentionally spending time with our mind. So we can take time out of our busy days to sit, breathe, and try to remain focused on our breath. So it is a well-researched self-care method that can promote positive effects in the brain, mood, and emotional management. So these were the references. Thank you.
Thank you. Thank you for a wonderful presentation. Session just question to ask.
So, Anisha, I have one simple question from your side. As you have shown that there will be a meditation you have provided for the students to come out from the anxieties. So there are any specific techniques of meditation that you have been adopted for that, because it is not mentioned, because meditation, there is a different manners, different ways are there to conduct the meditations. First. Second, basically when we are performing such type of activities, are you licensed or are you have gone through the such meditation techniques before conducting of this? Because without knowing of that, if you are not expertise in that, it is difficult to get the result from there. So this is my question.
Thank you, sir, for the question. So this strategies mainly included some breathing exercise and meditation, and for that, sorry, sir. I have undergone 4 weeks practice for this meditation, for doing this. 4 weeks training I have taken, and also it is also there for me. It's been taught that relaxation technique only for this. For the study purpose only, I have learned this technique.
I have also one question, Anisha.
Yes, madam.
Why you added, what is the implication of to edit the birth order you added na birth order. So what are the implication this birth order? And this is my first question. And next question is also the you have a certified trainer of meditation. If you taking the certified meditation course.
I have undergone a short training only, madam, for this study purpose. For a brief 4-week period only, I have gone through. There is a center in Thrissur. So daily 1 hour, like only for that course, a brief short course only, madam.
And my first question is also the birth. What is the birth order? Birth order. What are the implications?
When we consider the children in the family, usually the first child will be mostly pampered, like.
Actually, this is our perception. Na? This is our perception. Not only same like that. So what are the implications, this birth orders, implication? If there is any implication regarding that, is the proven things are there? Is anything you can think about that?
Madam, please, madam, I didn't hear.
I mean, I want to know the birth order. Why are you adding the birth order? The implication of birth order?
Madam, being the first order child, they will be, I think they are more anxious. They will be more anxious than the second and third order. They will be having some like adjustment problem will be more in first-born child. Many studies are also shown like that. So that's why I put the question like that. First child always will be like that only. They will be getting more care from the parents. It feels like
such in studies also, no? This type. Okay.
Thank you.
Okay. Nice. I appreciate your research on structured anxiety management towards students. My question is, what kind of anxiety you comes under from final year students?
Regarding the anxiety, sir?
Yes, what kind of anxiety they have? Why did you choose final year BS nursing students? Is there any specific reason for that?
At that time, they are nearing to their university exam actually. So they were in the period of exam preparation, and they were having some tensions based on that. And after the corona, the COVID protocol and all the examination, I mean the etc. were changed a lot regarding the valuation and everything. During the COVID time, it was some liberal like. So they were
fine. Then
also.
Okay, fine. Then that should be mentioned as exam anxiety. You have, if it is mentioned in a level of anxiety, means there are many kind of anxieties out there. Here you have not mentioned the what is that anxiety.
Actually, my scale is including all type of questions. A generalized anxiety question is only it is there in Hamilton anxiety scale. So our sample, as they were nearing exams, so it was like useful, like this strategies.
Fine, but my perspective, the final year students will have less anxiety when compared to other years. That's what my question here. Because they have adapted. Because they are adapted towards the exams, everything from first year to third year. So in final year they have.
That is true, sir. But they are outgoing students now, so they are some more anxious. But will be their result. Final result is also a tension.
Okay, fine. Anyhow, thank you for your presentation. It's a wonderful session. I think if the next person is ready, then next person can start.
Thank you, sir. Thank you.
Thank you, Anisha.
Thank you, madam. Thank you, sir. Shall I leave?
Yes, you can.
Thank you, sir, for the opportunity. Thank you, madam.
So the next,
this is my request to the presenter. Kindly keep in the time also in their mind while you are presenting. The time already given for your presentation, so try to finish in that, because another presenter is also waiting for that.
Ma'am, shall I come inside, ma'am?
Ma'am, there is another participant before you, so can I call them?
No problem. I am ready. No problem.
Yeah, thank you so much. So the next participant is Dr. Shaktiya Shivakumar. Shaktiya.
Good morning, ma.
Good morning, ma'am. Ma'am, kindly please note every participant. The presentation time is for 10 minutes and 8 minutes for the presentation and the 2 minutes for discussion. Thank you. Ma'am, Dr. Shaktiya Shivakumar, you can start your presentation. Thank you.
Good morning to all. I am Dr. Shaktiya Shivakumar, Professor, Department of Obstetrics and Gynecology, Sri Sai Ram Homeopathy Medical College, Chennai. First of all, I thank you so much for giving this opportunity to present my paper. Today, I am going to present Emerging Trend of Artificial Intelligence in Obstetric and Gynecological Nursing Students. Now
sorry for the interruption, ma'am.
Sir?
Sorry for the interruption. Can you play the slides, ma'am? Can you put it in the slideshow?
Where I have some network issues. Is it okay, sir?
Actually, it is not in a slideshow mode. It is in a normal mode.
Okay.
Just go to the slideshow and play the slides. In the option, you go to slideshow. In above column, tab.
Below also there is a slideshow mode, just like a cup-like image there. You can click it.
Sir, now I am showing.
There you play, ma'am.
Is it right,
From
sir?
beginning. No, ma'am. From beginning, you click the from beginning.
This is my first slide, sir.
Oh, yes. No, ma'am. In that above boxes, there is the no from beginning. You click that from beginning.
Is it okay, sir?
No.
No, ma'am. It's not playing. So after playing the slideshow, there is some options coming. No,
you can click the slideshow. You can click the slideshow. Click the slideshow. Yeah. Then the left beginning from beginning. You can click the from beginning. Yeah. Then only it will be.
Okay. So let's start, ma'am.
Slideshow na every pattern just game.
Shall I start?
Yes, ma'am. Yes, you can start it.
Today I'm going to present emerging trend of artificial intelligence in obstetric gynecological nursing. Healthcare system play a major role in day-to-day our life. Healthcare has improved rapidly with more structural and transformational and revolutionary changes with artificial intelligence. AI will play a significant role in assisting healthcare teams such as doctors, nurses, and other healthcare team members by delivering more efficient patient care and quality patient outcome. Nurses are an integral part of healthcare team who collaborate doctors and other healthcare professionals to provide comprehensive patient care. It is essential for nurses to have a basic understanding of artificial intelligence concept, since the use of artificial intelligence technology in healthcare, including accelerating innovation, improving decision making, automating, speeding up process, and saving time and overall cost. Artificial intelligence is defined as a type of digital computer system that parallel the way the human brain processes information and is used for complex algorithm in order for machine to reason and perform cognitive function, including problem solving and decision making. Artificial intelligence tool used in nursing. Artificial intelligence tool include clinical decision support and mobile health and sensor-based technologies, visual recognition, machine learning, expert system, and virtual reality, voice assistant, and robotics. Clinical decision support tool like electronic health record, clinical practice guideline reports, which enhance the nurse's ability to make clinical making decision. When coupled with artificial intelligence, clinical decision support can offer prediction and suggestion with accuracy and specificity beyond our human capacity. Artificial intelligence potential in decision support include helping nurses advocate for patient care and identify care gaps and challenges. Mobile health and sensor-based technology. Mobile health and sensor-based technology provide opportunities to reshape the nurse's ability to deliver care and monitor the patient, particularly when limited resources and staffing. Mobile health technology such as smartphone apps and wearable technology help to manage chronic illness by receiving and sending data directly between the patient and providers, creating comprehensive picture of the dynamic state of patient health in their daily life. Voice assistant and robotics. Nurses uses voice assistant to identify the most relevant information for the movement such as time setter and reminder for nursing care takes. Robots with artificial intelligence interact with the elderly to combat loneliness.
Ma'am, I'm sorry to interrupt, but your slides are not moving. Can you change it to the other slide?
Ma'am, my slide is visible or not, ma'am?
Ma'am, your slide is visible, but it's not changing to the next one.
Sir, voice assistant.
Ma'am, otherwise click on second on the left corner, 2.
Is it right, ma'am?
No, ma'am. Ma'am, on the left corner, you see all the slides. Maybe you can click on the second slide, third slide.
Ma'am, is it working?
Ma'am, change it to next slide. No, ma'am, no. The next slide is not visible.
Actually, problem is your first slide is visible, ma'am. The next slides are not moving. Only your first slide is there.
Okay, sir.
Ma'am, if you're facing any issues, can you please share the slides to the email ID or the WhatsApp?
For you, I can send it, ma'am.
Yes, ma'am, you can send it to me, and in meantime, I will call the other participant.
Okay.
Will it be okay?
Okay, ma'am, no problem.
Thank you, ma'am. Ma'am, so the next participant is Dr. G. Karpagavalli.
Okay, ma'am.
Ma'am, can you stop your screen sharing? Yeah, thank you. Ma'am, Dr. G. Karpagavalli, you can share your screen and you can start your presentation.
Yes, ma'am. Good afternoon, sir. sir, and good afternoon, madams.
Good afternoon.
Slide is visible, sir.
Good afternoon.
Okay.
Yes, ma'am. Slide is visible.
Good afternoon, sir. I am Dr. Chikarpakavalli, sir. My study is comparative study to assess the impact of maternal anemia on placenta weight and fetal well-being in selected tertiary care hospital. It's in Chengalpattu district, which is in Tamil Nadu. Introduction, if you say, anemia is the most common problem among the pregnant women. It's a current scenario. In India, anemia during pregnancy is a significant public health problem, with 45.7% of pregnant women is in urban areas, as well as 52.1% in rural areas, having hemoglobin level of less than 11 grams per deciliter. Anemia is the underlying cause of contributing factor for 20 to 40% of maternal death in India. So, as a researcher, I want to do the retrospective study for a. Hello, ma'am. Shall I stop, ma'am?
Yes, please go ahead.
Okay. As a researcher, I want to do retrospective study for this anemia in our tie-up hospital, which is in government sector. Our research period is only 1 week only. In that period, for the retrospective purpose, we have taken the pregnant woman during the time of labor. We have collected the history, anemia history, and hemoglobin history from the patient case sheet. Objectives. It's coming. Objectives. It is to assess the placental weight and fetal well-being among anemic and non-anemic pregnant women. To compare the impact of maternal anemia on placental weight and fetal well-being among anemic and non-anemic pregnant women. Next one is to associate difference between placental weight and fetal well-being with selected demographic data of anemic and non-anemic pregnant women. Research hypothesis. There is a significant difference between placental weight of anemic and non-anemic pregnant women. Hypothesis 2. There is a significant difference between fetal well-being of anemic and non-anemic pregnant women. The third hypothesis, there is a significant association between placental weight, fetal well-being, and selected demographic variables among anemic and non-anemic pregnant women. Fourth hypothesis is there is a significant correlation between the placental weight and fetal weight among anemic and non-anemic pregnant women. Research methodology here. Quantitative exploratory research approach we have selected for this study. Research design and analytical cross-sectional design we have chosen. Here we have selected the population of pregnant women who is coming to the hospital. They have registered in the government sector for the delivery purpose. In that, we have selected the anemic as well as non-anemic mothers based on the hemoglobin level. In the anemic mothers, we have collected. In the anemic mothers, we have collected the fetal well-being. We have collected the fetal well-being as well as placental weight variables, measurements, as well as for non-anemic mothers also, we have collected the placental weight as well as fetal well-being measured from the case sheet alone. The pregnant mother data we have collected from the patient as well as from the family members. Research setting. The study was conducted in Cronbert Government Hospital, Cronbert, Chennai, Tamil Nadu, India. Population, target population, all pregnant women registered in government hospital for the perinatal management. Accessible population, all pregnant women who come to the labor ward for the regular delivery process in government hospital. We have selected the mother from the labor ward only. Dependent variables is placental weight and fetal well-being are the dependent variables. Maternal anemia and is the independent variable. Sample, pregnant women, 41 anemic as well as 41 non-anemic women who visited the labor ward. We have selected sample size 82 among the 82 women. pregnant woman, 41 anemic, 41 non-anemic mother we have selected for our study. Sampling technique. Structured interview schedule was used to collect the demographic data from the patient. Placenta as well as fetal characteristic also collected from the case sheet from the hospital. Description of the tool. A structured interview schedule is done. It 5 items for the elicits of the specific variables of placental characteristic. Placental characteristics such as completeness of the placenta, weight of the placenta, maternal surface, fetal surface, umbilical cord length, and cord insertion of the anemic and non-anemic mother was collected. 4 items of the fetal well-being are such as weight of the baby, head circumference of the baby, length of the baby, and Apgar score at 1 minute and 5 minutes. Data collection procedure. All the pregnant women who visited the Crumpet Government Hospital were selected for the study. High risk mother, we have exclusion criteria. Demographic variables are collected. Placental weight and fetal well-being variables are collected from mother's case sheet as well as from the demographic variables from the mother as well as patient relatives. Comparative analysis of the impact of maternal anemia on placental weight and fetal well-being is done. Then coming to the demographic data analysis, here frequency distribution of demographic characteristic of anemic, non-anemic mothers are here. We have selected the demographic data for age, trimester, gravida. Here age comprised of 18 to 35 years. Trimester, first trimester to third trimester. Gravida, G1, G2, G3, G4. Gravida we have selected. Gestational age 37 weeks to 40 weeks of gestation. Then hemoglobin level less than 8 gram deciliter, above 12 gram deciliter. For the anemic as well as non-anemic mother, we have selected all these information as demographic variables. So coming to the comparison of mean, standard deviation and independent t-test of demographic characteristics of anemic, non-anemic pregnant women. It shows that only the pregnant women in both the groups were considered as an equivalent group with record of the age and weeks of gestation. That is non-significant. The pregnant women in both the groups were considered as an equivalent group with regard to the age and the weeks of gestation. Hemoglobin level alone is significant here. There is a variation among the pregnant as well as non-pregnant, anemic as well as non-anemic women in the hemoglobin level. This picture depicts the hemoglobin level of the anemic as well as non-anemic woman. This one is the anemic woman hemoglobin level. This one is non-anemic woman hemoglobin level which has taken. The comparison of mean, standard deviation and independent t-test of placental characteristic of the women's. Here, when you are taking this, the pregnant women in both the groups are equivalent in nature in the placental weight as well as umbilical cord length. It indicates that a homogeneous group was taken up in the study to compare the impact of anemia among the women. Non-significant here shows the equivalency among the women. This picture depicts the same. Then comparison of mean, standard deviation and independent t-test of fetal characteristic. Here fetal characteristic of baby weight, length, head circumference, Apgar score 1 and 5 minutes also non-significance. It shows that we have taken both the groups are homogeneous group among the mother for the study. This picture depicts the same of the fetal characteristic. Next, association of placental weight and fetal weight among the anemic and non-anemic. Here, anemic mothers, anemic mother placental weight, we are comparing with the fetal weight. Anemic mother fetal weight is not significant. Non-anemic mother fetal weight, placental weight as well as fetal weight is significant at 0.024 level. less than P 0.05 level. Chi-square test reveals significant association between the placental weight and birth weight of the newborn among the non-anemic birth weight of the newborn among the non-anemic pregnant women, as they were statistically significant at the level of P less than 0.05 level. Next one is this one is association of the placental weight, association of the placental weight as well as fetal here weight. Here we are taking the this one is non-anemic. So here non-anemic woman is non-significant. This one is significance at 0.24 level. Comparison of the frequency distribution. This is for the depiction of the difference between the placental weight as well as birth weight of the anemic as well as non-anemic woman. Now we are going to see the correlation of placental weight and birth weight among the anemic as well as non-anemic pregnant women. Comparison of placental weight as well as fetal weight. It shows anemic woman is not significant, non-anemic woman is significant. Here, pregnant woman, which indicates that adequate weight gain of the placenta has direct effect on the birth weight of the newborn, and vice versa among the anemic as well as non-anemic pregnant women. Same thing only I have here depicted. Significant positive correlation less than P 0.05 level exists between the placental weight and fetal weight is among the women, indicates the normal level of hemoglobin was significantly effective in improving the placental weight and fetal weight among the non-anemic pregnant women. Next one is which correlation exists between placental weight and fetal weight among anemic mother, indicates that abnormal level of the hemoglobin was not significantly effective in improving the placental weight and fetal weight among the anemic pregnant women. Coming to the discussion here, first objective was to assess the placental weight and fetal weight. Almost 53.7% of non-anemic mothers had greater than 12 gram deciliter hemoglobin levels, while at least 7.3% of anemic mother had greater than 12 gram deciliter hemoglobin level. There was a significant difference between the hemoglobin levels among the anemic as well as non-anemic. The same supportive study depicted on the right side, supporting the findings, current study finding. Second objective, to compare the significant difference between the placental weight as well as placenta weight. Independent sample t-test on comparing the two group of placental weight and umbilical cord length revealed that there was no significant difference in the mean placental weight among the anemic and non-anemic pregnant women. It indicates homogeneous group was taken for the study. Same supporting finding, we have taken it in the right side. Third objective, to compare the significant difference between fetal well-being among the anemic, non-anemic. The independent sample t-test comparing the two group fetal characteristic as well as is among the anemic and non-anemic women is no significance among that woman here. Here in the pregnant woman, both the groups were considered the equivalent group. Non-significance here, we have taken it in the equivalency. For the sake of homogeneous group, we are showing this. Same supportive finding we have taken here. Then correlation, the positive correlation that exists between the placental weight and fetal well-being among the anemic pregnant women, 0.37, was not significant at P 0.05, which indicates the abnormal level of the hemoglobin was not significantly effective in improving the placental weight and fetal weight. This is the main thing for the study. When the mother is having higher level of hemoglobin, the hemoglobin serves the purpose of increasing the placental weight. When the placental weight is increased, thereby the fetal weight also will be increased. Here, next p-value 0.05 is significant among non-anemic mother in the level. It indicates that normal level of hemoglobin was significantly effective in improving the not normal level, improving the placental weight as well as fetal weight among the non-anemic pregnant women. Same supportive study we have given here. Conclusion, the study concludes that the level of hemoglobin shows a positive correlation and significant association between the placental weight and fetal weight, which indicates that maintenance of normal hemoglobin level is essential for the normal growth and development of the placenta, directly which influences the growth of the baby. In case that this scenario is not met, it is evident that there is a vice versa effect on the fetal weight. Identification and intervention goes hand in hand. Thus, in order to get complete control of anemia, the explorative study on the impact of anemia on the well-being of the fetus is vital. If somebody is doing the study, otherwise in future also, we are ready to do this study on the as a exploratory study. Early detection and the effective management of the risk factors can reduce the preventable complications such as small for gestational age, low birth weight babies, as sequential complication can be avoided. Thank you, ma'am. Thank you, sir, and thank you, ma'am.
Thank you, ma'am. Section chairs, do you have any questions?
This study is, I think, is a population. You will giving the sampling technique. You will show me the sampling technique, please.
Yes, ma'am. Yes, ma'am. I will show. Sampling technique is there. Structure sampling technique, structure interview schedule. Random sampling technique we have used, ma'am, here. So random sampling technique. I have not it's missed. I have typed it, it's missed. Random sampling technique we have used, ma'am.
You are taking the random sampling technique.
Yes, ma'am. Yes, ma'am. Whoever is coming to the labor room, who is coming under our inclusion criteria, we have selected that methods, ma'am.
Okay. I have no question now. Any other judges have question? Then?
No, from my side, it's okay. Dr. Arun, sir, you can go through.
Good afternoon, ma'am. It was a good research. It was a good research done on pregnant mothers. I appreciate your concern. Only thing I also have the doubt that sampling technique was not mentioned there.
That's what I have typed it that okay, sir. Same thing I have repeated, copied here.
Okay. In random sampling, what type of random sampling we have used?
Simple random sampling.
Simple random sampling.
Yes, sir. Whoever is coming to the labor room, who is coming under our inclusion criteria, that mothers alone we have taken. We have avoided the high risk mother. We have taken the mother, anemic as well as non-anemic mothers. Based on that only we have selected the mother, sir, who is in the perinatal period.
Then it will be considered a convenient sampling technique. If you are selecting as a random sampling from 100,
random convenient sampling. Okay.
From 100, if you selected 82 by lottery method or some should be used.
Okay, sir.
If you are selecting all the participants, then will be considered the convenient sampling technique.
Okay, sir. Thank you. Okay, sir. Okay, sir.
It's a good study. It's a good study. It's a good study.
Thank you, ma'am. Thank you so much.
The intention of conducting study was very good.
Yeah. Only the sampling technique you should mention it.
Yes, ma'am. That I missed it.
That is. Okay.
Thank you, ma'am. Thank you, sir. Thank you so much for the suggestion, sir.
Thank you.
Thank you, ma'am. So I'm going with the next participant, Dr. Shakti Shivakumar.
Shall I start, ma'am?
Yes, ma'am.
Yes, ma'am. Yes.
Yes, ma'am.
Sorry, sir. Once again, I will start. Emerging trend of artificial intelligence in obstetric and gynecological nursing. Next. Healthcare system play a major role in day-to-day our life. Healthcare has improved rapidly with more structural and transformational and revolutionary changes with artificial intelligence. Artificial intelligence will play a significant role in assisting healthcare teams such doctors, nurses, and other healthcare team members by delivering more efficient patient care and quality patient outcome. Nurses are an integral part of healthcare team to collaborate nurses and other healthcare professionals to provide comprehensive patient care. It is an essential to have a basic understanding of artificial intelligence concept, since the uses of artificial intelligence technology in healthcare include accelerating innovations, improving decision making, and automating and speeding up process, saving overall cost. Next. In nursing practice, the clinical information was very vast and complex, constantly changing, and required a refined skill set for practical application during patient care. So high quality of nursing care was required for instant processing and decision action when interacting with abundant clinical data. Artificial intelligence is growing in obstetric and gynecological nursing fields also. In obstetric gynecological nursing, artificial intelligence tools include clinical decision support, mobile health, and sensor-based technologies. Voice assistant and robotic was used to interpret fetal heart rate and cardiography to aid in the detection of preterm labor, pregnancy, and complication. In vitro fertilization, gynecological surgery, screening cervical and ovarian cancer, screening for gestational diabetes mellitus, and review discrepancy in its interpretation between nurses to reduce the maternal and fetal morbidity and mortality. Artificial intelligence is defined as a type of digital computer system that parallel the way human brain process information and is used for complex algorithm in order for machine to reason and perform cognitive function, including problem solving and decision making. Artificial intelligence tool used in nursing. Artificial tool include clinical decision support, mobile health, sensor-based technologies, visual recognition, machine learning, expert system, and virtual reality, voice assistant, and robotics. What do you mean by clinical decision support? Clinical decision support tools like electronic health record, clinical practice guidelines, and report, which enhance nurses' ability to make clinical decisions. When coupled with artificial intelligence, clinical decision support can offer prediction and suggestion with accuracy and specificity beyond human capacity. Artificial intelligence potential in decision support include helping nurses to advocate for patients and identify care gaps and challenges. Mobile health and sensor-based technologies. Mobile health and sensor-based technology provide opportunity to reshape the nurse's ability to deliver care and monitor patients, particularly when limited resources and staffing. Mobile health technology such as smartphone apps and wearable technology help to manage chronic illness by receiving and sending data directly between the patient and provider, creating comprehensive picture of the dynamic state of patient health in their daily life. Voice assistant and robotics. Nurses use voice assistant to identify the most relevant information for the movement, such as time setter and reminder for nursing care takes. Robots with artificial intelligence interact with the elderly to combat loneliness and social isolation, and also are capable for serving, fetching, communicating, and offering emotional comfort. Nurses have frequently interacted remotely with the patient via voice assistant robot and to reduce the personal protective equipment using during repeated exposure with infected patient. Those technologies also may reduce the nurses' time spent for data collection and documentation during each patient visit. Visual recognition. nurses use computed physical images and streamed videos to identify, diagnose the condition, and assessing skin and wound integrity following obstetric and gynecological surgery, monitor the activity of fetus inside the uterus. Next. Machine learning to initiate and complete the task automatically by scheduling follow-up appointment to patient and also sending the result to healthcare team member who need to be notified. Expert system to solve the complex problem by reasoning through multiple sources for decision making as accurate and quick than human expert. It can anticipate the risk area of patients such as fall, sepsis, and readmission, and predict the length stay in the hospital and cost care for the patient. Virtual reality to computer generated image environment or experience to interact with the seeming real way. Virtual reality. This computer generated image environment or experience interact with the seeming real way. It is used in nursing education to stimulator for mock learning exercises like basic life support. Role of artificial intelligence in obstetrics and gynecological field for fetal heart monitoring. Artificial intelligence used to monitor the fetal heart rate help to decrease the discrepancy between the different nurses' interpretation during intrapartum period, which provide more reliable and replicable output, thereby reduce the perinatal and maternal complication. The application of artificial intelligence in fetal heart rate reading help nurses in interpreting and decision making and decrease the burden. Artificial intelligence technology could be used for outpatient care in the form of home monitoring that can adequately prevent the surveillance of high-risk patients. It provides warning system that inform the patient of danger in fetal heart rate reading and signal them to notify the nurses to decide and further care according to in-home in artificial intelligence analysis. Next. Ma'am, next. Ma'am. Ma'am, shall we show the previous slide, ma'am? Predicting preterm labor during pregnancy, artificial intelligence used to identify the presence of metabolic in amniotic fluid, which is responsible for preterm labor. It is also used to improve the accuracy and predictive value of artificial intelligence used in the in vitro fertilization, which include prediction of ovum and semen quality, sperm detection and selection for assisted reproductive technology like ART, embryo selection, which lead to increased success rate of pregnancy and result in health and live birth. Gynecological surgery, artificial intelligence used in gynecological surgery by providing better imaging before and after. During surgery, artificial intelligence help to decrease operative time and increase accuracy with the subsequent prevent operative complication. Screening of cervical and ovarian cancer, artificial intelligence used in the elderly early detection of malignancy in reproductive system by measuring microRNAs from the serum sample, which help to prompt treatment and better prognosis. AI technology based on deep learning algorithm used to intelligent recognition of medical images, which enable automatic diagnosis, testing, identifying lesions.
Ma'am, excuse me. Ma'am, you have only 1 minute left.
Okay. Shall we show the benefit of AI? To reduce the perinatal benefits of artificial intelligence, reduce the perinatal and maternal complication of morbidity, to get more reliable and replicable output, to save the time, to avoid unnecessary walk for the hospital for minor ailments, to avoid excessive burden, physical burden, especially for nursing, to provide specialized based care, to avoid misguidance, help in appropriate decision making of quality of patient care, help in early detection of diseases like cancer. Next. and also having a limitation of artificial intelligence, lack of human touch and lack of own creativity, lack of common sense, nurses' ability may diminish, wrong handling causes destruction. Now, can we show the last? Conclusion, the innovation of artificial intelligence in healthcare provide better future in obstetric and gynecological nursing field. AI technology help the nurses to have better data-driven decision, increase disease diagnosis efficacy, monitoring and caring the patient efficiently and accurately, integrate information, reduce unnecessary hospital visit to create time-saving administrative duties, AI decision engine that can exponentially increase effectiveness and efficacy of nursing care delivery system. Artificial intelligence cannot replace the nurses in obstetrical and gynecological area, but can create wonders through artificial intelligence. Thank you, ma'am.
Thank you, ma'am. The section chairs can ask their questions.
Thank you.
It's a good session about new innovation techniques. AI technology is doing wonders everywhere, and all aspect of not even healthcare, all the departments, all the areas now, artificial intelligence plays a major role. So we'll see what future will be in nursing with AI technology. Thank you.
It's also just like Arul sir tell that is a new concept, and artificial intelligence is different things in nursing care. I don't. It's my personal views is how can we help the patient care about the artificial intelligence. So this is otherwise the study is good, but some this is just like an article type. This is not a proper research. I mean, findings and everything is there. So it's just like an article type, and benefits and everything is in a writing there. So it's a good thing. Thank you.
Thank you, sir. Thank you so much for giving this opportunity. Thank you.
Thank you, ma'am. So I call the next presenter, Akriti from Zhengzhou University, China.
Yeah, I have one thing. Please mention the time. Time is exceed, na? So please mention the time also. They have only 10 minutes, na?
Yes, ma'am, for sure. The presenter,
because they know that the time is also very important thing. So please.
Yes, ma'am, for sure. The participant, kindly please keep in the mind the presentation time is for only 10 minutes and 8 minutes for the presentation and the 2 minutes for the discussion. Thank you. And now, Akriti, you can present it.
Thank you so much, all the respected chairpersons, all the friends. I'm Akriti. I'm actually from Nepal. I'm studying PhD from China, Zhengzhou University. Sorry for my voice. I'm not well today, that's why, but still, I'll try my best. I'm very lucky to present my small work here. Mental health, depression, anxiety, and quality of life in hemodialysis patients. A review. The examination of depression and its implications for quality of life
Sorry
among
for the
individuals.
interruption.
Yeah.
Sorry for the interruption, ma'am. Your slide is not visible.
Not visible, sorry. It's already been shared. Okay, let me check.
Kindly check, ma'am. It is not playing.
Oh, are you able to see?
No, your slide is not.
Your slide is not visible. You can
right now,
share the screen.
is it okay?
No.
No.
Now it's visible.
Now the slide is open.
Open, but you can
put it in the play mode.
Okay.
Yeah. Yes.
Slideshow. Yeah.
Thank you so much. Okay, I'll continue. So the examination of depression and its implications for quality of life among individuals with CKD constitute a vital and multifaceted areas of investigations. Numerous studies have consistently underscored high prevalence of depression among CKD patients compared to general population, attributing this phenomenon to multifactorial challenges associated with chronic illness. Depression in the context of CKD profoundly affects various dimensions of an individual's well-being, leading to compromised physical functioning, increased fatigue, cognitive impairment, and disruptions in sleep patterns. Importantly, this emotional burden can further compound the complexities of managing a CKD, chronic conditions like CKD. The presence of depressions in CKD patients not only hampers their adherence to treatment regimens, but also contributes to a decline in overall quality of life. Holistic care approaches that encompass mental health assessments, psychological interventions, strategies to enhance overall well-being become imperative in the comprehensive management of depression with CKD context. By adding both physical and psychological aspects of CKD, healthcare practitioners can strive to optimize patients' outcome and improve overall quality of life for individuals navigating the challenges of CKD. The aim of study is to investigate the impact of depression, anxiety, and quality of life in as hemodialysis patients with CKD. The study seeks to examine how the presence of depression symptoms affects various aspects of patients' well-being, including physical, psychological, and social dimensions. By understanding the associations between depression and quality of life in this specific patients' populations, healthcare professionals can better identify and address the needs of individuals undergoing hemodialysis. This knowledge is essential for developing targeted interventions and support strategies to improve overall well being and enhance the quality of life for CKD patients on hemodialysis. The findings from this review could have significant implications for patients' care and may contribute to development of more comprehensive and effective management approaches for vulnerable populations. The relevancy of research. The relevancy of research lies in its profound impact on addressing the psychological well-being and overall quality of life individuals undergoing hemodialysis treatment. By systematically reviewing and conducting analysis of existing studies, this research sheds lights on critical connections between depression and quality of life experienced by hemodialysis patients. By identifying the prevalence and impacts of patients on quality of life, this research it underscores the need for integrated approaches that consider not only the physical aspects of treatment, but also the psychological and emotional well-being of individuals undergoing hemodialysis. Furthermore, the systematic review and meta-analysis contribute to a deeper understanding of interplay between depression and overall quality of life among SDP. This comprehensive approach can lead to the development of targeted intervention support systems, holistic care strategies that address the multifaceted challenges faced by these patients, ultimately improving their mental well-being and enhancing their overall quality of life during the course of hemodialysis treatment. So this is the source strategy which I did during the reviewing this topic. So I have used a ProQuest and PubMed, Leo, and Lilacs and BESS to identify all the related articles. Then I have screened it, and then finally I have used 37 studies for my study. In the statistical analysis of the collected data, the gender distribution which I found was the chronic kidney patient, male patients surpasses that of females by 12%. The total participant pool amalgamated from the 20 articles encompassing both review and research articles specific to CKD accounts for 5,209 individuals. Further insights into the methodology employed in these studies, with a particular emphasis on the prevalence of cross-sectional approaches, are elucidated in greater detail. This analysis contributes to a comprehensive understanding of gender representation and research methods utilized in the context of CKD studies. The average age of participants in the collected reports of the review were of 45 to 60 years, with average age 57 years. The understanding demographic profiles of participants in the reviewed studies, particularly focusing on their age distribution, becomes more prevalent with the advancing age, and individuals in their late 40s and 60s are considered to be at higher risk. By focusing on this age group, a population that is more susceptible to CKD, allowing for targeted examinations of factors related to disease within demographic that commonly experiences its onset. Out of the 20 papers selected for a systematic review, the majority employed a cross-sectional research design for these studies. Among 20 research articles, 13 utilized cross-sectional methods, 2 employed standardized instruments, and the remaining studies utilized various single methods. This pattern underscores the prevalence and acceptance of cross-sectional methods as well as well-established and preferred approach for research within nursing field. The preeminence of cross-sectional designs in the selected paper suggests their effectiveness and suitability for studying phenomena in nursing, emphasizing their widespread utilization in nursing research. In the context of systematic review focused on investigating depressions among participants, the reported p-values ranging from 0.001 to 0.1 suggest a statistically significant association between depression and participants under study. The range of p-values indicates varying degrees of evidence against null hypothesis, with the lower values such as 0.001 pointing to stronger statistical significance. Moreover, unanimity among participants in acknowledging the impact of depression and quality of life underscores the practical significance of the finding. The collective agreements among participants aligns with the statistical evidence, reinforcing the idea that depression is a noteworthy factor affecting the quality of life in a studied population. It contributes to the scientific understanding of the relationship between depression and quality of life, but also emphasize the real-world implications and importance of addressing mental health concerns for overall well-being. Assessing depression scores on a scale of 0 to 100% in the review reveals that researchers employed diverse tools, utilized various models to compute p-values and quantify depression levels. The findings indicate that depression levels fluctuated in conjunction with the p-values across multiple studies.
Excuse me,
This
Akriti.
suggests a dynamic, yeah?
You have only 1 minute left.
Okay. So here I would like to provide the conclusion of my study, reviewed article. The reviewed study shed light on the prevalence and impact of depression and mental health conditions on quality of life with CKD. The findings consistently highlight the significant association between depression and mental health with overall quality of life of hemodialysis patients. Depression was reported in a considerable proportion of SDP, ranging from 5.52% to 76%, while mental health scores varied across studies but were generally associated with patient well-being. The impact of depression and mental health on quality of life was consistently demonstrated in majority of studies with significant p-values indicating a robust relationship. However, some studies had no significant p-values, possibly due to smaller sample size or different study population. Anxiety, though less commonly studied, was also found to have a significant association with quality of life in some investigation. Further research in the area may provide a more comprehensive understanding of the impact of anxiety on the well-being of SDP. Many studies did not explore the interplay between depression, anxiety, and mental health, which could provide a more comprehensive understanding of patients' mental well-being. Additionally, some studies had relatively small sample size, limiting the generalizability of their findings. The evidence suggests that addressing depression and mental health issues is crucial in improving overall well-being and quality of life of the patients with CKD. Healthcare providers should consider implementing interventions that target mental health conditions to enhance the quality of life with the patients of CKD. Further research with larger and more diverse samples is needed to explore the complex relationship between depression, anxiety, mental health, and quality of life of hemodialysis patients more comprehensively. This additional knowledge could provide valuable insights and guide effective strategies to improve overall well-being of SDP. So, here I come to the end of my presentation. Anything, please?
Thank you, Akriti.
Yeah.
Now for the discussion time. Section chair, do you have any questions?
Thank you for your presentation. Actually, this systemic review is done with the 20 articles, right? From different 20 research publications, right?
I'm sorry, sir. I'm not able to hear you, sir.
Actually, the systemic review is conducted from the 20 different articles.
Yes, sir. Yes, sir.
Yes. Thanks. So, in the aspect of mental health depression among hemodialysis patients were literally high among other patients. So, it's a good way to identify that depression among the hemodialysis patient is high. So, further than some interventions can be provided for the same population. So, that can be planned in the future. Okay, thank you for your valuable presentation.
Thank you, sir. Thank you.
Yeah. Akriti, it was
Yes,
really
sir.
very nice research that you have done. And because in these days, CKD is a very common problem associated with the population, and they have undergo for these hemodialysis that procedures, and they will really produce a severe stress to them, because even though they know that there is no completely outcome and they are not going to be cured with that. So it is good, and I think you have given a good that key. We have to be planned for the specific interventions to come out from the mental problems, especially depression. For that, good, congratulations, very nice.
Thank you, sir. Thank you, sir.
Congratulations, Akriti. I just know the sample and sampling technique. Sample. What are the sample we have?
Actually,
Sample and
I have
sampling technique.
I have collected all the samples. I have seen, I have checked and overanalyzed. Generally, I have dictated in this review, ma'am, not a specific sampling. In different papers, they have used different sampling techniques. So I have just generalized about these are the samples and age group like that, ma'am.
Okay, and tools. You use tools, no? You check the whenever you check the depressions, you use tools.
Yeah. So in various studies, they have used this DAS, depression anxiety scales, and even they have used the psychological adaptation tool, cognitive flexibility, inventory skills, social support survey instrument. So many they have used different standardized tools.
So otherwise, it's a good study, and I think it's needed also further review also needed. Okay.
Yes, ma'am. Yes.
Okay. Thank you. Thank you.
Okay. Thank you, ma'am. Thank you.
Thank you, Akriti. Section sir. So the next participant is Shweta Javali, but she has sent a video presentation. So will it be okay if I play it on the last?
Yes, when those are available, I can present.
Those are available. You can first proceed, then only we will see the videos. I think I go with this. So please, those who are available.
Yeah, thank you. So I go with the next participant is Josely Monica Raj from the Tajur College of Nursing, India.
Good afternoon, ma'am.
Good afternoon, ma'am. Yes, ma'am, you can present your topic.
Yes, ma'am. 1 minute. One minute. Is the slide visible?
Yes, ma'am. You can make it to slide share.
Okay.
Yes, ma'am. Yes.
Yes, ma'am. Yes, ma'am. We can start.
The comparative, good afternoon all. My topic is a comparative study to assess the determinants of maternal anemia that affects the birth weight among anemic and non-anemic pregnant women. So the background of the study, anemia is the most preventable medical condition with hemoglobin level less than 11 grams per deciliter. And anemia during pregnancy is the main risk for intrauterine growth retardation, low birth weight, high maternal and child mortality, and premature delivery. Understanding the determinants of maternal anemia is essential to boost the prophylactic and the therapeutic management during pregnancy. Globally, we see that 38.2% of pregnant women are being affected with anemia, and in India, 45.7% of pregnant women are affected in urban, and 52.1% are affected in rural area. And anemia is the underlying cause for 20 to 40% of maternal death in India and 80% of maternal death in South Asia. Not only affecting the mother, it also affects the fetus. The studies on determinants of maternal anemia has been scarce, and therefore it is essential to study the determinants of anemia during pregnancy and its impact on the birth weight to formulate a realistic guidelines to treat and prevent anemia during pregnancy. So with this aspect, the study was taken up on comparative study to assess the determinants of maternal anemia that affects birth weight among anemic and non-anemic pregnant women in the selected tertiary care hospital, Chengalpattu district, Tamil Nadu, India. The objective of the study was to compare the determinants of the maternal anemia and to assess the impact of maternal anemia on the birth weight and to associate maternal anemia with the birth weight among anemic and non-anemic pregnant women. Hypothesis: the significant impact of treatment of given to the maternal anemia among anemic and non-anemic pregnant women, and significant association between the determinants of maternal anemia with birth weight. Operational definition: maternal anemia, it refers to the condition in which the number of red blood cells or the oxygen carrying capacity is insufficient, that is less than 11 grams per deciliter. And birth weight, here in the study, 2.5 kg to 3.5 kg was considered as a normal birth weight. The conceptual framework taken up for the study, Ernestine Widenberg Helting Heart of Clinical Nursing Theory was taken up as a conceptual framework. It was setting was from GH Hospital, and a goal was to assess the impact of maternal anemia on the fetal well-being. The approach was quantitative explorative research approach was taken, an analytical cross-sectional research study was done, and setting was labor room, and population was all pregnant women who had come to the labor room for their delivery, and the sample size is 82, and the sampling technique was convenient sampling technique who did not have inclusive and high risk criteria. All pregnant women who took their prenatal care, the regular treatment was taken up for the study, and maternal anemia was a high risk which was taken up for the study. All the other high risk groups were not taken up, and the people who were willing to participate in the study were taken up, and those who had critical conditions and all the critically ill people were excluded. Instruments, like it was a structured interview schedule, demographic data was collected, and 5 items on the anemic characteristics was collected, and 1 birth weight of the baby was collected. The data collection process, first all the pregnant women in the Chengalpattu hospital was taken up, and from that maternal anemia pregnant women with maternal anemia was taken, and demographic and anemic variables were collected, and the birth weight of the neonate was collected. And comparative analysis of the impact of maternal anemia on birth weight among the anemic and non-anemic pregnant women was done. Ethical consideration was taken up. Approval was got from the college and from the Chengalpattu government hospital. And consent was taken from mothers who had come into the labor room for their delivery purpose. Demographic data, comparison of the frequency distribution of the age among the anemic and non-anemic pregnant women, and the most of the pregnant women, the major portion of the pregnant women were 21 to 25 years of age in anemic and the non-anemic group. And in the Gravida, most of the pregnant women were in Gravida 1 in non-anemic group, whereas equal Gravida 1 and Gravida 2 people were there in the anemic group. And in the non-anemic parameter, most of the people were from the parity, had the parity 1 and live birth 1 baby. And whereas in anemic group, it was both parity 1 and 2 and live birth 2 was also there. Comparison of the frequency distribution of the number of abortions, like most of them did not have any history of abortion, and most of them belong to 39 weeks of gestation, and they were belonging to the nuclear family, and most of them had undergone SSLC, that is the basic education, schooling education, and more number of people were seen to be undergraduates when it came to non-anemic women group when compared to the anemic women group. And most of them had the income of 10,000, and they are most of the pregnant women who had come for the delivery was unemployed, they were housewives and non-vegetarian people. Anemic characteristics, it was observed that in anemia, maternal anemia, most of them who had maternal anemia were anemic in the past. So 24 out of the whole thing, that is around 58% of the people had anemia in the past. And treatment given for anemia in the current scenario from the first trimester to the last trimester was oral iron supplementation, IV iron supplementation, a combination of IV and oral iron supplementation, and blood transfusion was given. And there were few people who took all the four, all the three. Whereas in non-anemic group, only oral iron supplementation and IV iron supplementation was needed. And the treatment was started from the first trimester in almost all of the non-anemic pregnant women, whereas anemic pregnant women, few of them had come in later, and so the second trimester, they have also started treatment from the second trimester. And comparison the frequency distribution of the level of hemoglobin levels, it was observed that anemic patients had lower hemoglobin level when compared to the non-anemic people. And the mean hemoglobin level was also compared with the error bar of 95% of significance. And the frequency distribution of levels of hemoglobin level at the first trimester, when the patient came in first, and at the third trimester was compared, and treatment modules had significantly improved the hemoglobin level of.
Sorry to interrupt. 1 minute more.
Has significantly helped them to improve their hemoglobin level. This is again the mean which shows the significant improvement of the hemoglobin level. The independent features shows that effectively the hemoglobin level has improved after the treatment. The paired features for the first trimester and the third trimester was observed, and in anemic and non-anemic group, the treatment has adequately improved the hemoglobin levels. The newborn characteristics was the weight of the baby was taken, and it was obviously seen that non-anemic babies were adequately weight gain was there when compared to the anemic babies. Again, the mean compared with the significance level of 95% significance. And on observation, like the oral and the IV and the blood transfusion that has been given was significantly influencing the anemic women and the newborn babies to have adequate weight gain. The other factors that influenced were the age, the gravida, and the parity, and the live birth. The major finding, the statistically significant finding of the study concludes that the independent features and the paired features of the maternal anemia at the first and the third trimester indicates the hypothesis that there is significant impact of treatment given to the pregnant women among anemic and non-anemic groups. And the Chi-square reveals a statistically significant association between the treatment methods adopted by the pregnant women and such as oral iron supplementation, IV iron therapy, and blood transfusion at P less than 0.001, which indicates that the treatment taken by the anemic women had a significant association with the birth weight. And there are, on discussion, there are studies given by Sushmita, Shaha, and Evangeline, and Joni Priya, who have also read about done investigations on maternal anemia. And the limitations of the studies was time series studies could not be done because the study duration was short, and it was a prospective data could have been collected because the time period was cut. Retrospectively, the first trimester hemoglobin levels were collected, and recommendation time series studies and longitudinal studies can be done, and larger sample can be taken up, and a comparative study with the rural and urban population can be done, and exploratory study based on the barriers in adequate maintenance of hemoglobin level can be also. On conclusion, early detection and effective management of the risk factors can reduce the preventable complications such as small for gestational babies, low birth weight babies, and possible maternal and fetal complications. Long-term positive approach towards anemia is the need of the hour. The management of anemia must begin before conception to have the maximum benefits of the treatment modalities. Appropriate assessment and holistic care are the key components of prevention of prenatal anemia. These are the references. Thank you.
Thank you, ma'am.
Yeah.
Now the time is for discussion.
Yes. Madam, I have a questions regarding that key. This is the comparative study, and you can see the determinants, na? Determinants.
Yes.
Okay. So previous also one Dr. G. Karavali is presented this comparative study also. And this is this. This is the impact of the study. So
yes,
impact.
Yes,
I think. And this is the determinants. So what?
I'm not able to hear you, ma'am. I'm not able to hear you, ma'am. Ma'am?
There might be a network issue. Ma'am, are you there?
Okay, Jocelyn, my question is,
Yes, sir.
how you have maintained the homogeneity in the samples? As you have taken the two groups, that is the non-pregnant and the non-pregnant women.
The chi-square testing was done, sir, which revealed that homogeneous group was taken. Chi-square of the age of anemic and non-anemic group was correlated, and it was not significant. And similarly, all the determinants were taken, and the chi-square was compared between the anemic and non-anemic group, and it was all non-significant. And that's how the homogeneity of the group was identified, and it was a homogeneous group that was taken up for the study.
Okay.
I don't have any questions, so yes.
Okay, thank you, ma'am.
Thank you, sir. Thank you, ma'am.
Thank you, ma'am. So the next participant is Sumaya Jamaluddin from International Islamic University, Malaysia.
Oh, no.
Sumaya?
Yes. Hi, everyone. Can you hear me?
Yes, you can share your screen and you can start your presentation.
Okay. Can you see my screen?
Yes, the screen is visible. Just play the slide.
Okay, so my study is about subscale component in the structured nursing clinical scale assessment on
The
aseptic
slide is not
procedure.
playing.
Sorry,
The slides are not playing. It's in
not playing. Yeah, stop again.
How about now? Can you see?
Slide is visible, ma'am. You just put it into the slide summary.
Not moving? Is it moving?
Yeah.
Can you see?
Yes, yes, yes. We will.
Okay.
Sorry,
So
I disconnected. Some technical glitches are there. So this is another topic. Okay. Sorry for it.
So my study is about soft skill component in the structured clinical skill assessment on the aseptic procedure. A study is, the method is about the clinical audit. So why this study is conducted? If we look at into the background of the study, aseptic technique is a fundamental skill that all nursing students are required to learn internationally. And nursing academies play a crucial role in cultivating appropriate attitudes toward aseptic technique among nursing students. And nurses are required to possess not only the technical skill, but also soft skill to handle the patient care in the clinical setting. And then if we see the problem statement, the healthcare-associated infection, or it is commonly known as the ACAI, are the most frequently reported adverse events in the clinic in the current healthcare delivery system. If the patient is admitted to the hospital, 100 patients, we can see like 7 to 10 out of the 100, they will get this ACAI infection. So nursing students need to know the consequences of breaking the sterility technique in the aseptic procedure. So not only that, they also should be assessed on their competency scale in this particular field, so that the aseptic procedure is one of the core procedures for the undergraduate nursing program. So if we look at into the assessment part, because usually for the undergraduate nursing program, we use the OSCE or the Structured Clinical Skill Assessment, but most of the time our checklists are given more focus on the technical skills, and the soft skill part is we cannot see clearly in our OSCE checklist. So what is the soft skill and why it is important? Soft skill in nursing is referred to the interpersonal and the behavioral attribute that enable nurses to effectively interact with the patient, their family, and other healthcare professionals. So these skills are often intangible and are not specific to technical or clinical tasks, but are critical for providing holistic and the patient-centered care. And soft skills are integral to the nursing practice as they contribute to effective communication, compassionate care, critical thinking, teamwork, patient education, cultural competence, and the stress management, all of which are essential for the delivery high-quality patient care. So in my study, why I have focused only on the structured clinical skill assessment or the OSCE, it is because if we look at into the Miller pyramid of this teaching assessment, we can see that OSCE is then in the very higher ranking place. So if we assess the clinical competency in our OSCE, so the students, whatever they show in the OSCE, they are really going to do in the clinical. So that's why the OSCE is standing the higher level compared to the, we check the student in their written examination and all. So in today's healthcare delivery system, soft skill has become the oxygen needed to resuscitate the seemingly dying nursing care quality, because nursing is about science and art. So for this research objective was to examine the soft skill element and their component in the current objectively structured clinical skill assessment of aseptic procedure in the undergraduate nursing program. Methodology was we use a clinical audit. Data collection was retrospective for the 2 years data collection. The study setting was all the higher learning institutions in Malaysia. So in this study, we have approached to the 12 higher learning institution. However, only 5 was participated. The sample is a OSCE document where we collected for the case scenario, and then the rubric or the checklist, the equipment preparation list, timetable, and then the examiner comment. So sampling method was using by the purposes sampling method. The instrument used in this study is we have developed. So the name of the tool is called Clinical Scales Analysis Index #3 tools to use in this study. So in this tool, we have looked into the 10 domain. Number 1 is about type of the procedure. Number 2 is about component of the soft skill. Number 3 is equipment. Number 4 is instruction for the student. Number 5 is clinical scenario. Number 6 is about model. Number 7 is duration of the assessment. Number 8 is assistance is given or not during the OSCE. And then number 9 is about how many marks of soft skills are allocated. And lastly is about what are the opportunities that can be measured in this aseptic procedure of this undergraduate nursing program. So initially the data was collected for 237 OSCE documents. The analysis is used only descriptive because this is a very preliminary study. So out of 237, aseptic procedure was found 51. So from the 51, we have analyzed based on the instrument. So number 1 is about type of the procedure. So under the aseptic procedure, we have grouped it into 10 procedure, which is number 1 is about dressing procedure. Number 2 is insertion of the urinary catheter, insertion of IV cannula, endotracheal sectioning, tracheostomy sectioning, removal of the drainage tube, suture removal, and then the gowning, gloving, oral or nasal sectioning, or surgical hand wrap. So these are the type of the procedure. However, we can see in the OSCE, frequently we ask is dressing procedure, even the dressing also simple wound dressing only we assess to the student, and follow with that, we can see like urinary insertion of the urinary catheter, and then this gloving and the gowning procedure. But however, coming to the domain 2 of soft skill element in this aseptic procedure, we can see is only communication skill is listed in the assessment of this OSCE document. And then for the domain 3 to 10, mostly all of the time is the same. Equipment is already prepared for the student, and then the instruction is given very clear, and then scenario use is very simple, and then model all the time we use mannequin. Duration is regardless of the procedure. We provide only 5 minutes.
Excuse me, ma'am.
Yes.
Sorry to interrupt. You have only 1 minute left.
1 minute, okay. So if we see the summary, currently this soft skill element are very limited in our OSCE. Most of the time we give only 5 minutes, and there is most of the time we use is a mannequin in the procedure. So that's why our checklist itself, the nursing academy itself, is we are limiting our students to be used their soft skills in the nursing procedure. So that is where we have to come up with a well-structured clinical skill assessment exam question set, because if we want to produce the holistic graduate nurse, and then we always talk about the holistic care and all. So because of our assessment, those are the ones that limiting to our student to be used this soft skill in their clinical procedure. So from this study, we can come out with a 9 soft skills, so that can be not only we teach to our student, it also can be assessed in their clinical exam, so that the student will bring from OSCE into the clinical setting to be used this soft skill with their patients. So with that, thank you very much.
Thank you, Sumaya. Now it's time for the discussion.
Thank you for your wonderful presentations, ma'am. Actually, nowadays it is in advanced mode. ASCII was practiced everywhere. So it is one of the very good tool to improve the soft skill as well as the student aspect. So on the current scenario, it was a good study was done, and it's very appreciable. And even when it is done with a clinical audit, it was very good, and it's really useful, I thought. Thank you.
Thank you.
ASCII is not a new concept. It's a very method is coming in new, but it's a good study and appreciable. Thank you.
Thank you.
Yeah, good study, ma'am. Because it is initial requirement in these days as the students are directly in contact with the patients, and we have seen so many cases of highly associated infection because of the improper care of and handling of the patient instruments there. Good, man.
Thank you.
Oh.
Thank you, Prof.
Thank you. So the next participant is Dr. Sunila from JSS Dental College and Hospital, JSS AHER from India. Ma'am, you can share your screen.
Yeah. Is it visible?
No, ma'am.
And am I audible?
Yes, yes, you are audible, but your screen is not visible.
Give me a moment.
Yeah.
I think I have to log in once again. I'm not able to get the link to share. There is some I was in, but now there's some issues over here. Yeah, I think now is my screen visible now?
Yes, ma'am, it's visible. You can make it into slide share.
Yeah. Distinguished chairpersons and the fraternity of nursing, thank you for the invite that I received on email. And this comes to share in my experience as a convener of dental education unit. I had the privilege of trying to render a training module to the nursing faculty. And that's the intention of trying to share this experience with all of you. Good afternoon once again. And as we all know, oral health is a fundamental component in overall and quality of life. And in fact, there are nearly around 100 systemic diseases, as the literature says, that oral manifestations of these diseases can be seen in the oral cavity. But incidentally so, that we are unable to have in the training of the nursing personnel towards oral health. And that was an important concern. So the paucity of oral health education in the nursing curriculum and the importance for us to have a nursing undergraduates course in or a module which we actually thought of for having the training towards their knowledge and practice was the needs assessment. As I think, if I'm going right, the nursing curriculum or the four-year nursing education has no specific recommendation as we went through for teaching oral health care or trying to train the nursing fraternity for oral health care training. I hope I'm right. Let me get my points at the end from the chairpersons. So the aim of this particular training module was to have a course for the second-year undergraduate nursing students, and the objective was to understand their knowledge, attitude, and practice towards the healthcare management amongst the different disciplines at our own institute. So this was a cross-sectional experimental study. We had a cohort of 42 second-year nursing students, and we went ahead with a module with involved lecture, video demonstrations, and chairside patient demonstrations where myself and my team were involved. And we went ahead trying to assess their knowledge and skills with the pre and a post-test 30-item questionnaire. And the lecture, the video demonstrations, and the chairside demonstrations were all with the regular routine oral health care needs that was requiring the assistance from the nursing personnel across our dental disciplines. So going further ahead, let me get back straight away to the results. So as we assessed, we felt that there was this module was highly appreciated by the nursing faculty, and the results of the pre-test to post-test was significant, and the 95% of the students also intended for further training. The questions that we actually presented to them in the pre and the post were here, as you're seeing on the screen. So we went ahead with these 30-item questions, which we tried to get them from the literature evidence, from the past literature, although there were very few which actually had the training for oral health care in India. So these were our questions, where we actually have 9 disciplines in dentistry, and the questionnaire was spread out across all the different disciplines, right away from oral diagnosis to the orthodontists, that is the middle age group, and through the geriatrics, where we have myself as a prosthodontist. So this was a short study or an intervention that we undertook. And as you see over here, we definitely had a difference between the pre and the post training sessions, and it was quite significant. So from this experience, I feel a greater awareness is required for the nursing personnel regarding the daily routine oral health care that they can render to the inpatients wherever they are, or the outpatients whenever it is in an institution. So a skill-based approach is definitely required, and a mouth care protocol for the nurses as well, educating them is also required. And the risk factors that are associated with, especially the denture and its hygiene, was something which we noted about. That most patients, the geriatric group especially, would be having a removal or a completely a complete replacement or a partial replacement with a removal appliances or a hybrid appliances which they may be having. So this oral health module was definitely of a shorter duration. We could not really extend for the reasons of the institutional concerns that we could not accommodate with a larger, a longer module. So this experience comes with all these limitations of a smaller sample size, which was done with a single setting, and we did not have a comparison control group when we did it, except for the pre-test that we performed. And I believe multiple opportunities can be given, and the feedback what we personally received from our own nurses at this institution, they desired exposure, they desired training towards the dental materials, the dental healthcare needs, and how they can go about these things on the routine basis. So I would like here to conclude that the knowledge and competence to meet the wide variety of oral healthcare needs may be daunting for the student unless the nursing student is trained. And in the limited resource setting, this particular training did improve the competence of the nursing students. So therefore, in introducing a teaching session for the essential components is something which is desired and required in the nursing curriculum for good practice. thank you for giving this opportunity and an invite email to share my experience.
Thank you, ma'am.
Thank you.
Thank you. Now it's time for the discussion section.
Yeah.
Chess, do you have any questions?
I desire your opinion, sir.
Yeah, ma'am. Thank you very much, first of all. And actually, we have already, this component is already added in the curriculum of the BSc Nursing. Second year itself, in the medical surgical units, where actually it is not in the detail. Basically, we have focus on the disease condition and their management, actually, in the oral care, oral health.
Yeah.
But even though as a part of that, we are taking the completely consideration for the importance of oral health cares, because most of cases we have seen, even though in the cardiac problems, we have find out the associate with the oral problems or the dental problems. So in that, we are awareing the students in the beginning of, and the curriculum is also focused on that.
Okay. But there's no specific focus on the education regarding the dental materials and when the nursing personnel are actually assisting us, they are unaware about the required treatment needs for the patient. That was a concern. So we thought that we should try to, as on a convener for this dental education unit, I had this privilege. So probably I could make it to your platform and share my experience. I'm not able to hear you, sir.
Yes. I have one question regarding that. If you pursue in another level, in community level, it will be also helpful for general public also. So further you studied in this nursing student is okay. Nursing students is also there, but community level is also effective study. I think so.
Okay, you meant to say that community level we are supposed
You mean primary healthcare level? Primary healthcare level.
All right, but I feel that if it comes as a part of your training from your curriculum, that benefits the personnel at large.
For the awareness and the knowledge regarding that.
Yeah, the only deficit which we see as the dentist fraternity is that there is no scope for an education regarding these in your curriculum. So they need an extra training after they arrive, after join in an institution, or they get into a dental clinic where they have to assist. They're supposed to expose themselves to the new learning. So this was just a viewpoint from my side, and I hope you don't get me wrong. It was a viewpoint from our side that there could be an addition, and I was just trying to speak to one of my colleagues who is in the nursing, Dr. Sheila Williams, so that there can be a promotion of this and a forward letter to your nursing council. Anyway, with the limit of the time that we have here, let me wind up. Thank you for your listening and your inputs. Thank you.
Thank you. Thank you.
Thank you, ma'am. So we are going with the next participant, Heaven Dagia from Lakshmi Bai Batra College of Nursing. Miss Heaven. Okay, so move on with the next participant, Dr. Sunaina Sethi from OPJS University, India. Dr. Sunaina. Hi, Sunaina, you can unmute yourself. Dr. Sunaina. Dr. Sunaina, can you please try it again?
She has texted that she is not able to unmute. Maybe she has
Yes,
to
but
change her settings.
yes, Sunaina, but can you try it again because I have made you as a co-host? Still, it's not working. Okay. Okay, Sunaina, I will get back to you. Now I go with the next participant, Hadar. Hadar from the Safra Children's Hospital, Israel. The next participant is Dr. Priya Reshma. Are you there? Dr. Priya Reshma. Anu Sugumaran.
Yeah.
Anu
Good
Sugumaran.
afternoon.
Good afternoon. Can you present your topic?
Yeah.
Thank you. Ma'am, you can share your screen. Ma'am, can you please unmute yourself?
Yes, Nivedita, I am working on it.
Okay.
Are the screen visible?
Yes.
Am I audible too?
Yes.
Okay. Good afternoon, all the dignitaries. Thank you for giving me opportunity to present my abstract on this platform. So I'll begin with the title of my study. I have conducted a study, a randomized controlled trial, to assess the effectiveness of nurse-led navigation clinic on medication adherence among adult oncology patients attending outpatient unit in a tertiary cancer care center. With the introduction, with the expansion of scope of nursing practice, nurses have been enrolling into different roles of clinician, patient manager, and leader.
Anu, madam, आपके slides are not moving.
Okay, then I think I need to re-share it. I'll do it. I'll share once again. Sir, is it moving now?
Now your title of the study, you just try to move, then only we come to know.
So, sir, I'm moving from the title to introduction.
No, not moving.
It's not moving.
Yeah.
Go
for the slideshow, ma'am.
I have put it in the slideshow. Maybe it is not moving in the slideshow. Is it moving right now?
Now we are not able to see your slides also.
Okay, I'll retry. Is it visible now, sir?
Yeah, visible, ma'am, but not moving actually. Then you have to go with the slides wise, na? Yeah, it's okay now. Like that you can.
I think this in slideshow it's not moving.
Yeah.
I'll keep it in this way.
Yeah.
I'll increase the size. Okay. So is it fine?
It's okay, no issue. We will be
Okay,
continuing.
okay, I'll continue. So, nurse-led clinics are also emerging in most populous countries like India and many low and middle socioeconomic countries to provide quality and cost-effective care to patients. The Oncology Nursing Society in 2017 defines an oncology nurse navigator as a professional RN with oncology-specific knowledge who offers individualized assistance to patients, families, and caregivers to help them to overcome healthcare system barriers. Moreover, studies have proved that patients are more satisfied with nurses' clinics in terms of cost, accessibility, and time spent to clear their concerns and doubts. The patient navigator provides emotional and social support, help the patients to make appointments and arrive at scheduled appointment on time, prepared, facilitated applications for financial assistance, connects patients with resources and support systems, and facilitates interaction and communication with healthcare personnel. Thus, the navigation nurse bridges the gap existing in the system. The patient When an oncologist navigator was included into the healthcare team to assist patients being evaluated for pancreatic neoplasms, the time from first contact to physician intervention has significantly reduced from 26.6% to 8.9% with a p-value of 0.012. So the need of the study we assessed was cancer patients often find it difficult to locate stratified care support systems like various procedure rooms, daycare appointment, chemotherapy, medications prescribed in the OPD cards, their side effects, and home care management. This further delays the diagnosis, treatment initiation, and medication adherence towards the of the patients. Currently, there is no structured navigation program in practice in our system. The aim of the study was to assess the effectiveness of nurse-led navigation clinics on adult oncology patients on medication adherence among cancer patients. The methodology adopted, the research approach was quantitative, and the research design opted open-label, non-blinded, parallel group, randomized controlled trial. Independent variable was nurse-led navigation, and dependent variable was medication adherence. The population opted for the study was adult cancer patients, and the sample was adult GI cancer, gastrointestinal cancer patients. Sampling technique was convenient sampling with random number allocation, and sample size opted was 90. So we have selected almost 90 eligible 90 patients who are receiving NAIF 3 weekly chemo regimens of 3 regimens TP, carboplatin and cisplatin, and capoxibin and oxaliplatin, and gemcitabine and oxaliplatin, in which capacitabine is an oral tablet. All the other drugs were given IV form. And we randomized the 90 patients into 2 groups, intervention and control, 45 each, in a 1:1 ratio. In the control group, the patients received only usual care, wherein the intervention arm, the patient received usual care plus nurse-led navigation. The usual care means the patient attended only the physician's clinic for the follow-up or the initial prescriptions as well as the follow-up, wherein usual care plus navigation. After attending the physician's clinic, the patients will be led to the nurse-led navigation room clinic, and they will be receiving the nurse-led navigation from the nurse navigator. And during the follow, we lost 4 patients in the control arm and 3 patients in intervention arm, but we went for an ITT, intervention to treat analysis, in which we took all the 90 patients for data for analysis. Coming to the intervention part, it is labeled as NAVGISM. It is the short form of Navigation Gastrointestinal System Model, NAVGISM model. So this is developed based on a model developed by Vizela in 2014, and in which we have tailored according to our patient's need. Like the patient will be explained about, and the following things includes disease prognosis, investigations to be performed, and the need for those investigations as per the prescription they have received in the OPD card, and directing them to the respective rooms for investigation as per their prescription. This is individually tailored to the respective rooms, and elaborate drug prescriptions and warning signs according to the drugs prescribed. For here, I have already said that we have taken 3 regimens only, in which they will be following a common pattern of follow-up and drug administration. Explain the major side effects of chemotherapy, home care, and self-care management, and explain the available social support system in the center, which includes like the medical social support system available for exempting the various procedures, the payment for exemption of payments, and free of cost medicine provided. Those all facilities were included, and provide an emergency contact number in case of emergency which they can contact. This is a short, in short, how it is developed in a single. There are 18 points we have developed, and we have elaborated it into 3-page intervention. In fact, this handout has been used for all the patients when we are giving the navigation to all the patients. But some of the points, all the patient does not need all the points. So some patients did not need all the points. So those points were excluded for individual patients. That in that way, the navigation model has been tailored for each individual patient according to their need. That is the only that is how the intervention was done. Now we'll go to the intervention results part. So in the clinical profile of the patient, we have assessed that majority of the patient had cancer of colon, and they have reported in the stage 3 of cancer, and majority of the patients were receiving Capox. That is capecitabine is an oral tablet which need continuous re-emphasis, otherwise the patient will tend to not take that medicine on the course of treatment. So that was the implication of this navigation model as well. Major implication, and the intent of treatment was neoadjuvant for majority of the patient. Neoadjuvant, like before the surgery, the patients are receiving the chemotherapy. So in that again, if the treatment regimen fails, then the patient's prognosis will deteriorate very significantly. And the patients were accompanied by spouse. So we were focusing on this. Why we have included this variable? Because if the earning member is accompanying the patient, then the financial status, this financial source will be blocked, and the patient will not be able to continue the treatment. So to assess that, we have included this also. And majority of the patient were fall under the BPL category, and majority of them had no health insurance as well in the Indian scenario. So coming to the effect of NSLAD navigation clinic on medication adherence, in which we have found that the NSLAD navigation had improved the percentage 100% medication adherence with a significant p-value of 0.017 in the intervention arm during the post-test. So the intervention had made in this bar graph, it is more evident that 55% of the patients had 100% medication adherence in the control arm in the pre-test, which has in fact deteriorated to 48.9% in the post-test.
Ma'am.
Yes.
Your time is up.
Yeah, just one more minute. And in the intervention arm, it was 53% in the pre-test, and it has improved to 73.3% in the post-test with a significant p-value of 0.017. So Kathleen et al. In 2009 done a similar study, and they have identified that 87 to 94% of the patients had medication adherence improved, similar to this present study. To conclude that the NSLAD navigation clinic was found to improve the medication adherence compared to the control group, and this can be done in multiple centers, and the results can be correlated. So these are my references, and thank you for the patient listening. Am I audible?
Yes, ma'am.
Okay. Yeah. Over to you, Nivedita.
Ma'am, the section says you can ask the questions.
Anu?
Yes, ma'am.
It's a very good study, and it shows the hard work. So it's a good study. I have no question regarding that. And
thank you, ma'am.
Sir, do you have any questions?
Yeah, Anu, it was really very nice study.
Thank you, sir.
Specifically, when we will see the nursing studies, Very rarely they will go for the randomized control and randomized trials. And really it is a good, and I think that study will help the nursing professional also for getting good knowledge. I think, have you given this study for publication of any journals?
Sir, I am working on the manuscript. I have not yet completed.
Okay, good, good. Congratulations.
Thank you so much, sir.
Nice presentation. Thank you.
Thank you, sir.
Thank you, ma'am.
Thank you, Nivedita. Good day.
So we are going with the next participant, Dr. Sunaina Sethi from OPJS University, India.
Hello, everyone.
Yes, ma'am, you are audible. Ma'am, you can share your screen and start the presentation.
Yes. I'm just starting with it. Just a minute.
Ma'am?
Yes.
Ma'am, are you there? You can share your screen, ma'am.
Yeah, I'm there. I'm just looking for that document on my screen.
Okay, okay.
Because morning I was there, then I got.
Ma'am, I'm sorry, we have very limited time.
Yeah, I'm sorry.
Can you please make it as soon as possible?
Yeah. I'm having just a lagging issue with my system. I'm sorry.
Okay, ma'am. Ma'am, if it takes some time, can I call the next person?
Ma'am, can I pitch in? I'm Mary Johnson. Can I pitch in?
Yes, ma'am. Give me a time, ma'am. Dr. Sunaina, can you please tell me?
I have just you can pitch in anyone else first. I'm sorry for that.
Okay, thank you. So the next participant, it's Mary Anbarasi Johnson from the College of Nursing, CMC. Ma'am, Mary?
I would like to share my screen, ma'am. I will share my screen.
Yes, ma'am.
Is it visible, ma'am?
No,
Is my
ma'am.
screen? It's not visible. Is it visible, ma'am? No?
No.
Is it okay if I just talk, ma'am? Sorry for the inconvenience. Is it okay if I just talk?
Ma'am, yes, ma'am, but if you have a presentation, then you can share it through the WhatsApp, so I can share it for you.
Okay, okay, I can do that.
Ma'am, but if it takes some time, I will ask the next participant to present it.
Sure, sure, ma'am, sure. Sure,
Yeah, okay, ma'am, thank you. Dr. Sunaina, are you ready now? Dr. Sunaina. So the next
Yes, I'm
participant.
I'm there. I'm there.
Okay, okay, ma'am, then you can share your screen and you can start your presentation.
It is visible now.
Yes, ma'am, yes.
Sorry for that delay last time.
It's okay, ma'am.
So my topic for the today's presentation is importance of rational practice in nursing. Okay, first with the introduction. What is rational practice? First of all, it just simply means in accordance with the reason or a logic. I would say in simple words that we don't underdo, overdo the things or don't do without any reason or the logic behind. Thinking critically before administering medicines and treatments to the patient is important part of patient care. Prejudice should be avoided in cases where individual needs are to be addressed. The specific definition given by WHO is the rational use of medicine is defined as patients receive medications appropriate to their clinical needs in doses that meet their requirements for an adequate period and at the lowest cost to them and the community. Rational practice is required to have desired result without harming the community, treating the patient in safe and effective manner. It basically includes critical thinking, clinical reasoning, clinical decision making, and compliance with the policies and guidelines. Now, why rational practice? It plays a pivotal role in disease prevention, and by optimizing the healthcare resources, ensuring the efficient allocation of medications and treatments. Through a comprehensive review of literature and case studies, we examined the various dimensions of rational medicinal practices that are characterized by the emphasis on evidence-based decision-making, cost-effectiveness, appropriate prescribing, continuous education of the stakeholders, including nursing personnel and patients. It helps in building a healthcare system which is both beneficial to providers and patients. They offer a systematic framework for healthcare professionals to optimize the utilization of resources, ensuring the treatments and medicines are administered judicially. It not only aims to enhance the individual patient care but also contribute significantly to public health by mitigating the spread of diseases and reducing the overall healthcare burden. In this presentation, we will also discuss the challenges and barriers that hinder the widespread adoption of these practices and can propose some strategies to overcome them. With continuing with that, RUM focuses on 4 essential aspects. It includes the correct medication, correct dose, correct duration of the treatment, and correct cause, that is explained by Chaudhary et al. In 2017, again explained by WHO in 2002. It is critical for achieving the therapeutic goals, avoiding unwanted effects. All stakeholders, including the government medicine producers, healthcare staff, and patients, they are responsible for implementing this. Again explained by Vaishal Mordi et al. And WHO in 2002. Nurses play a crucial role in drug safety as healthcare team members. As health workers, they do not have that sufficient pharmacological knowledge and they are more likely to make mistakes during the practice. Providing education to all the concerned in correct use of medicine is an effective strategy to gain knowledge and solve the problem of irrational use of medicine, as said by Burkitt et al. In 2020. Now, nursing and rational practice. Nursing profession is both art and science. They apply these skills using systematic knowledge earned from their learning institutions. The art and science must be embedded with sound reasoning, appropriate decision making, precise judgment as the key elements in providing patient care. Nursing should be trained to their full extent by integrating fresh approaches in practice, by keeping them updated regarding the latest researches, studies, and motivate them to readiness in incorporating these in their daily patient care nursing practice. Through operative leadership organization authority, we can maximize their capabilities and potentialities by professional collaboration, learning, training, continuous professional development. This is the basic practice rational care model as explained for the nursing. We can see that the nursing process, it all revolves around the patient care and the aspects of rational practice, clinical reasoning, clinical decision making. They both are again interconnected in every aspect for the clinical judgment to be taken for the patient. Clinical decision making is a process that nurses undertake on daily basis for the judgments about the care they give to the patient. Clinical decision making as a nurse gain more and more experience with a good guidance by a specialty clinician, and with their experience they gain a confidence and clarity in relation to their clinical decision making. And again, as explained by Smith et al. And Thompson et al. In 2004, to develop nurses as autonomous clinical decision makers, pre-registration, education, training programs need to be incorporated to the educational framework that would support the development of prerequisite intellectual and cognitive skills that are needed in order to manage complex information and to make the judgments. If you look at some basic reasons for this irrational use of medicines, as explained by Aspan in 2014, there might be lack of information, confusion between the staff, inadequate education and training of the professional, the communication between patient and healthcare professionals. Some other reasons which we can observe practically are ambiguous or false beliefs, insufficient knowledge of the user, prescribing burden on the doctor, some advertising events by the pharmaceutical industries, absence of protocol application. In short, these low quality decision making, these tend to violate the various rationality criteria. As we further develop into this deeper section of rational practice, some suggestions which we can propose by the basic studies are by optimizing the healthcare resources allocation that includes staffing, budgeting, supplies, focusing on continuous medical education, development programs for nursing staff, having brainstorming and one-on-one session with them so that their challenges can be understood and they can be guided wherever possible. Include the topic of this rational practice in their curriculum, motivating the nursing staff by giving value to their work and dedication so that they take keen interest in further learning and improvements, preventing unnecessary medication dosage and prescriptions, promoting patient empowerment through education, keeping in view the patient rights. The rational practice medicine offers a holistic approach to disease prevention, treatments, and then ultimately patient care. Therefore, the knowledge of RUM is the basic and the important component, and it needs to be improved in all the process of the nursing care within the hospital or healthcare facilities. Thank you for listening in this.
Thank you, ma'am. So the section chairs, do you have any questions?
Thank you for presentation. I have no question.
Okay. Okay, ma'am. Thank you. So I'm going with the next participant, Mary Anbarasi.
Yes, please go ahead.
Ma'am Mary. I will share you the screen for you, ma'am.
Very kind of you, ma'am. Thank you very much.
Thank you.
The presentation, can I go ahead, ma'am? Can I start, ma'am?
Yes, ma'am, yes. Ma'am, the screen is visible, right?
It has to be magnified, ma'am. It has to be, yeah, it's very small. Size should be made big, ma'am.
Okay.
I suppose I can manage, ma'am. It's okay. I can manage. So good afternoon, everyone. And at the outset, I would like to thank all of you, and especially the organizers, for giving me this opportunity to present. I'm not going to present on any study, but the management, what happens in pediatric nursing department, in pediatrics as well in Christian Medical College regarding the IDDM management. We know IDDM. Next slide, please. Next slide, please.
Ma'am, I have changed the screen. Is it not visible?
Still, it's okay, ma'am. Yes, actually, it's not visible. It's small.
Okay. Ma'am, you can start, ma'am.
Yes, ma'am. That's okay. I think I can manage, ma'am. I can manage. So IDDM, we know that it is one of the pressing issues in country is like India, where many of the children presently, the number is increasing. Even among the staff dependents, the number is quite increasing. And therefore, it is a key concern. We know IDDM is otherwise called as type 1 diabetes or brittle diabetes or early onset diabetes or ketotic diabetes because the carbohydrate metabolism is deranged, and IDDM requires a comprehensive medical and nursing management to ensure optimal control of blood sugar levels and reduce the risk of complications. And what exactly happens here, all of us quite know that insulin is the key component, which is like a key for carbohydrate metabolism. And when that is lacking due to causes like maybe infections, viral infections or bacterial infections have insulted the pancreas, then the insulin production is not there. And therefore, carbohydrate metabolism is deranged, and that affects or insults the other metabolism as well, the fat and the protein metabolism as well. So they present with the characteristic features which we call as the 3 Ps, the polyuria, polydipsia, polyphagia. And besides that, they also present with dry skin, enuresis and bedwetting, feeling very hungry, losing weight without trying, and also feeling irritable, having other mood changes and feeling tired and weakness. And also they have, some of them complain of blurry vision as well. And so what are the main causes? Genetic, especially when both parents are affected, the probability is much higher compared to one parent being affected. So genetic is main component. And besides that, viral infections, which can cause acute pancreatitis, which can reduce its production, and other environmental factors also. So family history, genetics, geography, they say if they are away from the equator, the chances are much high. And even among age, the first peak incidence occurs in children between 4 and 7 years, and the second peak incidence is said to be between 10 and 14 years. So the lack of insulin causes poor carbohydrate metabolism. That is, the glucose in the blood is not being utilized, and that causes hyperglycemia. And also there is cellular starvation, and because of that, the child starts eating a lot, which we call it as polyphagia. And once the levels hit up more than 180 milligrams percentage, then the child also presents with polyuria and glycosuria. And because child has polyuria, the child also presents with polydipsia or excessive thirst. And now the other result would be fat. The fat mobilization happens, and from the adipose tissue and various other result. And therefore, the child also presents with other fat metabolization problems like the beta-butyric acid, acetoacetic acid. All those are released, ketones, acetones. All those are released, and the child can also present with ketonemia and ketonuria, which is something. Usually, the fat is not the one immediately pitching in for carbohydrate. For the metabolism, and that's why that happens. And the other result will be protein, and that's why invariably almost all these children look very thin, unlike the adults. So why? Because the muscle mass also gets kind of mobilized. So all the metabolism gets affected, and we also know there is derangement in the hepatic gluconeogenesis, glycogenolysis, and also lipolysis. And the main hormones that are involved are the glucagon, growth hormone, catecholamine, and the cortisol. And if these children are not treated, in the very short course, they may present with various complications, and even in the long term, they may have complications. So what are some of the complications? It can cause cardiomyopathies, it can cause neuropathy, retinopathy, and also skin infections like fungal and bacterial infections. And if it happens to be an early pregnancy, like adolescent pregnancy, they can also produce babies with diabetes mellitus. And the management, different hospitals have different mode of management, but the principles are almost same. And what we even when I was a staff many years ago, we used to use Mixtard and Actrapid and give it as 2 shots, one in the morning 6 a.m. and one in the evening. But there is a trend now. What we right now do is we give Actrapid, which is short-acting insulin, which starts its action within half an hour to 40 minutes, and then it goes on for 6 hours. So we give Actrapid, one in 6 a.m. and another dose at 12 noon, and the third dose at 6 p.m. And at 9 p.m., the child is covered with Lantus, which is long-acting insulin, which has its effect almost for 24 hours. And when the child's levels go beyond 9, the insulin is given as subcute, we all know that. And if it goes beyond 250, we term it as DKA or diabetic ketoacidosis. In that case, we have to intervene with IV insulin, which is 0.1 to 0.2 units of Actrapid per kg body weight. So glycemic control is very, very important, and glucose monitoring, almost it's monitored 4 times a day, 6, 12, evening 6 p.m. and at 9 p.m. And weekends, they also do at 3 a.m. And so glucose monitoring is to be done, and continuous glucose monitoring devices are available, which is expensive, more than 5,000. And if they can afford even, that can be adhered to. So nutrition, I'm sure all of us know what is the nutritional management here. Because they are children, we must be careful that we do not curtail their calories at whatever cost may be. So they are given 50 to 55% carbohydrates, 30% of fat, and 15 to 20% of protein. And so if the child has to have 2,000 calories, there is no curtailing on calories. However, modification of diet only is done. So what is the modification? We tell them to avoid highly sweetened items like cola, sugars, and sweets, and also to we try and give the calorie split up like this: morning 30% of the total calorie requirement, noon time 20% and night 20%, which accounts for 70, and then the remaining 30% is split and given during the morning around 10 a.m. again 3 p.m. and 9 p.m. So making it 100%. And the other, so at no point the child should be kept starving, because the child can easily go to hypoglycemic attack. And also they are advised to take complex carbohydrates and more fibers, so that the carbohydrates will be released very slowly and the child will be able to maintain euglycemic stage. We, our team, we have a wonderful medical team, so harmonious, and a lot of advice we get from them. And we have diabetic camp being held, a major camp once a year and minor camp once in 3 months. And just last week also we had a camp where all around India, people came and they were participating, parental networking. And these children, it's so amazing to see these children actively participate in various competitions and things like that. And they literally lead a normal life. And we learn a lot from other institutions within the country and as well from the other countries. And their input is definitely welcome, and we learn quite a lot from them. So that's about the diet management and new regular exercises to be incorporated, because we don't want these children to develop diabetic ketoacidosis. So can they participate in sports, or can they do diving, or can they climb a mountain? Yes, it is all definitely, there should not be any curtailing of exercises. In fact, we encourage them, and only thing that they have to have the tag, and during the time they participate in sports, they know there should be modulation of exercise and modulation of diet and insulin. Probably during such day, the diet can be increased and we may reduce on the insulin. And so there is no need for restriction of whatever this one exercise whatsoever. And management of acute complications, we know the complications can be microangiopathies and neuropathies and retinopathies and so on, but particularly hypoglycemic attacks. So what we do here is, where we tell them, in case the child presents with all the signs and symptoms like excessive sweating or shallow breathing, or a child feels giddy and all that, we talk to them about the signs and symptoms. And then in case the GRBS drops below 70 for a child who's more than 1 year, then we tell them to take 2 to 3 teaspoons of glucose mixed up in 1 glass of water, and recheck the blood sugar again after the 15 minutes. And still the sugar level is less than 70, then again take 3 more teaspoons of glucose in 1 glass of water, and recheck after 15 minutes. By then, probably the sugar level would have come up more than 100. Then they can go for a snack. And besides that, we assure them psychologically. And so we talk to them about the signs and symptoms, how to early pick up, like shakiness, sweating, trembling, palpitation, and the difficulty in breathing, disturbed color vision, and difficulty in hearing, confusion, loss of consciousness, seizures, and so on. And also we also highlight on the risk factors. If the child is less than 6 years, it's more probable, and the HbA1c is lower, that's more probable, and hypoglycemic unawareness. So education is one component. And we also teach them how to differentiate unconsciousness between hypoglycemia and hyperglycemia. That is also being taught to them. And the other most important complication is diabetic ketoacidosis. We know the signs and symptoms already. They present with more than 250 mg percentage acidosis, where the pH drops less than 7.3, bicarbs are less than 20 millimoles per liter, and they present with ketosis, and severe ketones are present more than 5. And so in diabetic ketoacidosis, we manage dehydration first by giving normal saline, the first half being given over the first 8 hours, and the remaining half over the next 16 hours. And the other result will be treating hyperglycemia, where we intervene with insulin 0.1 to 0.2 units atropine, and also correcting. We check on the ABG, and if child presents with acidosis, then we move on to treating the child with soda bicarb 2 to 4 ml per kg body weight. So we teach the parents, in case child is found unconscious, is it due to hypoglycemia or hyperglycemia? We tell them.
Ma'am, your time is over, ma'am.
Time is up. Yeah. Actually, recently we did a small project, and we found that the adherence in children less than 1 year, it's not at all good. But the adherence in children from 1 to 6 years is around 80%, and beyond 6 years, if they are old cases, then the adherence is almost 98%. That's a kind of a conclusion which came up on a small project which has been done. I once again thank the entire team for giving me this opportunity, and I learned quite a lot from all of you. Thank you very much, and God bless our team.
Thank you for your insightful presentation, ma'am. Section chairs, do you have any questions?
Thank you, ma'am. Thank you for your project. Thanks.
Welcome.
Thank you, ma'am. So I'm going with the next presenter.
Yes.
The presenter, Adar, from
Yes.
Safro Children's Hospital.
Just a minute. Wait.
Así. Ok, ya, así. Cancélalo.
Just a minute. Okay. We can start?
Yes.
Okay. Good afternoon. My name is Shrezninger Adar. I'm the head nurse in the Oncologic Palliative Unit Care in the Safra Children's Hospital in Israel.
My name is Bukovla Shiran. I'm the deputy head nurse in pediatric cardiac intensive care in Israel.
And my name is Babayev Diana, and I am the deputy head nurse of the pediatric surgery department.
We will introduce to you all our study regarding the unstable child simulation, and we'll show you how our study can improve knowledge, clinical skills, and communication between nurses and doctors, mainly residents. The nurses and residents in the Safra Children's Hospital deal with the unstable child on a daily basis. They do not always know how to approach the patients, what equipment to bring to the doctor, and the doctor himself also faces this stressful situation between sometimes even for the first time.
In order to improve the quality of the treatment, providing a quick and high quality response, we set up a stimulation system for the unstable child in Children's Hospital for both the nursing staff and the resident. These stimulations are designed to closely mimic real-world situations. They occur in the home department of the training staff. During the stimulation, the staff use their regular used equipment. Following each stimulation, a debriefing session will occur to discuss the scenario, extract value lessons, and facilitate experiential learning. The primary goal of the study is to teach both nurses and physicians in the various departments in the Children's Hospital to become more professional in caring of the unstable child. By experiencing multiple scenarios of the unstable child in the study, the team will know better how to deal with the similar situation in real world. We believe that by practicing this, they will be more organized, more professional, and will improve the teamwork and communication skills. In addition, it will decrease anxiety while facing this situation in the real time.
The secondary goal is to learn from each participant what is her main difficulties, what else needs to be done, and how the simulation improves their future knowledge and skills. Therefore, questionnaires are distributed to the nursing and medical staff in departments at the Safra Children's Hospitals before starting the simulation and after 6 months. This study is still ongoing. Up to date, 120 medical staff has answered the first questionnaires and participated in the simulation. 50 nurses and residents have answered the second questions 6 months after doing the simulation. Although the final results of the study are still in process, the preliminary outcome shows that the simulation improved team clinical performance, knowledge, professional skills and abilities, and communication. This realistic scenario allowed the participants to learn and practice in safe conditions, efficiency, reducing uncertainty and anxiety in preparation for future real-world actions. Now, this project is extending to include other departments within the Children's Hospital, and we hope it will be good. So thank you all.
Door close ಮಾಡ್ಕೊಂಡು.
Yes. Questions?
Thank you. Any question? Section chairs, do you have any questions?
No. I have no questions. Thank you. Thank you very much.
Okay, thank you
all.
Thank you. So going with the next participant is Dr. Priya Reshma. Dr. Priya Reshma. Okay. The next participant is Dr. Vishwa.
Yeah, it's Dr. Vishwas, yes.
Yes, sir. Sir, you can start your presentation.
Yeah, sure. I'm unable to share. I think they need to remove this screen.
Can you please stop your screen sharing? Sir, now you can try it again.
Yeah, very good afternoon to one and all present here. First of all, I would like to give a great thankful for the 7th International Conference organizers for giving us a platform for presenting our research work with all the associated partners. And myself is Dr. Vishwas. I work for a community department in College of Nursing, Amity University. My statement of the problem is a study to assess the DOTS providers' perception and satisfaction on tuberculosis patients' nutrition assessment tool and intervention guidelines. Ma'am, can I confirm, am I audible?
Yes, sir, you are audible.
Yeah, thank you. All right. The statement once again is to assess the DOT providers' perception and satisfaction on tuberculosis patients' nutrition assessment tool and intervention guidelines. The tuberculosis is a contagious disease which requires ongoing medical attention and care. India accounts for more than 26% of total TB cases, with 34% of all the deaths in the world due to tuberculosis. According to National TB Prevalence Surveillance 2019-2021, the estimated infection rate in India was 316 for 1 lakh, which was higher than 193, which was predicted by World Health Organizations. The prevalence of TB about the age of 15, such as old age, just a minute, I'm going to, yeah. 15, such as old age, male genders, malnourished, smokers, alcoholics, and diabetic patients was 31.4%. The report recommends for more measures on nutritional interventions for undernutrition, early screening, and intervention for old age, and steps to prevent smoking and alcohol for better control of pulmonary tuberculosis among general population. The need for study goes like this. Undernutrition is a known factor for progression from tuberculosis infection to active TB diseases. Malnutrition has been prone to worsen clinical outcomes and rise of morbidity, mortality, and post complications, and it must be identified and treated as a separate illness. Therefore, nutritional status may also be very important for controlling the illness and predicting the treatment outcomes. Patients who are identified as malnourished or at nutritional risk should undergo periodic assessment with suitable tools to track improvement or deterioration. The first step in addressing the undernutrition should be screening all TB patients who are currently active at the time of registration. Individuals who are found to be at higher risk should then have the nutritional status thoroughly assessed. Hence, the present study aimed to assess the DOTS providers' perception and satisfaction on tuberculosis patients' nutrition assessment and interventional guidelines. The nutritional assessment tool and nutritional guidelines was developed by the researcher and validated systematically, focusing on nutrition status and needs of TB patients. Research methodology is a quantitative approach with survey research design. The population was community health workers. Sample was DOTS providers, which includes ASHA workers, Anganwadi workers, TB health visitors, community health officers, male and female health workers from respective sub-center, primary health center, and community health center. The sampling technique was total enumerative purposive sampling technique. The size was 128 samples, the total enumerative, and the setting was selected health centers of Uttarakhand state. So the sample setting was being selected through the study setting was selected randomly using the lottery method after choosing Dehradun district as a convenient. So under Dehradun, there was 6 community health centers. So under which through lottery method, I got Raipur as a CHC, and under Raipur, still there was 4 primary health center through which Thanu primary health center was chosen, under which there was 8 sub-centers which was functioning for so many villages. Henceforth, the setting was chosen on this particular way. The inclusion and exclusion criteria for the samples was the health workers involving in DOTS therapy, trained under RNTCP for DOTS therapy, administering DOTS therapy on day-to-day basis, consented to participate in study. And the health workers not willing to participate, directly involved in DOTS therapy and available at the time of data, not available at the time of data collection are excluded. So the data collection goes like this. A self-administered questionnaires was developed and validated to assess the DOTS provider's satisfaction and perception with 5-item Likert scale. Data was collected from April 2022 to July 2022 after obtaining prior permission from the concerned authority before starting the investigation in the research setting. As per inclusion criteria, 128 health workers was selected from various health centers, in which 37 health workers did not take part in the study. The reason for dropout was no TB cases registered for the given population. Hence, the total participants for the study purpose was 91 health workers. The consent was taken from each participant with clear instructions regarding the nutrition assessment tool and intervention guidelines. The total duration provided was 45 days until they met TB patients and performed nutrition assessment with the help of tool provided. And no participants was being forced in order to submit the tools or whatever it is. The data was analyzed with the help of descriptive and inferential statistics. The result and interpretation goes like this. Socio-demographical characteristics includes age, gender, education, income, occupation, type of family, religion, marital status, habitat. Have you been appointed as DOTS providers under RNTCP? What is your experience as active DOTS providers? Have you attended any training program regarding nutritional needs and TB management? The distribution of satisfaction of DOT providers in the nutrition assessment tool and intervention guidelines goes like this. Since it was a Likert 5-point scale, so every item was having 5 options with not at all, a little, rather, satisfied, much satisfied. The first item is, did this assessment tool and intervention guidelines benefit you, your routine assessment? There was much satisfied with 69%. And the next item was like where you successfully using the tool among all adults TB patients who come to receive DOTS. And there was satisfactory level of 49%. And the next item was 58% much satisfied with, were you able to manage time in using this tool in spite of your busy schedule? And the next item was, the domains items mentioned in the assessment tool was clear. For this, the satisfactory level was 54%. What is this? I'm just unable to see the upper one. Okay, never mind. So the next item was, did you feel interventional guidelines helps in quick recall of points to educate TB patients? There was a satisfactory level of 47%. And the item, do you wish to continue this assessment tool and intervention guidelines always? Yes, the much satisfactory level was 54%. And finally, the satisfaction with 53%. Do you think that this tool will be helpful in giving the desirable result? So the descriptive statistics with the scoring of mean was 35.16 and the standard deviation 3.06 with minimum 27 and maximum 40. The percentage of satisfaction, it comes with the medium 36.1% and the high level was 35.1%. And the low level goes with 28.9% where the scoring is less than 32. And the medium was 33 to 36 and the high level was 37. Now the perception, the scoring of the perception, the items goes like this. Again, it's a 5-point Likert scale where the items was being divided with strongly disagree, disagree, undecided, agree, and strongly agree. The items was nutritional assessment, do not divert resources from optimal TB care. So for this, there was a strongly agree 68%. A nutritional assessment tool is required for quick and easy evaluation of patient condition. Again, for this, the strongly agree was 80%. The TB patient's nutritional assessment should be done only by certified expert. So for this, strongly disagree was 89.01%. And the next item was all essential macro and micronutrients are essential for well-being of TB patients. For this, strongly agree was 74.73%. So should be assessed for the, I can see this, the upper one. So since it has been merged, well, the next item was weight loss is a common symptom shown maximum by all TB positive patients. For this, like the strongly agree was 65%. The TB patients with malnutrition can be provided with fortified supplementary food. So for this, strongly agree was 64.84%. TB patients with severe malnutrition to be referred to medical centers. Again, strongly agree was 65.93%. The appropriate counseling is very important on TB patients' nutritional status throughout the treatment. Strongly agree was 72.53%. The fortified supplementary food can only help to restore the normal nutritional status of TB patient was strongly disagreed from 53.85% of participants. So the lean body structured people are affected with tuberculosis. Further, 61.54% of participants strongly disagreed. So 50 participants strongly agree with tuberculosis management may lead to loss of appetite in patients, and 54 participants strongly agree with tuberculosis can worsen pre-existing undernutrition. So the description of statistics for perception was the mean was 78.3196, standard deviation with 4.9656, minimum 63 and maximum 85. So the percentage of perception was like the medium level with 79 to 81, 47.4%. And next goes for the low 33% with high 19.6%. Finally, the association between satisfactory level and selected socio-demographical variables. The significant association with satisfaction of dots provided with socio-demographical variables was assessed using chi-square analysis. The significant association found with education, income, occupation, religion, marital status, and the variables such as age, gender, type of family, habitat, experience, and training program had no any significant association with level of satisfaction. Same way, the association of level of perception with socio-demographical variables, again through chi-square, it was being analyzed. The significant association found with age and education, there was no any significant association found with gender, occupation, type of family, religion, habit, and marital status, experience, and training program. Finally, the conclusion is the DOT providers' perception and satisfaction on tuberculosis patients' nutrition assessment tool and intervention guidelines reported in the study may help DOT providers on daily basis routine assessment and get quick and valuable information regarding TB patients' nutrition status, which may be a part of effective TB management and cure. The implication of the study is tool can be useful to all the healthcare workers, clinicians, community health workers, dietitians, ASHA workers, sub-center workers, Anganwadi workers, and in existing nursing training program or courses available for registered nurses, it may be a value-added topic to enhance knowledge, attitude, and skill in caring especially TB patients with nutritional aspect. Thank you so much. Thank you.
Thank you, sir.
Yeah.
Section chairs, do you have any questions?
Dr. Vishwas is a good study, and it is related to, I think it's related to fully community, and I think you study provided in DOT clinics only, na?
Yes, ma'am. DOTS providers. DOTS providers. Actually, to be very clear, it was my PhD thesis work. So in the first two phases, I have developed a tool. So it was a methodological study. I developed a nutrition assessment tool. And later in the last stage, I have assessed the satisfactory and perception level. That is what I have presented currently. So the tool was checked through reliability and validity. And finally, it was one other part. So here, only in this part, I have shown my satisfaction and perception of DOTS providers. What was their response?
And you use the nutritional assessment tools.
Yes.
Is this tools any prepared tools or any?
Yeah, it was standardized tool. I prepared it through Delphi process. In the initial stages, I prepared this tool, and finally the reliability and validity was being assessed as my PhD partial fulfillment. And later, the last stage was assessing this satisfactory level of DOTS providers. I have got copyrights from Government of India also for my tools.
Okay. Okay. Thank you. Thank you. It's a good study. Thank you.
Thank you, ma'am.
Thank you.
Thank you, ma'am, and thank you, sir. So the next participant, it's Adira from AIMS, Diogar, India. Adira?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Am I
Adira,
audible,
you
ma'am?
can share your screen and you can start your presentation.
Okay. Thank you. Sit.
Adira? Okay, so going with the next participant, it's Sunil Kumar. Sunil Kumar. Okay. The next participant, it's Sugandhi Rajesh. Sugandhi.
Slide able to all, there was network issue. Am I audible?
Ma'am, okay.
Ma'am,
Ma'am, yes, you
whether
can
I'm
share
audible?
your screen. Yes, yes, you are audible.
Okay, okay. I hope the slide is visible to all.
No, ma'am.
I'll try to share again because in my desktop it is showing shared. Ma'am, whether it is visible now?
No, ma'am. Ma'am, did you share the screen?
Yes, yes. Your screen share. Ma'am, actually, I think there is net issue.
Okay, ma'am. Ma'am,
I'll
if you
try
need
again.
if you need some time, can I call the other participant?
Oh, okay, ma'am. Can I get 1 minute? It's
Yes,
getting
yes,
shared.
sure, sure. Mm-mm.
Whether it is visible now?
Ma'am, yes, ma'am.
Okay. I hope the slideshow is visible to all.
Yes, ma'am, it's visible.
Okay. Thank you, ma'am. A very good afternoon to all. Thank you for giving me a chance to present my narrative review. The topic is on prevalence of respiratory disorders and associated factors among workers of coal mines, a narrative review. And going to the introduction, coal resources, it account for 27.62% of energy consumption worldwide. And with its increased utilization, coal mines and the workers, there is a legacy of lung diseases increasing apparently. And earlier it was the term like pneumoconiosis or anthracosis was more prevalent. And now they have changed it to a spectrum like coal mine dust lung diseases, which include coal workers pneumoconiosis, silicosis, mixed dust pneumoconiosis, dust-related diffuse fibrosis, and as well as COPD. So in the study of global burden of disease study, which was conducted from in 195 countries and region from 1990 to 2017, pneumoconiosis in general was found to be increasing by 66%, and where in this proportion, coal workers pneumoconiosis was found to be 27% and 25% respectively. And for the published literature, it has been reported that more than 20 million workers are exposed to coal dust in the workplace like in China and India alone. And by the end of 2021, it is proposed that 9,15,000 patients with occupational pneumoconiosis have been reported in China. And moreover, earlier it was given emphasis on pneumoconiosis alone. But now it has been recognized that with decades of coal mine dust exposure, the coal mine workers, they can have COPD also. For that, the recent studies have added to the strength of its evidence. The coal mine workers are also susceptible to COPD and also tuberculosis, lung cancer. So we felt the need to review the prevalence of respiratory disorders among coal mine workers. And with these objectives, we have conducted our narrative review to assess the respiratory disorders prevalent among coal mine workers and to find out the associated factors that pose a risk of developing respiratory disorders among coal mine workers. And the design adopted was a narrative review. And we used the material and methods which we used was in the search strategy, we have searched in 5 databases, PubMed, Cochrane, CINAHL, Google Scholar, and the following medical subject headings we used when we employed the search strategy, like coal mine respiratory disorders, prevalence, coal miners, coal mines, pulmonary function, and coal mine dust lung disease. And the eligibility criteria for the study was, the study should include a study population of coal mine workers. It should include measurement of prevalence of respiratory disorders among coal mine workers. It should provide information on associated factors for developing respiratory disorders among coal mine workers. And in the selection process, while screening the studies, finally we could take only 11 studies for our narrative reviews, depending upon the criteria. Like if they are meeting the eligibility criteria, the reviewers, we have selected finally 11 studies. And through the data analysis, we have found that the 11 studies I have put up in a tabular column. And in this, all the 11 studies which we have taken were cross-sectional. And the first study, which was conducted in USA during 2005 to 2015, the 5,605 coal miners with at least 10 years of tenure were included in the survey. And here they have used a questionnaire which included demographic details, occupational history, smoking status. Then a chest X-ray was evaluated depending upon the ILO classification, International Labour Organization chest X-ray classification. Then spirometry was used. Here, among the sample, 103 miners had radiographic evidence of coal workers pneumoconiosis, and 524 miners had abnormal spirometry. And in this study, they have revealed that those who had a tenure of 10 years or more, they had prevalence of lung function impairment. And in the next study, which was conducted in Tanzania, 250 workers of coal mine were included in the study. And here the researcher, they have used only a respiratory questionnaire, which is the British Medical Research Council questionnaire. And from this questionnaire, they have found high prevalence of dry cough, 45.7%, breathlessness, 34.8%, and blocked nose of 23.9%. And here they have seen that there is an association of coal dust exposure with cough. Next is the study which is conducted in USA, where 4,742 surface coal mine workers with more than 10 years of tenure were selected in the sample, and they used a questionnaire, a chest radiograph findings as the data collection tool. And here they have seen that they have shown that pneumoconiosis was present in 109 surface miners, where they had 12, they had complication of progressive massive fibrosis. And in the study, they have found that the type of mining, like surface mining itself, the type of work like drilling and blasting has more evidence of pneumoconiosis or association with respiratory disorders. And next study, which is conducted in India, in West Bengal, where it is a comparative cross-sectional study where 230 underground coal miners and 130 age-matched workers of coal mines were used, where the sample, and the data collection tool which they used was a structured questionnaire and spirometry. And in this study, they have found that lung function indices were significantly impaired between the exposed and non-exposed group. And they have found a positive relation between exposure time and lung function deterioration. In the next study, which was conducted in USA in 2021, 2,568 former coal miners were included in the study. And here they have used spirometry and chest radiograph as the data collection tool. Here they have found the result as 56.6% had abnormal spirometry, and there was an age standard prevalence of airflow obstruction among miners aged more than 45 years was 18%, and 12.2% among never smokers. And in again another study in USA, it was a surveillance study only. Sorry, it was a surveillance study only. 24,686 coal miners were employed, and they used a questionnaire and chest X-ray. They have found that 8.5% had advanced coal workers pneumoconiosis, and prevalence was highest among younger, that is less than or equal to 56 years. And then the next study in China, where they have administered the study to 445 coal miners. Here also they used questionnaire and spirometry test. Here they have seen that new miners experience an initial rapid decline in the forced expiratory volume in 1 second, especially during the first years of mining, and later on they showed a recovery. And they have shown that the FEV1 forced expiratory volume first in 1 second decline was more among smokers. Next is study which was conducted in Spain. Here 226 coal mining workers were there, and here they have used a questionnaire by American Thoracic Society and spirometry. Yes.
Ma'am, you have only 1 minute left.
Okay. So coming to the results, here we have employed a narrative synthesis of 11 articles, and it was seen that majority of the study was in United States of America, and our sample size, which was from 226 to 24,686 participants, and all studies were observational and quantitative. Here the studies, most of the studies, they used a respiratory questionnaire and spirometry, and very few only used chest X-ray. And in the cross-sectional survey, which is conducted in India, lung function indices were significantly impaired. And another study, which is conducted in Spain, also they have found the decline in forced vital capacity ratio. And in majority of the studies, which was conducted in USA, they have shown spirometry changes as well as coal worker pneumoconiosis prevalence was very high, because on all those studies, they have used chest X-ray. And in the associated factors from the narrative review, we have found that period of tenure in coal mines has a strong association with the prevalence of respiratory disorders, as well as habit of smoking, and the size of small mine, like small mines, have a strong association with the development of respiratory disorders, then a previous history of TB also has been found to have a strong association with respiratory disorder in one study. So in discussion, we have found that there is high prevalence of respiratory disorders, especially high prevalence of abnormal lung function. Whereas in previously from the literature, we can see that pneumoconiosis only is present more among coal mine workers. But from our narrative review, we have found that there is prevalence rate of not only pneumoconiosis, but the other obstructive respiratory disorders. And this review have found a strong association of years of coal dust exposure and smoking with prevalence of respiratory disorders. And we recommend that there should be appropriate workplace culture and future studies can be employed. And these were the references. Thank you.
Thank you, ma'am. Ma'am, any questions?
Very good
I have no
afternoon.
question.
Yeah. Okay, ma'am. Please continue. Bhattacharya ma'am, please you ask. I will ask later.
Yes, thank you. It's a good study. And what is your sample size?
Ma'am, it was a narrative review, and the sample size ranged from 226 to, in one survey, it was 24,686.
Okay. Okay.
Yeah, Athena ma'am, my question is that it is a narrative review. Okay, you have
Yes, ma'am.
gone for the narrative analysis of the various research studies. So actually, what is the benefit that nursing profession got from that?
Sir,
The
actually,
healthcare
I'm a
professionals
PhD.
get the benefit from that narrative analysis.
Okay, sir. Sir, actually, I am a PhD scholar, and my study is about prevalence of respiratory disorders. And after that, I will be developing a nurse-led pulmonary interventional package for those with respiratory disorders. So for the review of literature, I came across the different tools which can be used for assessing the prevalence of respiratory disorders, and it can help me to develop the nurse-led pulmonary interventional package. And I am working in the state of Jharkhand, where there is, it is called as a coal capital.
Coal capital, right?
So, yes, sir. So I can, means like we can initiate nurse-led interventions in our aims itself. And we can help the other coal mining occupational health units.
So this was just any research you have done for your PhD purpose to develop that, because it is not directly involvement of the samples in that your studies.
Yes, sir. This is for helping my review of literature.
Review only.
Means, yeah. I am in the process of conducting study.
Okay.
Okay.
Thank you, ma'am.
Thank you, sir.
Thank you, ma'am. So can I go with the next participant? Sunil Kumar. Sunil Kumar. The next participant is Suganti Rajesh. Suganti Rajesh. Okay. Dr. Priya.
Yes, good evening, everyone.
Ma'am, you can share your screen.
Yeah, I'm sharing my screen.
Okay.
Is my PPT visible?
No, ma'am.
Can I start my presentation?
Yes, ma'am, but your screen is not visible.
Yeah, screen will come, ma'am. So that, shall I start?
Yes, ma'am, okay.
Okay. Good evening, everyone. The title of my study is Exploring Empathy Among Undergraduate Nursing Students at Universities of India and South Africa. The authors, like two authors are from India and the two authors are from the Community Health and Sciences Nursing University of Western Cape. So when we talk about empathy, empathy is an important professional value to be possessed by nurses. Empathy is to imagine oneself in another's shoes. To be empathetic, one should be an attentive listener, see things from others' point of view and share who you are, validate other concerns and feelings, and be genuinely curious about others.
I think slide is not visible.
Not visible, ma'am.
The slide is not visible.
Okay. Can I continue or should I wait?
Ma'am, your PPTs are not visible for us.
It's visible, sir?
No, not at all.
Not at all. Yeah.
1 second. There's some network issues here, so I'm trying from right 1 o'clock.
I was thinking that network issues are in India only.
Can I continue, sir? It's not loading.
Okay.
Yes, continue, please, continue. Continue.
Okay. So empathy is the ability to understand and share the feelings of others. It is an action of understanding, being aware of, being sensitive to, and vicariously experiencing the feelings, thoughts, and experiences of another. Empathetic involvement is an essential ingredient in forming therapeutic nurse-patient relationship, which would lead to more optimal patient care. The present study aimed to assess empathy among nursing students at 2 universities of different continents. To come to the operational definition, empathy can be defined as the ability to understand are you able to see my screen now?
No, ma'am.
Okay. So empathy can be defined as the ability to understand and view the world from others' point of view. In this study, empathy is measured through the Jefferson's empathy scale, which include measurement of standing in patient shoes, compassionate care, and perspective taking. Permission to be sought from the permission has been sought from the author to use the scale. And in this study, students refers to the undergraduate students of both the universities who are pursuing their BSc nursing. In the methodology, quantitative approach was used with the descriptive survey design. Convenient sampling technique was used for the participants and voluntary participation was encouraged. Sample size, 377 students from India and 245 samples from South Africa were recruited. Empathy was the research variable and demographic variables were age, gender, religion, and marital status. Demographic proforma and Jefferson's empathy scale was used to collect the data. And the study was carried out at Enapoya Dimtobi University, India, and the University of Western Cape, South Africa. All-inclusive sampling technique was used, and students, those who were not willing to participate, were excluded from the study. The demographic proforma was peer validated, and pre-testing was done for the Jefferson's empathy scale, and the reliability of Jefferson's empathy scale was 0.7, but the researcher also calculated the reliability in Indian setting, which was found to be 0.89. Hence, the tool was found reliable. Data collection procedure, ethical clearance was obtained from the Institutional Ethics Committee. Formal permission obtained from the concerned authority. Informed consent was taken from the participants and data was collected using Google Form. The study result showed that the mean age of students in India, it was 19.70 plus or minus 1.19, whereas University of Western Cape, the mean value was 22.17. The other parameters were the gender, year of study, all the 4 years were included, and the marital status.
Hello.
That is,
Hello, ma'am. I'm calling from the nursing conference, ma'am.
yes. What we can see is the test of significance, chi-square test was applied, and it was seen both the groups were homogeneous except for the marital status. Then ethnicity of South African students were studied, and it was seen majority were from black, then 34% were colored, whereas in Indian students, the religion was studied, where it was seen that majority of the students were Christians. Majority of the students were Christians. Then comparison of empathy scores of students of South Africa with the socio-demographic variables, it was seen that gender, year of study, and ethnicity, okay, all these socio-demographic variables or the parameters, the groups were similar and they were showing high empathy scores. But compared to Indian students, South African students' empathy was better, where they showed the moderate empathy, that is 71 to 105 in the scores. The maximum score of the empathy score was 140. So it was seen that the students from the South Africa, they had a better empathy scores. And T-test was used to compare the empathy between the students of both the continents, and it was found that there is a significant difference in the empathy score of both the students at p less than 0.05. So it is said that both the university students had higher empathy scores, but the students from University of Western Cape, they showed higher empathy scores than the Indian students. In the discussion part, previous studies have shown that nursing interns have a better empathy than the other students, and as the age advances, the student shows better empathy level. Compared to males, female students exhibited better empathy. And these findings were consistent with the findings where the previous studies have found that, mean scores of empathy of females were better than the male students. The limitations of the study, the major limitations of the study is only one institution from each country is taken for the study. And sample size also is not equal from both of the institutions. There is a scope for future work. The similar study can be conducted on a large scale between the institutions. Government and private sector students can be compared. Similar study can be conducted on nurses between the institutions, government and private sectors, and their results can be compared. This study has an implication to nursing, especially the nurse educators can study the empathy of different grade students and help them to inculcate this professional values among the students. And in conclusion, the study explored empathy level among nursing students at 2 universities, and we found that a higher empathy level among participants of both the universities, but students from Western Cape had better or higher level of empathy, and female students were empathetic over the males. Use of continuous reflection and regular educational activities could help the students to develop empathy during their study period, which will help them to be an empathetic nurse in future. So thank you. This is for about my presentation. I'm very sorry that I couldn't display the slides. I'm ready for any questions.
Thank you, ma'am. Section chairs, do you have any questions?
Yeah, Priya ma'am.
Yes, sir.
Okay, your study was basically good because it is in these days empathy is an initial part of the nursing care when we are dealing with the patients.
Yes.
So the question is that what method you have been adopted for the sample selection?
It was total enumerative sampling technique. That means the BSc nursing students of both the universities were open to participate in the study, but the participation was voluntary. So the Google questionnaire were mailed to them, and then only a few students participated. So based on the statistics, what we need, we got the study participant number. So what we can call is total enumerative sampling technique, we can say. But
So
the
how you
inclusion
maintain then how you maintain the homogeneity of your samples?
homogeneity I have calculated, sir. I couldn't present my slide. So the tests were used to calculate the homogeneity, and both the groups were found to be homogeneous, except for the their marital status. Others, their age was homogeneous, the year of study was homogeneous, and also their gender was homogeneous.
Basically, the issues are coming when you will compare with the pattern of the African countries and the Indian countries of their curriculum. It is little bit differ.
Yes,
Uh,
but the
so
basic nursing foundation remains the same. So we had a collaboration with those researchers, and based on this, our discussions, we were interested to study regarding this professional values. So we didn't find much difference in the professional values, though the African students had, better empathy than Indians. Both India and African students showed the higher empathy scores only on the Jefferson's empathy scale. So we cannot say that, in India it is less or in Africa it is more. It was like higher side for both the institutions.
okay, thank you.
Thank you, ma'am. The next participant is Suganti Rajesh. Suganti Rajesh. Okay. Heaven Tagya. Heaven.
Yes, ma'am. Very good afternoon.
Good afternoon. You can share your screen and start the presentation.
Okay, ma'am.
Heaven. Heaven. Heaven.
Yes, ma'am.
Are you sharing the screen?
Ma'am, I'm sharing the screen, but can you share the PPT I have sent to you, ma'am?
Yeah.
I think I have some connectivity issue.
Heaven,
Yes, ma'am.
I have shared you the screen. You can start your presentation. Heaven, is my screen is visible?
Yes, visible.
Okay. Then you can start your presentation.
But ma'am, I'm not able to see anything on my screen. Sorry.
Heaven, I have shared the screen.
Okay.
Is my screen
Yes, ma'am.
visible?
Now I can.
Can you able to see my screen?
No, ma'am.
Section chess. Is my screen is visible?
Your screen is
No, ma'am.
visible. Is visible. Screen is visible means research, not PPTs. PPTs is not there.
It's just a single page, ma'am.
This is only the single page is there. Okay.
Yeah. Yes. Can I start?
Yes.
A very good afternoon to all the dignitaries. Today, my topic for the presentation is study assess the knowledge level of adolescent girls regarding anemia and its prevention. Selected community area of Mehrauli, Delhi. I conducted this study the collaboration of my coordinator, Mrs. Kamal Priya ma'am. She is participating at the College of Nursing. So, anemia, it is one of the major health concern among the adolescent girls.
Heaven. Ma'am. Section shares, am I audible?
Yes, audible, but screen is not visible now.
Ma'am, she left. No. Heaven, are you there?
Yes, ma'am.
Heaven, you can present your topic.
Ma'am, I was already presenting.
Okay, but
with this network issue.
Okay, carry on. Thank you.
The findings of the study indicated that close to 47% of the girls were having knowledge regarding the anemia and its prevention. also, there were no association between the selected demographic variables and the knowledge score of the girls. So for the future, more samples can be taken.
Niveda, I think it is a connectivity issue. So kindly.
Yes, ma'am.
I think it's connectivity issue.
Yes, ma'am. Heaven. Okay, I will go. Heaven, your voice is not audible. I hope we have some connectivity.
Is it audible now? Hello?
Yes, Heaven.
Am I audible?
Yes, yes.
Okay, so the topic of my study was to
Heaven, you are not audible right now. Heaven, I hope there is a connectivity issues. And the time is also very limited, so I go with the next presenter. Suganti Rajesh, are you there? Suganti Rajesh. Sunil Kumar. Sunil Kumar. Okay. Ma'am, now I'm going with the video presentation of Dr. Shweta.
Yes, please.
Good evening, myself. Dr. Shweta Javle, Assistant Professor, Department of OBG Nursing. Background of the study: uncertain gestational age is associated with the higher perinatal mortality rate and increased incidence of low birth weight and spontaneous preterm delivery. Errors in gestational age estimation can lead to iatrogenic neonatal morbidity from prematurity. Precise determination of gestational age antenatally is a boon to modern obstetrics in context with improved neonatal survival. The most effective way to date pregnancy is by sonography. Several parameters can be considered for estimation of gestational age. Transverse cerebellar diameter is one such parameter. So, title of my study is A Study to Determine the Correlation Between Transverse Cerebellar Diameter and Gestational Age Among the Pregnant Women in Second and Third Trimester. Objective of the study: first objective, to determine the correlation of TCD and gestational age with ultrasonic parameters in normal pregnancy. Second, to determine the correlation of gestational age with biparietal diameter, femur length, abdominal circumference, head circumference in IUGR pregnancy. Third objective, to evaluate correlation between gestational age and transcerebellar diameter. Research hypothesis. H1. There is a significant correlation between TCD and gestational age with ultrasonic parameter in normal pregnancy. H2. There is a significant correlation between gestational age with BPD, femur length, abdominal circumference, head circumference in IUGR pregnancy. H3. There is a significant correlation between gestational age and transcerebellar diameter. Methodology. So, research approach in my study: descriptive and evaluative research approach. Research design: correlation research design is used. Population: pregnant mother between 15 to 40 weeks of gestation. Sample: 100 women recruited into the study from routine antenatal clinic, and patient admitted in Navodaya Medical College Hospital and Research Center, Raichur. Sampling technique, convenient sampling technique. Setting of the study, Navodaya Medical College Hospital and Research Center, Raichur. Variables under the study, independent variable, gestational age, dependent variable, transcerebral diameter, biparietal diameter, femur length, abdominal circumference, head circumference in IUGR. Demographic variables are age and parity. Results of my study. Table number 1. It reveals that the patient with normal pregnancy were aged between 18 to 32 years with a mean of 21.9 with standard deviation of 3.8. The patient with IUGR pregnancy were aged between 17 to 30 years with a mean of 22.8 and standard deviation of 3.38. So there was no statistically significant difference between the two groups with respect to the age, as the p-value is 0.26. Table number 2, that is table number 2, reveals that among the 80 patients, that is frequency and percentage distribution of the IUGR pregnancy patient according to their parity. So it reveals that among 80 patients with normal pregnancy, 45 were primary gravida, 18 were gravida 2, 15 were gravida 3 and 2 were gravida 4. Among 20 patients in IUGR pregnancy, 11 were primary gravida, 5 were gravida 2, 3 were gravida 3 and 1 was gravida 4. Table number 3, that is correlation of TCD with BPD, femur length, abdominal circumference, head circumference in normal pregnancy, and table number 4, there is table number 4 shows that correlation of gestational age with the BPD, femur length, abdominal circumference and head circumference in normal pregnancy. So the regressional analysis from the table number 3 and table number 4 reveal that transcerebral diameter and gestational age was well correlated with the various ultrasonic parameters, including biparietal diameter, femur length, abdominal circumference, head circumference, and TCD with R square, that is more than 0.9, and the relationship was curvilinear, best described by the polynomial equation of the second order. Table number 5, which is a correlation that R square and p-value of gestational age with BPD, femur length, AC, head circumference in IUGR pregnancy. So it shows that in IUGR pregnancy, the gestational age was correlated to various ultrasonic parameters, including biparietal diameter, femur length, abdominal circumference, and head circumference. So the high correlation was seen between the gestational age and the other parameter, including BPD, that is R square is equal to 0.92, FL, that is femur length, R square is equal to 0.83, abdominal circumference R square is equal to 0.90, and the head circumference R square is equal to 0.95. So from the figure 1 shows that in IUGR pregnancies, the gestational age was correlated with the TCD. The correlation between gestational age and TCD was highly significant with R square is 0.85. So discussion, the transcerebral diameter, biparietal diameter, femur length, abdominal circumference and head circumference were measured in all the cases to assess the gestational age of the fetus, and an attempt was made to detect the correlation between all these parameters and gestational age. An attempt was also made to know the correlation between TCD and other parameters. In our study, we have found a good correlation between BPD and gestational age. Third trimester was more consistent, whereas it varied in the late third trimester. In the late third trimester, alteration in the shape was found due to the molding in most of the cases. Above discussion concludes about the uncertainty in the estimation of gestational age, which is further amplified in cases of fetal growth retardation, which are further hampered by lack of precise estimation of gestational age leading to difficulty in determining whether a fetus is truly growth retarded, constitutionally small for age, or appropriately grown, but with incorrect gestational age. To solve this dilemma, estimation of gestational by transcerebral diameter has been found to be much advantageous. In our study, it was seen that correlation between TCD and gestational age was 0.85 with the p-value 0.0001, which is statistically significant. These findings are similar to the study conducted by Mayer et al. In 1993 and Goyle P. et al. In 2010. So, conclusion, in our study, it was concluded that fetal biparietal diameter, femur length, abdominal circumference and head circumference measurement of the fetus in normal pregnancy were comparable with transcerebral diameter measurement between 15 to 40 weeks of gestation. Transcerebral diameter is an added advantage in causes of IUGR pregnancy as it correlates well with the gestational age as compared to other growth parameter. TCD can also be used as a single growth parameter to predict the gestational age using the various formula obtained both in normal and IUGR pregnancy. Thank you. Thank you for the opportunity given. Thank you.
So is anyone is still there to present your presentation? Sugandhi Rajesh Khanna is there. Ma'am, are you there to present your paper? Sugandhi Rajesh Khanna, are you there?
Yes, ma'am. Now I am. Yes, ma'am.
Yeah, you are audible now. Please go ahead.
Okay. Can I start the sharing of my topic, ma'am?
Yeah, please share your screen.
Okay. My presentation topic is cryotherapy. Cryotherapy the statement of the problem. A study to assess the effectiveness of cryotherapy on pain during insertion.
Ma'am, sorry to interrupt. Ma'am, screen is not visible yet.
Not visible. 1 minute, ma'am. 1 minute. Ma'am, is now it is visible?
No, ma'am, it is not visible.
Is it visible, ma'am?
Yes, ma'am, it's visible.
Oh, okay. 1 minute. The statement of the problem, a study to assess the effectiveness of cryotherapy on pain during insertion of cannula in AV fistula, that means arteriovenous fistula of hemodialysis patient admitted in dialysis unit of Government General Hospital, Karaikal. Chronic renal failure is a devastating medical and social and economical problem. For both patient and families in India, most chronic kidney disease patients reporting to tertiary care centers in India are in the final stage, where renal replacement therapy is the only option at that stage. Hemodialysis is the most frequently used renal replacement therapy, with the AV fistula being the gold standard for vascular access in hemodialysis. Because many of the peoples in end stage of renal disease won't go to the renal transplant because of economical problem. They will come to the hemodialysis only. Most of the 75% of the peoples with the chronic disorders, renal disorder, their option is a hemodialysis. Hence, they are in the stage of putting AV fistula. It's one of the very painful procedures during each and every time of hemodialysis. We have to operate that AV fistula. That is a very much painful one. Very elegant study done in one of the central Indian town of Bhopal reported that a crude incidence of end-stage renal disease is 151 per million. Need for the study, why I am selecting this study means here, because of the pain is the worst conditions for the patients. Every day they are coming with the fear of tolerating that pain. Hence, I have selected this cryotherapy is one of the coldest, simplest and comfortable measures of the interventions for nurses. That is the cryotherapy is cold applications during the time of AV fistula insertions. That gate control theory here I am applying. For that, it will reduce the pain. Nurses' first option in the patient care for the patient care is comfortable to the patients. For comfortable devices means pain, we have to relieve the pain. Once pain touches the patients, then only they will approach the health personnel. So that's we are in the first line to care the patients. We have to reduce the pain and make the patients the most comfortable positions. That's why cryotherapy is the one of the economically effective one to relieve the pain without going to the analgesics. Objectives here in this study, objectives of the study to assess the pretest level of pain during insertion of cannula in AV fistula of the hemodialysis patients, to assess the effect of cryotherapy on pain during insertion in AV fistula of hemodialysis patient, to associate the pretest level of pain score among hemodialysis patients with the selected demographic variables. Operational definitions, effectiveness, I will go, these are all the things, it will take time to read everything, every definition I am telling means I will go for the next slide. Hypothesis, there was significant difference between pre-test and post-test pain score among hemodialysis patient in study group. Hypothesis 2, there was significant association of pre-test pain scores among hemodialysis patients with selected demographic variables. Research designs here I am selecting is pre-experimental design, that is quasi-experimental designs, and setting of the study in Government General Hospital. Usually in that designs 2 cycles. First cycles that is a pre-test assessment of the pain. And second cycles, I am giving the cold applications, that is the cryotherapy. And third cycle is after cryotherapy, I am assessing the patients about the pain, post-test pain score. And population, hemodialysis patients, sample person with AV fistula for hemodialysis. And the sample size is 40. Sampling technique is purposive sampling. And methodology, variables here, dependent variable, pain during insertion of cannula in AV fistula. Independent variable, effectiveness of cryotherapy on pain during insertion of cannula in AV fistula. Inclusion criteria, adult patients from 21 years on hemodialysis attending in dialysis unit, patients who are alert, conscious and cooperative, patients with atrial venous fistula on the forearm of hand, patient not having any other pain related to other pathological conditions. And exclusion criteria, patients with the systemic diseases, patients requiring more than one attempt for fistula puncturing, patients with the temporary access. Procedures. The first, already I told, cryotherapy is the application of cold applications to the local area. Here, how I am applying means with the help of gloves, I am putting, that is the easiest way. Otherwise, comfortable devices according to our finance level we can make. But here for general hospital, this is the facilities we are having. With the help of gloved hands, we will put the ice cubes and apply in between the web of the fingers during the time of hemodialysis. I am sorry, during the time of insertion of AV cannula. Here, the procedures I am selecting is refers to the local or general use of low temperature in medical therapy. It is having physiological effect like a painkiller, anti-inflammatory, muscle relaxation. In this study, it refers to cold applications, that is applying ice pack wrapped with gas piece on the web between thumb and index finger of the hand, not having the AV fistula. That is the contralateral arm. The procedures will be started 10 minutes before venipuncture and continued for 10 minutes. And the mechanism is based on gate control theory and acupressure point. Numerical scale. I am taking this numerical rating scale for measuring the pain level. Descriptive statistics, the responses were analyzed through descriptive statistics, mean standard deviation, frequency percentage, and inferential statistic, t-test and chi-square value, with regard to effectiveness of cryotherapy on level of pain during AV fistula puncture. The obtained t-value was highly significant at a p-value less than 0.00 level. Based on the research approach, hemodialysis patients were assessed with the pain level during puncture of AV fistula without giving cryotherapy intervention on first day. The study finding revealed that 14 people, that means 35 persons had mild pain, 22 persons had moderate pain, and 4 persons had severe pain. The same patients next day, cryotherapy was given and analyzed the finding. The study results revealed that in the study group, the mean pre-test was 4.55 and the mean post-test was 1.68. The mean difference between pre-test and post-test was 2.87. The standard deviation value for pre-test was 1.709 and the standard deviation for post-test value was 0.997. The t-value within the group was 12.079 and the p-value was 0.0, which was highly significant at a p less than 0.001 level. Hence, the stated hypothesis 1 accepted. There was significant difference between pre-test and post-test pain score among hemodialysis patients in identified group. The study results revealed that there was no significant association between level of pain during AV fistula vein puncture among patients undergoing hemodialysis and selected demographic variables such as age, gender, occupations, income, residential area, duration of illness, frequency of dialysis, type of vascular access, and duration of presence of AV fistula. Regarding the clinical variables of personal habits such as smoking, alcoholism, like that, the result shows that there was significant association occurred between pre-test level pain score. Hence, the stated hypothesis 2 was not accepted. There was no significant association between level of pain during AV fistula vein puncture among patients undergoing hemodialysis and selected demographic variable except personal habit in study group. From the experience and effectiveness of result of present study at hemodialysis unit of Government General Hospital, Karaikal, the practice of cryotherapy for reduction of AV fistula puncture pain was good and ideal in preventing addictive analgesics and the complications. And also one of the things taking drugs is really already they are in the chronic renal stage. They are taking so many drugs. Along with that, for pain they are taking, it's also very discomfortable to the patients. Hence, this kind of therapies is very beneficial to the patients during the time of this procedures, hemodialysis procedures. Cryotherapy was a best cost-effective therapy for patients in reduction of pain and promoted comfort during the treatment period. This research shows that imperative need to understand the purpose of cryotherapy technique regarding reduction of level of pain during AV fistula vein puncture among patients undergoing hemodialysis, and it will improve the quality of life, which includes stability in physiological, psychological, vocational, and lifestyle aspects. For that, cryotherapy is much better to remove pain during the time of IV cannula insertion and AV fistula for hemodialysis. Thereby, we can improve the quality of holistic life to the same extent. Implications we may apply in all the settings. Whenever the pain is the highest problem for the patients in all the settings, even in the dental case, in tooth extraction, root canal treatment, in many conditions, pain is the one of the first sign. Means we can use this kind of cryotherapy technology. Learn accurate assessment of level of pain during AV fistula vein puncture with the standard numerical pain assessment scale. Understand the importance of cryotherapy technique intervention as an adjunct to the pharmacological therapy, of course, and encourage all colleagues for use of cryotherapy intervention as a form of diversion among the clients undergoing hemodialysis. Initiate the use of cryotherapy intervention in reduction of
I'm
AV
sorry to
fistula puncture
interrupt.
related.
Your time is over, ma'am. Kindly please wrap it up.
Okay, ma'am. That's all. These are the implications only. Otherwise, nothing. Thank you, ma'am.
Thank you for the presentation, ma'am. Session chairs, you have any questions?
No, thanks. Thanks for the presentation.
Thank you, ma'am.
That's all for the presentation. So kindly we can wrap it up now. Let's give the vote of thanks. On the behalf of the 7th International Conference on Nursing Science and Healthcare, I would like to express my gratitude to our session chairs for time consideration and guidelines throughout the session. I would like to thank all the presenters for their participation in making this conference a very informative and interesting one. Coming to the certification and proceeding book part, you will receive certificate and a proceeding book link through your mail within 4 to 5 working days. Thank you, everyone. Now you can leave the meeting.